coagulopathy, even after the control of the bleeding, surgical, this does not target the endpoint of resuscitation, because most of the majority of the patient have got normal coagulation profile. Serious patient may have hypocoagulability. So life-threatening coagulopathy has been reported in shock, massive hemorrhage, and increased early transfusion requirement. That may lead to organ dysfunction. So all the patients should have coagulation studies to initiate appropriate therapy. Routinely PT, APTT, INR, and platelet is being done, but they do not target hemostatic resuscitation. But in spite of damage control resuscitation, large volume of FP aggressive use can have adverse complication. So most of the studies recommend the use of TAG integrity primitive changes that may lead to organ dysfunction. So there is 4 pathogenic changes that interact with each other. That is, whenever there is a tissue injury, leads to hemorrhage, severe hemorrhage associated with hemostatic abnormalities like loss of fibrinogen, thrombin generation, impaired platelet function, dysregulated fibrinolysis. All these changes can lead to acid-base disturbances and also the hypothermia. So that prolonged hypoperfusion reduces oxygen depth. That is related to duration and depth of hypoperfusion. So it can lead to refractory shock as well. So adequate resuscitation is a challenge in the ICU. Over-resuscitation, under-resuscitation have got adverse consequences. So full restoration is not required for only for arresting bleeding or maintain hemodynamic, but to re-establish microcirculatory flow. And organ hemostasis basically repay oxygen depth, and otherwise organ dysfunction is going to occur. In this graph, it shows a normal after the hemorrhage, the patient develop oxygen deficit. If it is being replaced, then a full recovery is possible. Otherwise, oxygen deficit may lead to delayed recovery with oxygen deficit. And if it persists, then it can lead to refractory shock and lethal cells injury and excessive oxygen depth. The endpoint for resuscitation includes microcirculatory and macro. The macro can be monitored by temperature, acidosis, urine output, and oxygen delivery by cardiac output, preload, contractility, afterload, oxygen capacity, and saturation. Now, after hemostasis is being attained, then one should focus on microcirculatory stability, because the concerns are of endothelial dysfunction, impaired RBC, addition of RBC and WBC to endothelium. So in ICU, usually patient is provided with anesthesia and sedated, and that is expected to constrict the blood vessels, dilate blood vessels, and improve microvascular perfusion, and maintain the systolic BP more than 100, heart rate less than 100, and normal urine output. Normalization of ABG is very important. Time ho gaya. Achha, pH, lactate, base deficit suggests restoration of microcirculatory perfusion. So lethal triad should be corrected. That includes hypothermia, coagulopathy, acidosis. But the goal can be changed in patient with comorbid and CNS injury. So effective resuscitation is being assumed when normalization of lactate, base deficit, pH, organ failure, central venous oxygen consumption. Patient would have got a persistent base deficit and lactate level indicate occult hyperperfusion, and it has got a poor outcome. So lactate is a better than for occult hyperperfusion than base deficit, because serial lactate level should be done in critically ill patients. If hemostasis is achieved early, definitely it will limit the shock, underlying organ dysfunction, improved response can be, resuscitation can be observed. Patient with prolonged can result in an organ dysfunction. So for the interventions, whether it is surgical or coagulopathy, Aggressive transfusion, if it is going in a patient, it indicates either there is a surgical bleed or irreversible shock or hepatic dysfunction. To limit transfusion, one should consider surgical cause, angiography reevaluation, and to find out occult injuries and to discuss with the surgeon. Blood product has got itself adverse effect. This was a case report in which they say that doing less is better. But even there is a school of thought that under-recitation can result in occult or crepitic shock, and state of compensated shock can predispose to organ dysfunction in the ICU. So fluid suction also affect upon microcirculatory perfusion, goal of resuscitation after hemostasis, and independent of volume expansion or oxygen capacities. Some studies recommend Hestrel, hypertonic, 7% saline, dextron have got a greater benefit than the crystalloid, but microcirculation is benefited by relative small initial bolus. Small volume resuscitation, pre-hospital, early stage of resuscitation is adjunct to hypotensive resuscitation. So to determine whether the patient is going to survive or not, if the patient is not responding to resuscitation, it indicates either patient has got occult injury or misinjury or ongoing hemorrhage or irreversible shock. Undiagnosed injury search by radiography, angiography, sonography, and operative re-exploration. Acidosis, hypothermia again become refractory to aggressive measure which can be taken. And irreversible shock should be identified. If there is unsuccessful, repeated, persistent effort to resuscitate the patient, then futility is an issue to discontinue further resuscitative effort. This is a report in which they recommend current concept evolving advancements in technology like aortic occlusion aorta for maintain the systolic blood pressure, use injury severity score to determine timing of intervention, and also use thromboelastography for coagulopathy. This is what happens, the complications, because ICU management provide organ protective support. Aggressive resuscitation can itself lead to the hemorrhage and septic shock. Complication of transfusion therapy includes TRALI, ARDS, and TACU, that is transfusion-related overload, and TRIM also immunomodulation. Hypothermia is one of the problems that can occur in the ICU, and it can lead to coagulopathy, acidosis, dysarrhythmia, and infection. Renal damage, rhabdomyolysis with the polytrauma patient can occur, hyperkalemia, hypocalcemia, adrenal insufficiency, hyperglycemia, and if abdominal is involved, hypertension, abdominal compartment syndrome can develop. So to summarize, polytrauma patient with severe shock from hemorrhage and massive tissue injury present a major challenges for management of resuscitation in ICU. ICU intensivists must be prepared to receive patient in varying degree of stability and be ready to take over and complete resuscitation process. In some cases, fine tuning may be all that is required before addressing long-term critical care needs. In others, intensive must be prepared to undertake immediate massive resuscitation, correction of severe physiological derangement if the patient survives first 24-hour admission. How well the intensivist can prepare to meet these challenges may be critical, affect 24-hour survival after severe injury, and also development of potential life-threatening complications. As a patient becomes more fully stable, the ICU intensivist can then transition priorities towards longer range management issues. The past decades has been seen the radical changes in approaches in resuscitation from hemorrhage and polytrauma. These changes have drastically influenced how resuscitation is carried out in ER, OR, or in ICU. Future development will improve our understanding of microcirculation and interaction between hemostasis, inflammation, endothelium, and influence how we manage these complex and challenging patients. This is the data which is being collected from Shaheed Mohtarma Benazir Bhutto Institute of Trauma from January to November 22. Total we have got admission about 1300 to 39, and they were being admitted in ICU were 66 and in ICU were 33%. In the mortality was 22% and ICU it was 31 and NICU it was 0.6. And these are all the polytrauma patients. Thank you.
Thank you very much. Let me rewind that first bell is on 12 minutes, second bell is on 15 minutes, and you have maximum time of 18 minutes. So you completed your presentation well in time. Thank you very much.
Thank you.
Thank you, ma'am, for your presentation. I hope you liked the presentation and have taken some notes for the end. Our next topic is tetanus and its ICU management. The speaker of this topic is Professor Dr. Safia Zafar Siddiqui. Dr. Safia Zafar Siddiqui graduated in 1986 from People's Medical College, Nawab Shah. She passed MCPS in 1990 and FCPS in 2002. She also did MSc Pen Medicine in 2009. She is currently working as Head of the Department of Anesthesiology in Dow University of Health Sciences, Karachi. She is also examiner of MCPS, FCPS and Pen Medicine examinations. During last 5 years, around 55 anesthesiologists are qualified from her department. First Pen Management Clinic in Sindh by the government of Sindh was established because of her special interest and dedication. Please welcome Dr. Safia Zafar Siddiqui on stage. एक्सटेंड कर दिया
ये टाइम मेरा नहीं है. Thank you. Thank you, organizing committee, for inviting me here. I will try to finish in time. In the next few minutes, we will discuss tetanus. Is everybody knows it is characterized by muscle spasm that is caused by tetanus toxin produced by Clostridium tetani, and in the last many years, the tetanus and the relationship of traumatic injury were well known ongoing in ancient Greek and Egyptian time, and it is in 1940s, and it is called at that time it is called as lockjaw syndrome. World Health Organization has done lots and lots of work on it, and because it is not a Western country disease, so इसमें बहुत कुछ नया नहीं है जो आगे आप सुनेंगे, तो वही चीज़ें, क्योंकि this is the problem of poor country जहाँ वैक्सीनेशन नहीं होती है ठीक से, that is why. Global burden इसका बहुत ज़्यादा है, that is estimated 48,000 to 80,000 deaths occurred in tetanus worldwide in 2016. That is why it is important to know about something about tetanus. It is caused by Clostridium tetani. Spores are incompetently destroyed by boiling and eliminated by autoclaving 1 atmosphere. And this is the clinical condition. This is the clinical condition in which Clostridium tetani produce toxins, and you can see the body of the patient. It is because of the severe skeletal muscle spasm. The predisposing factors are penetrating injury or co-infection with other bacteria, revitalizing tissue, and foreign body localized ischemia occur because of these toxins. And other things are splinters in other puncture wounds, gunshot injury, compound fracture, burns, and other utensils. Tetanus in unusual settings, like in neonates due to infection in umbilical stems, in obstetrics patients due to aseptic abortions, and these things are occurred in low resource countries. And post-surgical tetanus occur in adolescents after circumcision in dirty places, and patient with dental infections, diabetic patient with infected extremities ulcers, patient with dirty syringes. And then we should know little about the pathophysiology of the disease. It is because of the release of two enzymes, that is tetanospasmin and tetanolysin. Tetanolysin is capable of locally damage viable tissue surrounding the infection and optimizing condition for bacterial multiplication. And tetanospasmin will lead to all clinical syndromes. That is the clinical feature of the disease. And when it is toxin load is high, it enters in bloodstream and go to central nervous system and causes other symptoms. I will skip it for as the time is not. Tetanus toxoid vaccination in pregnant women. This is a study done in Bhavalpur, in which they see that the neonatal tetanus is a serious disease in newborn baby and high mortality rate associated with it. In 2008, the estimated 59,000 newborn died because of the tetanus. This is neonatal tetanus. They said that there are 5 major factors for neonatal tetanus, that is because of unclean delivery practices, access to the awareness about tetanus, and inadequate coverage of tetanus toxoid vaccination, particularly TT5, and lack of herd immunity and database नहीं था इनके पास. These things are important to know about tetanus. तो prophylaxis में होता क्या है कि immunization after delivery there are 3 set of immunization with the name of DPT, 2 months, 4 months, 6 months, and then after every 10 years. Lifelong होनी चाहिए ये after every 10 years. The clinical patterns are there are 4 types of usually generalized, local, cephalic, and neonatal. And incubation period is 8 days but ranges from 3 to 21 days. If it occurs just after injury, it will be serious mostly. And if it occurs after 20 days or 25 days, it will be milder form. The most common and severe is generalized tetanus, and in ICU care, mostly the generalized tetanus comes to the ICU. The clinical feature in these patients are manifest early phase of sweating and tachycardia because of the autonomic instability, and in later phase, illness, profuse sweating, cardiac arrhythmias, labile hypertension, and fever are most often. Patients with tetanus characteristically have tonic contraction of the skeletal muscle and intermittent intense muscular spasm, and it is very painful. These patients needs good analgesia in the form of opioid and non-opioid. and these things are triggered by loud noises and touch, light. So we should be careful with these patients. Tonic and periodic spastic muscular contractions are responsible for most classical findings of tetanus, that is stiff neck, opisthotonus, rhizus sardinus, and board-like rigidity, and these things. So they classify these forms of tetanus into 4 forms. That is called ablet, mild, moderate, severe, and very severe. In ICU, mostly the severe and very severe patients are admitted in ICU, and they have severe trismus, generalized spasticity, prolonged spasm, respiratory rate more than 40, dysphagia, apneic spells, and pulse more than 120. And these patients should be admitted in ICU care. And this is the patient admitted right now in my ICU. He was admitted with the very little mouth opening, 1 finger. And this is better condition, and now he is much better, Allah ka shukar hai. And abdomen was rigid. Drug-induced dystonia, differential diagnosis is must to exclude, क्योंकि लेबल अगर लग जाता है कि टेटनस का पेशेंट एडमिट हो रहा है और सब उसको टेटनस की तरह ट्रीट करने लगे, it should not be the criteria. You should go by differential diagnosis, and the diagnosis of tetanus is purely clinical. Management. Treatment strategies involve three management principles. Organism present in the body should be destroyed to prevent further toxin release. It should be done by debridement of the wound. अगर wound नहीं मिल रहा है तो you should find, उसको पीछे देखें, आगे देखें, कहीं ना कहीं पे कोई wound मिल जाता है और उसको ढूंढना पड़ता है, और जब मिले तो उसकी debridement is must. Toxin present in the body outside the CNS should be neutralized. The effect of toxin already in the CNS should be minimized. तो इसमें फिर करते क्या है कि ह्यूमन टेटनस इम्यूनोग्लोबुलिन is the antitoxin choice of neutralized unbound toxin, and the United States Centers the Disease Control and Prevention recommends single dose 500 units of intramuscular. इससे पहले previously the dose was 3,000 to 6,000 units, and this globulin should be administered as soon as the diagnosis of tetanus is considered, with the part of dose infiltrated around the wound. Active immunization is must in these patients. When the diagnosis is must, you should do this active immunization. The other things which should control the clinical condition of the patients are benzodiazepines. The diazepam is the drug of choice, or Valium is the drug of choice, and it is used most frequently in ICU and outside ICU. If patient is in the ward, they are using it. Starting the dose of diazepam with 10 to 30 milligram and repeated as needed after every 1 to 4 hours. But you should be careful to see the level of sedation, level of airway reflexes. It should all be considered important. And continuous infusion of IV midazolam is also important, and we are using it very frequently. The other thing is to block adrenergic autonomic response is the magnesium sulfate, and it is the gold standard drug. I think everybody is using it for the tetanus. And it has been studied in a randomized controlled trial in tetanus because it is used clinical series of management of autonomic dysfunction and adjunctive treatment for the controlling spasm. Why it is important? That it acts as presynaptic neuromuscular blocker, blocks catecholamine release from nerves, reduce receptor responsiveness to catecholamines, and it has advantage of worldwide experience in the treatment of eclampsia. So everybody knows about magnesium sulfate, and it is a very safe drug if you are using carefully, and the level of magnesium sulfate should not cross the therapeutic level. Otherwise the toxicity of magnesium sulfate will occur and it will complicate the patient. The randomized double-blind trial of 256 hospitalized patients with severe tetanus in Vietnam, magnesium sulfate infusion compared with placebo-controlled autonomic dysfunction. The patient were randomly assigned. Other thing is beta blocker and opioids. Labetalol. Sometimes it is important to give labetalol, has frequently been administered in these patients if it is required. And beta blocker alone with propranolol, for example, should be avoided because it causes sudden death of the patient. For pain, morphine is very helpful drug, very important drug, because the muscle spasm is so intense, so painful, so morphine is not available. सब लोग ये बोलेंगे. So the other thing is weak opioids, that is nalbuphine. We are using nalbuphine in this patient with paracetamol or with some other NSAIDs to reduce the pain of the patient. Next is baclofen. Baclofen IV is not available in Pakistan, and it is used IV and intrathecal use, and it is available in the tablet form in Pakistan, 20 milligram and 10 milligram tablets. And this study shows that they are using it intrathecally. They reduce the symptoms, but on mortality it is not very helpful. Sometimes it is not recommended, but sometimes we have to use this neuromuscular blocking agent to reduce the spasm for some time if it is very severe and we cannot control it. For the time being, जब तक मैग्नीशियम का लेवल मेंटेन कर रहे हैं, we can use these drugs. Other thing is the study occurred in Brazil. इसमें इन्होंने यूज़ किया इंट्राथीकल इम्यूनोग्लोबुलिन्स, लेकिन इसमें भी इन्होंने कहा कि मॉर्टेलिटी वाज नॉट सिग्निफिकेंटली अफेक्टेड, लेकिन सिम्टम्स इन्होंने कंट्रोल कर लिए थे इससे. इसमें अब इस पूरे को नटशेल में किस तरह हम कहेंगे कि स्टार्ट मेट्रोनाइडाजोल intravenously 500 milligram 3 times a day to control anaerobic situation. Give tetanus human immunoglobulin 3000 to 6000 unit, but now it is recommended that 500 intramuscular should be given. Admit to ICU, commence oxygen, obtain IV access and attach monitoring. Alert surgeon to perform radical debridement, and it is very important. Very much, you have to remove the focus. Slow loading of diazepam, and start diazepam 10 milligram 6 hourly, increase to hourly if required. Titrate symptom. Start magnesium sulfate. तो पहला काम ये साथ साथ कर देना चाहिए. Start magnesium sulfate. Magnesium sulfate can depress heart, so you should be very careful. Give it slowly, as recommended in books. Phenobarbital is another drug, and sometimes tracheostomy is required. If patient is on ventilator and on prolonged ventilator, tracheostomy is required to wean smoothly, easily from ventilator. Intermittent positive pressure ventilation is required sometime by giving neuromuscular blocking agent. General care, the hydration is must. पानी नहीं पी सकते, तो you have to give fluid as recommended 10 ml 15 ml per kg per hour. Nutrition is must. अगर ये मैंने खुद देखा है, हमारे पास पेशेंट देखते देखते छोटे हो जाते हैं, पतले हो जाते हैं, तो न्यूट्रिशन इज मस्ट. इलेक्ट्रोलाइट बैलेंस, डीवीटी प्रोफाइलेक्सिस, ट्रेकोस्टमी केयर एंड जनरल नर्सिंग केयर, ऑल दिस थिंग्स आर इंपॉर्टेंट. बस ख़त्म कर रहे हैं. कॉम्प्लिकेशन में अगर with the disease laryngospasm and hypoxia, complication of treatment, sedation leading to coma, aspiration, apnea, ventilator associated pneumonia, acute respiratory distress syndrome, gastric ulcer, these things happen in ICU, which is common. Bradycardia, tachycardia because of autonomic instability and magnesium sulfate, high output renal failure. Tetanus is entirely preventable by vaccination. However, it remains a major health problem worldwide, especially in poor countries. In developed countries, severe grade present in elderly and unimmunized patients. Mortality is high in these patients remains high. Prolonged intensive care support may be necessary, but most treatment is based on limited resources. Major therapeutic challenges lie in control of muscular rigidity, spasm treatment and autonomic disturbance, and the prevention of complication associated with prolonged critical illness. For the developing countries, tetanus is major challenges with high mortality among all age group. The use of magnesium sulfate to avoid long-term ventilation is hopeful development and will need to further evaluation. Thank you.
Thank you so much, ma'am, for your time. Our next presentation is Fluid Stewardship in Sepsis and will be presented by Dr. Syed Farjad Sultan. Dr. Farjad Sultan is consultant anesthesia at Dow University of Health Sciences and currently heading the anesthesia services of university. After MBBS from Dow Medical College in 2002, he completed his fellowship training in Ireland from College of Anaesthetists Ireland in 2009. He got his CSST in 2013. He also has a fellowship in ultrasound-guided peripheral nerve blockade from Cork University Hospital in 2010 and in critical care in 2013. He did not stop there. He was also awarded a PhD in anesthesia and intensive care in 2015 from University College Cork of National University, Ireland. Please give a warm welcome to Dr. Syed Farjad Sultan.
शुरू तो नहीं किया है ना? टाइमर शुरू हो गया है क्या? अच्छा, बस फिर ठीक है. Right. Assalamu alaikum. Thank you very much. First of all, I'd like to thank the organizers for inviting me to give this talk. So it's fluid stewardship in sepsis. We can use it in sepsis or otherwise. We had a very nice presentation yesterday on burns, but it's a sort of different, it's a paradigm shift, and this is something that we all need to think about. We've all heard of antibiotic stewardship. It's time we started thinking about fluids. So no conflict of interest. Why is fluid stewardship important? Well, we need to define what is fluid overload. One, there is no universally accepted definition. It does not exist. The most acceptable one is an expansion of extracellular fluid volume with a positive fluid balance that produces a weight gain of greater than 10% from baseline. That's the most accepted one, but how many of us actually know our patient's baseline and how much is the weight gain? When do we start the baseline is a separate question. What are the problems? We can see from that it happens in every single system that exists in the body. Then the complication, where it increases mortality, it increases the length of stay, it causes acute kidney injury and everything else. Why does it happen and how does it happen? With the four mechanisms it happens. One is aggressive fluid resuscitation. So the sepsis 1 bundle, I'm just going to take an example, for patients with sepsis and hypertension suggest 30 ml per kg in the first hour. Well, if you have a 120 kg patient coming in, that's 3,600 ml in the first hour. Really? Who gives that much fluid in the first hour? That's a huge amount of fluid without knowing the condition of the patient's heart, lungs, and all that. So the outcomes per ideal, adjusted, or total body weight have not been evaluated. Hence, recommendations cannot be made. But it has been suggested in practice, precision-based resuscitation using small boluses and dynamic assessment of fluid responses may be beneficial. That's the maximum that they have said. They cannot give any firm, fixed, fast rule that this is what you do. And approximately half of the patient administered fluid challenges will be fluid responsive. And this is, again, a huge statement, and it is quite well published, that despite extensive evidence and guidelines to support dynamic indices to predict fluid responsiveness, static measures are still commonly used. And we all know that. So there is a lack of knowledge as well. Again, we need to understand all measures have limitations. We don't have the perfect measure for anything. But the lack of dynamic indices may contribute to the overload as well. Then we have the hidden fluids, which are the requisite fluids administered as part of routine care. These are fluids which are not prescribed, but giving a bit of flush, a bit of diluent for IV fluids, these are unmeasured. So if you look at it, it's a huge load. We have the persistent use of maintenance fluid. There was a study, point prevalence study of 49 ICUs in Europe and America, and they found 62% of ICU patients received maintenance fluid despite over 80% receiving full nutrition. So someone is getting full nutrition and they're getting maintenance fluid as well. It's just too much fluid. So what to do about it? So there has been this huge debate of who is responsible for it. Is it the doctors? Is it the paramedics? Ground reality is all of us are responsible for it. But practically, we are not there with the patients 24/7. Who are there with the patients? These are the paramedics. So the thought process has changed. We need to teach things. We need to learn things so that it makes things easier for the paramedics to look after the patients, something that they know how to do. So this is what they have suggested. This is what is taught to all paramedics for patient care, for pharmacy, and this is the concept from there. The 4 rights, the 4 R's, the right patient, the right drug, the right route, and the right dose. This was previously the 4 Ds of fluid therapy: the drug, dose, duration, de-escalation, but they suggested the 4 Rs as a change towards patient care. The 4 Ds we do as doctors, but as doctors, ground reality is we go, we prescribe, we walk away to the next patient. Who is looking after the patient? The paramedical staff. So we need to modify our thought process to make it easier for them to understand. So what is the right patient? Is it the right patient for fluid resuscitation or the right patient for maintenance fluid? They've also suggested the ROSE model, which is rescue, optimization, stabilization, and evacuation. The rescue is the first critical minutes of life-saving support. That is where we come in as doctors. Optimization is guided by the dynamic indices to fine-tune the therapy. This is where we come in. And this is generally combined in resuscitation. So this is the right patient for fluid resuscitation. For the right patient for maintenance fluid, stabilization, and evacuation, which happens over days and weeks. So this is where the paramedical staff comes in. So we need to divide the care as per time. It makes life easier for us, for the paramedical staff, and it saves lives. It's being very practical. The right drug, the patient-specific factors, and the phase of fluid resuscitation will dictate the fluid choice. What is the optimal resuscitation fluid? Which will provide immediate and sustained increase in intravascular volume aimed at improving stroke volume, cardiac output, and blood pressure. Well, it does not exist. We all know that. There's a huge problem. The principles of fluid composition are governed by the osmotic pressure, which is total solutes per unit volume. So hypertonic, isotonic, or hypotonic. The oncotic pressure, which is the osmotic pressure exerted by proteins in the intravascular space. This will shift volume from extravascular into intravascular, and the acid-base balance. So as a general rule, if strong ion difference, cation or anion of infusion fluid is greater than the baseline bicarb, the pH will tend to move towards alkalosis and vice versa. Bit complicated to think through, but it is as a general rule. So colloids, starches, crystalloids have all been extensively studied. Normal saline 0.9% is the most commonly used fluid despite its negative effects. It causes hypochloremic metabolic acidosis. GI intestinal edema, it causes ileus, renal vasoconstriction, AKI, increases the need of RRT. It increases intraoperative blood loss. It causes postoperative complication. It has been known to increase mortality. Despite all that, it is available. It is written down in every resuscitation fluid. The reason is it is easily available, relatively easy to produce and store. Ground reality. Maintenance fluid are the core component of support care. Most recommendation regarding fluid choice are opinion-based. Everybody has their own opinion, so you can't give a firm fixed guidelines. Hypotonic solutions cause hyponatremia and significant adverse events. Despite that, we all know that it is still prescribed, and hence evidence-based guidelines are quite lacking. Then we have the right route. Should we give it enteral or parenteral? For enteral resuscitation, only animal models are available. I mean, if you think about it, no one is going to go to the IRB saying this patient has an acute abdomen, has an ileus. Instead of giving IV fluid, I want to randomize and give them fluid via the NG. Or someone who has a gunshot wound anywhere, we want to see how the gut absorbs. We're not going to get the IRB approval at all. The enteral route preferentially fills the interstitial compartment before the IV compartment. The hidden fluids, it's an early conversion of IV antibiotics to oral or enteral route, if appropriate, and we need to measure all the ins and outs. Regarding the right dose, we need to develop, individualize, even though hospitals, protocolized assessment and management of fluid requirement. All things are poison, and nothing is without poison. Only the dose permits something not to be poisonous. This was said by Paracelsus, and I think it was 200 BC, or maybe before that. So in conclusion, the 4 major indications for fluid administration in the critically ill are resuscitation, maintenance, replacement, and nutrition. Please, please, please do not forget nutrition, enteral or parenteral. A lot of our patients are there in ICU, and sometimes we sort of, in life-saving things, nutrition takes second priority. We need to save lives first. It doesn't matter whether you use the 4Ds, 4Rs, ROSE model, just use a model. The 4 basic questions which surround fluid therapy are, and this is when we're starting or when we have a patient, is when to start fluids, when to stop fluid, when to start fluid removal, and when to stop fluid removal. So we need to start thinking on that. How do we get along with fluid stewardship? Well, it's a 3-pronged attack. We need to educate. This is why we have conferences. We need to give out the information why it is important. We need to change our own prescribing habits. We need to look at what we do. If you look at all our ICU patients, most, if not all, will be fluid overloaded. We will be overprescribing them. They will be getting more fluid than required, and we need to increase the awareness. Thank you very much. Sir, घंटी से पहले. सर, पहली घंटी हमारे ना वो 20 मिनट की होती है. Thank you.
Thank you very much, sir, for your great presentation. Our last topic of this session is post-intensive care syndrome, which will be presented by Dr. Hamidullah. Dr. Hamidullah is Associate Professor of Anesthesia and currently working in Aga Khan University, Karachi. After graduation from Dow Medical College in 1991, he completed his FCPS in Anesthesia from Aga Khan University, Karachi. He is an asset of Pakistan Society of Anesthesiologists. He is also a member of Pakistan Medical Commission and Association of Anesthetists of Great Britain and Ireland. He received Best Teacher Award in Aga Khan University in 2011 and Faculty Development Award in 2004. Please welcome on stage Dr. Hamidullah. बस सर मिल जाती है.
ये पॉइंटर चल रहा है?
Yes, बिल्कुल चल रहा है.
इस पे आता नहीं है पॉइंटर को.
Assalamu alaikum. So I'm standing between you and the tea, so not a nice place to be. Okay, so thank you very much for giving me this opportunity. I'm always grateful to the organizers and thoroughly enjoy the Peshawar hospitality. So I'll talk about post-intensive care syndrome. I have no conflict to declare. What is an outcome? In ICU, we monitor outcomes, and outcome is only what we look for. So what we generally look for in ICU is mortality. We look for infection rates, ventilator days, organ failures and organ supports, length of stay, and so on and so forth. But if you look at all these outcomes, they begin in the intensive care unit, they end there. But the patient doesn't stop here. Patient goes back to the wards, to special cares, high dependency, then to general wards, then they go home and to the society. Let's see what happens when these patients go out. This is a graph showing pre-admission status of these patients, and they have followed them up for 72 months. And you can see most of them do not get back to the position that they were before their admission to ICU. And greater the severity of illness and greater the risk factors, the greater the number of patients not getting back to where they started. So there is something going on after we discharge them from ICU. What happens with them because of their disease process, and what we do with them as part of treatment. We do things that decrease their muscle strength. Hypoperfusion happens. We predispose them to delirium. There is altered thirst and nutrition. All of that leads to, in addition, with the hazards of bed rest and hospitalization, immobilizations, diet issues, low plasma volumes, low ventilation, social isolation, sedating mechanisms. To summarize, what happens is they develop weakness, they develop cognitive impairment, organ dysfunctions, and psychological problems. This all leads to increased mortality, inability to return to their social roles, recurrent healthcare needs even after discharge, and there is a burden on the caregivers as well. So these are the elements that happens in critical care depending on various factors, primarily the disease and the care given in intensive care. So bringing them all together, this is known as post-intensive care syndrome, which is a collection of physical, mental, and cognitive symptoms that continue to persist after the patient leaves the intensive care unit. So this is called PICS, and the portion of PICS that happens with the family and caregivers is called PICS family or PICS F. So what are the symptoms of post-intensive care syndrome? So the family suffers from mental health issues, which is anxiety, autism disorders, post-traumatic stress disorders, depression, and complicated grief. So this family issues will definitely impact the care of the patients as well. The survivors of the intensive care unit have three different types of abnormalities. One related to mental health, the second one to cognition, and the third to physical impairment. The mental health I've already discussed is the same as with the families. In cognitive impairment, they have issues with their memories, attention, and mental processing speed. So in summary, they have problems with understanding, remembering, learning, and thinking. And with regards to the physical impairment, they have primarily neuromuscular and physical function disorders, and some of them develop this to an extent that they have issues with their pulmonary functions. If we put them into perspective of percentage-wise, the highest is 16%, which is cognitive impairment alone, 13% depression, and 7% disability. This is after 12 months of discharge from ICU. And only 44% patients are free from this syndrome. There are all type of overlaps, and about 4% of patients have everything. So this is important, this is serious. What do we do to contribute to this post-intensive care syndrome? We stop following these patients. We have been deliberately doing things to reduce the incidences of delirium, to reduce the incidences of neuromuscular disorders, post-intensive care neuropathies, myopathy. But when we discharge them, we stop following them. And when they go out of intensive care unit, in most places, there's nobody to coordinate the care. The primary physician and the primary surgeons lack knowledge about this syndrome, and there are many physicians and surgeons who are looking after the patient from different perspectives. Simple decisions like starting off antipsychotics or stopping antipsychotics. We are using vasopressors in intensive care units. When they go back, the diseases are resolved, they develop hypertension again. There's a huge delay in restarting their antihypertensives. And the more importantly, the family and the home support that becomes very important in this part of rehabilitation is not as good as has been perceived in the initial stages of illness. What can we do to minimize this? We can't take this off. We can only minimize this. It's a A, B, C, D. So awaken them. Don't let them sleep for long periods of time in the intensive care unit. Let them breathe on their own, even if for short periods of time. Coordinate the care so that the families are much more involved. Always assess for delirium and do everything you can to prevent this. It's very difficult to treat the delirium. It's best to prevent this. Mobilize them. Even if they can't get out of the bed, turn them on their sides frequently. Follow them up. Involve the family in decisions and engagement. Do functional reconciliation. Post-ICU clinics are the best part that can deal with this. Develop peer support groups in the institution, which can provide them psychological support. I'm sure every institution which have intensive care would have psychologists. There has to be very good hand-off communication when you hand over your patient to another physician. And most of the lacking happens in that point, at that time. Give written information to the family. Educate them. Give them videos. Maintain ICU diaries. And create the right environment for their discharge. Not every patient needs everything. They need individualized, personalized care to become a useful member of the society. You know, if they don't become a useful member, it aggravates the situation further. What has to be done when the patients are in the hospital? First 3 months, first 12 months, after that, there are several protocols lying there. Assess their needs. Do interventions that would help them. And take it from there. This is again that ABCD. Awake and breathe, coordinate. This is the same thing. Okay. In the end, I will read the memoirs from a patient who has suffered this. This is Nancy Andrews, a creative artist. I cannot put feelings in this, but this is something that touched me. So for 3 weeks, I was held in a room. If I tried to get away, they would tie me to the bed. I couldn't eat. I could barely sleep and couldn't speak. Groups of people would come into my room and look at me and talk about me and sometimes undress me. I was shot full of drugs. I was too weak to move. I couldn't see my body, but I had been cut nearly in half. There were insects on the walls and ceiling. I was in a boat in the bottom of an underground waterway. I was in a deep well. I was tethered to the ground by rubber tubes attached to my genitals. I was in a space pod. I was in a raft, in a library, in a conference room, in a fly-by-night health clinic. I was in the Arctic. I was in the desert. They were trying to kill me. They tried to get me into a room separate from everyone else or wait so late at night. Some part of this is actually happening, and some part of this is the big hallucination bit that she's suffering from. And most of our patients do suffer. They do not express, but they do suffer. Where was I? They asked me this question every day, and I didn't know the answer. I was in the intensive care unit, the ICU of one of the best hospitals in the world, where doctors and nurses were using the most current medical technologies and knew how to save my life. Physically, what had happened to me? In the hospital, they saved my life, and for this I am deeply grateful. But life after this ICU experience was extraordinarily difficult. The memories weren't of things that had really happened there. So you can feel the pain that she's suffering from. There is no easy fix, no pill or clear drug therapy. It's a long and complex journey. And in the end, she gives some suggestions. I can continue to update my blog and web pages for those of us who need more information. and I can also share advice from my experiences. For those people like me, reach out, talk about your memories, draw, dance, do physical therapy, do talk therapy, listen to music, learn new things. Talk to your doctor, ask for help and for therapy, and for friends and family. Notice those changes in your loved ones, whether they are in the hospital and they are acting strangely. Let the staff know. When you get home, talk to somebody if they seem to have cognitive and psychological changes. And don't give up on that old person who comes home from a prolonged ICU stay showing signs of dementia. These symptoms could be reversible. This is the time to coordinate care between the cognitive, the psychological, and the physical. The sooner we get help, the better we do. Thank you very much.
Thank you, Dr. Hamidullah. With this ends our presentations. Now I would request our panel of chair for their final comments. Dr. Mehdi Hassan Mumtaz, would you like to comment on the session?
Bismillahirrahmanirrahim. Qalu subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim. All the whole papers were very good, up to the mark. But I have got some views to say a few lines about the fluid and electrolyte and fluid therapy. As we do, if we want to correct ourselves, so the formula is you correct yourself from inside out. When you plan your fluid therapy, we fill the body from inside out. Inside is the vessel. Outside to vessel is the interstitial compartment. Outside to interstitial compartment is the cell. First of all, you satisfy the vessel because the vessels are taking the nutrition and oxygen to the tissues. Then you satisfy the interstitial compartment. Then you satisfy the intercellular compartment. Basic fluid therapy. It's for the junior doctors free. Senior should ignore it but basic fluid therapy, when we plan it, we always plan 1.5 to 2 ml per kilogram per hour. And if we look at its kinetics, we produce urine 1 ml per kilogram per hour, and we are left with only 1 ml per kilogram per hour. We lose the fluid in the form of sweat or insensible loss 0.5 ml per kilogram per hour. Then we left with only 0.5 ml, and that 0.5 ml is required for the homeostasis of the body. Now this fluid therapy, when we gave it, we also look 3 compartments. There are 2 partitions which are controlling it. Now always I've seen most of the people, they try to give crystalloid to resuscitate the person. For example, if the patient comes with a polytrauma, there is no problem with the capillary at this moment. There is no infection. The only contraindication to the colloid fluid disease immediately is the sepsis or burn patients. Do not use any colloids in the beginning till the capillary poles start becoming to the normal size. So if you, for example, if you give saline or sodium containing fluids, its volume distribution is only intravascular volume and interstitial volume. It stops going to the cell because at the cell, fluid transfer is controlled by osmolarity or osmolarity. Now, if you look at the extracellular fluid volume, it is 2/3 of the total body water. Out of 2/3, again, out of 1/3, again 2/3 is in the interstitial compartment. Now, if you give 1 liter of saline to a person, 660 ml will go into interstitial compartment. Only 330 or 370 will be left in the vessel. So if you want to resuscitate to give 1 liter, to keep 1 liter in the intravascular compartment, you will have to give 3 liters of saline. So why not to give colloid which stays in the vessel? In my opinion, if there is no contraindication to colloids otherwise, initial resuscitation should be with the colloid solution, but how would we monitor it? Central venous pressure. If the patient is ordinary, or in any case, we will put the central venous pressure. If the patient is on ventilator, then the central venous pressure cannot give you the exact amount of fluid should be given to that patient. Then we have to push the transesophageal echo. You pulse pressure variation or what we call as stroke volume variation. They will guide you the exact amount to be given. This is my comment a little bit about the fluid therapy. Thank you.
Thank you so much, sir. Our second chair today was Dr. Ashraf Sia. Sir, would you like to comment?
Bismillah ar-Rahman ar-Rahim. Kul Rabbi Zidna, Kul Rabbi Zidni Ilma. Thank you very much. Sir has given a very detailed discussion about fluid management, and I think the time which was not taken up by Dr. Farjad has been very nicely covered by Sir Patima Mumtaz. So this was really a very nice presentation and topic covered by all the speakers. First of all, Madam Sadka Aftab elaborated in a very nice way management of polytrauma patients, and exactly the same patient we are dealing in our ICU with polytrauma, with pelvic binding and fluid challenges. And second, Madam Safia Zafar has very nicely and in detail given the treatment of tetanus, its management, because it's a very frequently we receive patients in ICU and we have a lot of challenges for their management. Fluid stewardship has been discussed in detail by Professor Mehdi, और मेरे ख्याल उसमें कोई चीज़ रह नहीं गई. एक बड़ा इम्पॉर्टेंट टॉपिक जो प्रोफेसर हमीदुल्लाह ने जो एसोसिएट प्रोफेसर हमीदुल्लाह ने जो अभी एलेबरेट किया, वी कम अक्रॉस विद पोस्ट इंटेंसिव केयर सिंड्रोम, एंड दिस इज द टॉपिक विच इज most of the time is neglected in ICU, and these patients have ICU psychosis when they are discharged from them. So this is very important that we should have a feedback from these patients, और उसके बाद we can improve how to minimize these complications. One suggestion which was given one of presentation was that the family should be frequently involved in ICU management, but in our setup we cannot involve the family to that extent, because the way they are entering in ICU, that creates a lot of trouble for management. So all the presentations were very nice and up to mark, and we had a lot of knowledge sharing, and thank you very much.
Thank you so much, sir. Our third panelist today was Dr. Tahir Ali. I would like to request him to comment on the session. Please, sir.
Assalamu alaikum wa rahmatullah. Thank you very much. So I was going to comment on the post-IC intensive care syndrome, because that's something very big on. But first I have to comment on the fluids. I'm afraid, I think just because something physiologically makes sense, it doesn't necessarily translate to evidence. And I think it's important for us to try our best to move away from opinions and go with best evidence. So if we were to look at the sequence of events in terms of the trials, there are far too many trials to discuss in 1 minute, starting from the SAFE trial, and then following that the VZEP trial, and then following that the Albios trial, and then there are multiple trials looking at colloids versus crystalloids, and even crystalloids balanced versus non-balanced. So if you were to summary, my little recommendation is we have together a group of intensivists and trainees put together a website called The Bottom Line. In that, to make life simple for trainees and for their exams, we summarize every single paper, every single research article, we critically appraise it, and we ensure the pros and cons, and being very honest about them when it's a bad trial. So if you Google Bottom Line, it is free. You can access all the data. In summary, I think from what you mentioned in your presentation, I suspect the reason why saline is still in all the guidelines is because there's a SALT ED trial, and then there's multiple other trials that have shown that it doesn't actually worsen mortality, even though we all see that horrible hypochloremic metabolic acidosis. We know we see it. And of course, the latest trial, looking at crystalloids versus colloids, is the 6S trial. And of course, it shows an increase in mortality. It shows an increase in renal replacement therapy. So, doesn't translate to evidence. And when we're talking about leak, there is an albumin, there is a natural albumin leak anyway. And therefore, when you administer albumin, it will absolutely temporarily cause an oncotic pressure, of course. Then it will leak out. And more importantly, it does not translate to evidence. The only colloid which does not increase mortality or morbidity, which has been extensively studied, is albumin, but there is no evidence that it actually improves anything. The only thing you're doing is you end up, and I do tend to give albumin sometimes when I don't want to give too much fluid, because I have evidence that it does not increase mortality. But it's just a more expensive way of giving the same thing. So that's my little thing over there. My question actually to the post-intensive care syndrome one was, do you use patient diaries? And actually that's something we use a lot, where pen and a little book diary, and the nurses will write their journey. The family can come and write in it as well, because what we also find is there are these blank, there's the periods of amnesia. They can't recall various events, and actually that we find is quite useful for them to fill in those blanks. And also, do you use pickups screening tool for following up your intensive care trainees? Thank you.
Mike Ladd.
Yes, we have used diaries in very few patients, maybe on one hand fingers, 4 or 5 patients. They have been very useful, and we plan, actually the patient lot that we get is very different from what you get. And writing while being in intensive care is not something that is common. And most patients also would not like to do that as well. Only the very educated ones and who have very good family support. We have seen 4 or 5 patients who would write what they feel, what is going on with them. And for the tune-up things, no, we don't.
No, sorry, I meant patient diaries where it's for the patient and the nurse writes, this happened to you today, this was done, other people came into the room, and where the family can also write about their days.
We don't write this,
okay,
but we do this as a nursing practice, but we don't write this.
Thank you.
Any question or comments from the audience?
इनको माइक दे दें प्लीज.
Thank you very much, sir. My question is regarding the management of a tetanus patient in ICU. I was just wondering that whether we do the tracheostomies to avoid the oversedation or as a part of the airway management. Your few words, Professor Mehdi. Thank you.
Question Professor Imran Skandar has asked.
Could you repeat your question again?
Sir, मेरा question ये है कि क्या हमसे oversedation की complications को avoid करने के लिए tracheostomies करते हैं, या जो complications होती हैं spasms की वजह से airway compromise हुआ होता है तो उसकी वजह से करते हैं? Your few words.
While a patient is in ICU, there are definite indications for doing the tracheostomy, Any patient who is going to stay more than 7 to 10 days, we always plan do the tracheostomy. Any patient, if we think that the patient is going to, now we immediately do the tracheostomy also. And if the patient comes with a respiratory obstruction, then we assess it to bypass the obstruction, then we do the tracheostomy. And sometimes, if it is prolonged, you have to have a better hygiene of the mouth and better care, nursing care, then we also do the tracheostomy and explain to the patient, the relatives and the patient, if the patient can understand these things also. So it depends. So otherwise, if you look at the indication of tracheostomy written by ENT people, they start from A up to Y and then say there are yet more indications to do the tracheostomy also. So it is decided individually on individual patients also. So you can do you can reduce the sedation and by doing the tracheostomy, but the sedation is so important in intensive care unit, because when I went to Birmingham Hospital, I went for one purpose. There was Professor Robinson. He was a very well-known teacher, and when I went there, he was on ventilator. And because they did the ventricography, and that time there was no CT scan. And I used to sit by his side at night and used to say, I have come to learn from you, and you are lying here, you will have to come back. It went on for 6 weeks. Then they declared his brain is dead, but there were no guidelines that time for the brain, dead brain. Then his assistant said, no, I'm not going to disconnect it from the ventilator. After another 6 weeks, he came around. The only thing he said when he woke up, and he's still alive, he's 97 years old, he said, two things were bothering me. One is the noise of the door of the ICU. And second thing was somebody used to come and say me that I have to come back. Then I said it was me, and he became a very good friend. And he taught me so much. He taught me physiology, respiratory physiology in a mathematical way. Every morning we used to go to canteen and have a tea, and he used to discuss with me. So sedation is very important also. We indicate tracheostomy is never ever done for avoiding the sedation. Sedation is very important.
Assalamu alaikum. My question is Dr. Safiya Zafar. What is recommended evidence-based duration of treatment for IV metronidazole in tetanus patient?
आई थिंक 5 डेज है ये, बुक में तो ये लिखा है. आपका थोड़ा सर ने बिल्कुल सही बोला, आई टोटली एग्री विद हिम. बस ट्रैकोस्टमी तो होती ही है एयरवे प्रोटेक्ट करने के लिए. जिस पेशेंट की मैंने पिक्चर दिखाई थी, ये मेरा पेशेंट तकरीबन ठीक हो गया है बगैर ट्रैकोस्टमी के. इसको ज़रूरत नहीं पड़ी. इसको सेडेशन लेवल हम मॉनिटर करते रहे. दिन को रात को बहुत विजिलेंट मॉनिटरिंग चाहिए होती है. सर बिल्कुल ठीक कह रहे थे, तो नहीं ज़रूरत पड़ी. और ये वाला सीवियर वाले में नहीं गया कि इसको हमको वेंटिलेट करना पड़े. सिर्फ ऑक्सीजन दे के और बाकी मैग्नीशियम सल्फेट और वेलियम, इस पर ये कंट्रोल हो गया.
Why don't we go for intrathecal baclofen in Pakistan? Is it very much costly? या हमने कभी परवाह ही नहीं की लोगों को देने के लिए? अवेलेबिलिटी तो बहुत सारी चीज़ों की आज से 10 साल पहले नहीं थी, अभी हो गई है. लेकिन बहुत सारी ऐसी चीज़ें जो कि अभी अवेलेबल नहीं है, सिर्फ इसलिए अवेलेबल नहीं होती. फॉर एग्जांपल सुगामाटेक्स कि वो बहुत ज़्यादा कॉस्टली है. हम गरीब लोग हैं, हमारे यहाँ पब्लिक सेक्टर में शायद उसको हम अफोर्ड ना कर सकें. why not intrathecal baclofen कि मरीज बेचारा स्पाज्म से जो है तड़प रहा होता है और हम कुछ नहीं कर सकते. मसल रिलैक्सेंट पे मसल रिलैक्सेंट दिए जा रहे होते हैं.
अच्छा, मसल रिलैक्सेंट इतनी देनी नहीं पड़ती अगर आप मैग्नीशियम का लेवल मेंटेन रखें. ये बहुत विजिलेंट मॉनिटरिंग करनी होती है. क्लिनिकल मॉनिटरिंग बहुत इंपॉर्टेंट होती है. एक चार्ट बना के हमने लगाया हुआ है जिसमें पटेलर रिफ्लेक्स देख रहे होते हैं बार बार. और मैग्नीशियम सल्फेट ज़्यादातर एडल्ट की बात कर रहे हैं 2 ग्राम 1.5 ग्राम टू 1.51 इस पर चला रहे होते हैं इनको 24 आवर्स. और जहाँ उसका लेवल थेरेपेटिक लेवल में आ जाता है बस उसको फिर उसी पे मेंटेन करते हैं. कोशिश ही करते हैं कि फ्लक्चुएशन नहीं हो मैग्नीशियम में. अगर होता है तो उसको स्पैज्म होते रहते हैं. तो मैग्नीशियम सल्फेट एंड ये अपना जो बेंजोडाइजेपिन, इससे मोस्ट ऑफ द टाइम कंट्रोल हो जाता है. कभी कभी बहुत सीवियर में आता है तो आपको फॉर सम टाइम मसल रिलैक्स करना पड़ता है, वेंटिलेटर पर डालना पड़ता है थोड़ी देर के लिए. इस दौरान आप अगर मैग्नीशियम लेवल मेंटेन कर लें तो वो हो जाता है ठीक. एक बात. दूसरी बात ये कि कभी कभी ऐसा होता है कि नहीं संभल रहा होता है तो आपको फिर दूसरी एंटी कन्वल्सन दे के सम टाइम देना पड़ता है, फिनोबार्बिटोन टाइप की चीज़ थोड़ी देर के लिए. इंट्राथीकल वाला ये कि अवेलेबल नहीं है तो मैं क्या करूं, एक चीज़. लेकिन लिटरेचर में है, इन्होंने दिया था, लेकिन उस पर भी वो कह रहे हैं कि मॉर्टेलिटी पे इतना फ़र्क नहीं पड़ा है, लेकिन स्पैज़म कंट्रोल हो जाते हैं उसके, तो पेशेंट के लिए पेनफुल कंडीशन नहीं रहती. तो पेन के लिए हमारे पास दूसरी 4 दवाएं हैं, वो यूज़ करते हैं. अगर हमारे पास नहीं है तो नहीं, लेकिन होनी चाहिए. बिल्कुल सही है, यू आई एग्री. और सुडामिडेक्स भी आने वाली है, वैसे मैंने सुना है जल्दी आने वाली है. रॉकुरोनियम तो आ गई,
रॉकुरोनियम तो अवेलेबल है.
नहीं हमारे पास तो है, हम यूज़ कर रहे हैं.
सर, Dr. Raza, Assistant Professor of Pulmonology and Critical Care. My question is from Dr. Farjad. Thank you, sir. You have explained very well. But still, the question is not clear. What is the drug fluid of choice? Apart from in sepsis, apart from normal saline, we are unsurprised to our even residents, our students, that they say that, for example, ringer lactate has low pH as compared to normal saline, and we see most of the time the septic patient are most of the time acidotic. Apart from the complication you have described, is there any head-to-head trial, because sepsis surviving compliance is based on Cochrane review and multiple studies? So is there any head-to-head trial that can suggest which fluid is better in sepsis?
Right. Thank you for the question. Pehla baat, which is the most optimal fluid, it does not exist. So again, as part of the presentation, we have to look at the problems that the patient has, and then we have to take our own decision. ऐसा हो नहीं सकता कि हम बोल दें बस ये है और plug and play कर दें बस यही चलेगा. Every fluid has its own problems. Every patient has their own physiology. एक तो होता है bookish physiology. फिर इंसान जो है वो evolve करता रहता है physiological changes के साथ. For example, people evolve and accommodate, let's say for example, mitral stenosis या aortic stenosis. But we as doctors, अब जब patient जिस condition में आता है, I don't know what the kidneys are, how the liver is functioning. I don't know what is being absorbed or what can be absorbed or cannot be absorbed. So we have to individualize treatment for each patient. ये plug and play हो नहीं सकता कि यार ये 4 पहिए हैं, गाड़ी है, यहाँ से वहाँ पहुँचा देगी. No, we have to individualize fluid with everything. Sir ने भी बड़ा अच्छा डिटेल में भी बताया कि there are so many factors that we have to consider. If it was that easy, it would be there. That is why there are guidelines, they have suggestions, but there is no hard level 1 evidence saying this is better than that. जहाँ तक normal saline की बात है, it's an economical thing. It is easily producible, it is easily available, it is easily stored. But again, a lot of guidelines do say कि 2 liter, 3 liter के बाद, you should start thinking of some other fluid as well, a more balanced fluid. But initially it is easily available. कि बनाना उसको आसान है. It's normal saline 0.9%. Whereas if you look at the other solutions, there's a lot of tweaking. ये दें, वो दें, ये दें. So it's which is easier to make and store. That is it. But as for there are lots of trials going on, but none, as far as I know, have given a hard evidence that this fluid is the optimal fluid. This fluid should be used for sepsis. Yeah, this fluid should be used for trauma.
इसमें थोड़ा सा इसमें देखिए मकसद हमारा क्या है. मकसद ये है कि ऑक्सीजनेशन करनी है टिश्यू लेवल पे, यही मकसद है. इसी के लिए हमें ब्लड को ट्रांसपोर्ट करना है फ्रॉम लंग्स, फ्रॉम हार्ट टू द पेरिफेरी, यही करना है. तो हमें इतना वॉल्यूम चाहिए और ऐसा वॉल्यूम चाहिए जो ऑक्सीजन को लेके वहाँ पहुँचा रहा हो जहाँ पर टिश्यू पे चाहिए. तो आपको ये भी देखना होगा, इनका कहना बिल्कुल सही, उसकी फिजियोलॉजी क्या है, उसका हीमोग्लोबिन कितना है, उसके अंदर प्रोटीन कितना है, उसका किडनी फंक्शन कितना है, उसके लिहाज से आप फ्लूइड डिसाइड करेंगे ना. तो इस पर कोई एक रूल तो हो नहीं सकता. तो आपको उस पेशेंट के लिए डिसाइड करना पड़ेगा क्या करना है कि हम ऑक्सीजनेटेड ब्लड टिश्यू तक पहुंचा दें. बस ये सोचना है. अगर ये समझ में आ गई बात तो आप फ्लूइड डिसाइड कर लेंगे.
Yeah. Kindly be seated. I hope this session has been productive. I would like our chair, Dr. Mehdi Hassan Mumtaz, to come on stage and give shields to our presenters. Dr. Mehdi Hassan Mumtaz. I would like to invite our first presenter, Dr. Sadika Aftab, to please come on stage and collect her shield. Dr. Safia Zafar. Thank you, sir. Sir, you can again sit on. Yes, sir. Thank you, sir. Now I would like to invite Dr. Ashraf Zia to come on stage and distribute the rest of the shields. Dr. Syed Farjad Sultan, please come on stage, sir.
इनके टीमों आ गए ना सर.
Dr. Hamidullah, sir, please come on stage. Sir, एक shield और लेते. Dr. Safia Puram. Thank you, sir. Now, I would like to invite Dr. Safia to come on stage and present shields to our honorable chair. Safia. Dr. Ashraf Zia. Sir, कोई बात नहीं आप आज. Okay. Dr. Mehdi Hassan.
लोगों तो सीनियर लोग ही जाके दे दूं.
सर कोई बात नहीं. Thank you so much, sir. Now, Dr. Ashraf, ma'am, kindly ask me. Dr. Ashraf Zia, our second panelist.
लेट हो गए सर.
साहब आप इधर एक तस्वीर बना लेंगे.
वीडियो बनाएगा काली की.
Thank you, sir. Dr. Tahir Ali, please come on stage.
डील साहब ने ताहिर साहब को शील दी.
अच्छा.
Dr. Tahir, you should remain on the stage, madam. Please बैठ जाए. And now I would like to bother Brigadier Salim sahab. Dr. Tahir Ali was speaker yesterday in the plenary session, but he left for some reasons and couldn't receive his shield. So I want you to give the yesterday's shield to him now. Okay, thank you very much. With this, we come to a very productive session now. The tea was supposed to be of 30 minutes, but since we are short of time, and the next session, which is about the panel discussion, which will be moderated by Dr. Tahir Ali, very productive session. So I request all of you to come back at 11 a.m. sharp. See you then. बस मैडम चाय साथ लिए यहाँ बैठ जाए. चाय और बिस्किट यहाँ ले आए.
Hello, testing. Hello. 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 Hello, testing. Hello. 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 बिलाल भाई हेलो ठीक है जी बाहर जाओ
Our today's moderator for today's panel session is Dr. Tahir Ali. You have met him yesterday. Dr. Tahir Ali is a consultant in intensive care medicine and anesthesia, Buckinghamshire Healthcare NHS Trust. And he is an education tutorial for ICU, and he guide.
Clear, I think, because we are delayed by half an hour. Yeah, can you pop that? It's working, but it's not there. Yeah, but it's not up. Is it F, Control F or something? Is it Control F or, come on. Okay, there we are. Okay. All right, so this is not a PowerPoint presentation. This is actually just little highlights of what we're going to discuss today. So obviously the first topic is neurotrauma, and actually just to give neurotrauma only half an hour is not doing it justice, because obviously neurotrauma incorporates not just brain but spinal cord injuries, and we over there are fortunate to be the National Spinal Injuries Unit, and we pioneered the Paralympics from our hospital, from the physiotherapists, and so we've got a fair bit of experience with that. But I mean, hopefully in the next PSA we will do a whole session on spinal injuries trauma. But we'll start off, and this is questions open forum. I'm actually not going to pick on individuals. I'll just leave it open, and anyone who wants to discuss. Your patterns of injury are probably a bit different to ours. Is that a fair comment? What sort of pattern of injuries are the panel familiar with, or more commonly familiar with? We can start with you from the left, actually.
Okay, thank you. I'm not aware about the pattern of injury in your part of the world, but what we see as neurotrauma, the major portion of it is from road traffic accidents.
Okay.
It is because of the motorbikes. They don't wear helmets regularly, and the way they drive, everybody is aware of that, and that is the major bulk of our neurotrauma. Apart from that, there's a little bit of firearm injuries, bullet injuries, and very few is because of falls, history of falls. So if I would grade in terms of magnitude, it's road traffic accident, then there is bullet injuries, and then there is falls.
Interesting. And in the audience, hands up, is that sort of the types that you're familiar with, and actually you agree with that? Fine. So this is the general patterns. Okay. Yes? Yes, I was going to say, no one mentioned that.
Out of few countries, Pakistan is among out of few countries where blast complex injuries are.
Yeah.
Peshawar is one of the place who manages maximum of these injuries. They are very complex.
Right. Okay. Yes. I mean, I think we're all aware of that. Now, you actually touched on something which is going to be discussed later, so we might as well talk about it now. You said they don't wear helmets. What we as doctors should do, as we are patient advocates and public health advocates, and we know far more about injury prevention than politicians would. We can start. What do you think our role as physicians, as doctors, and as quite an impressive group and a dynamic group of male, female, young and old, how can we impact on public health in terms of changing laws, for example, mandating seatbelts? I'm sure some people will want to throw something at me for saying that. And mandating helmets, and actually introducing fines for people not doing them. What are your feelings about that? For you, yes, and then ma'am.
You can name. In fact, in Peshawar, I observe daily a motorcycle rider with the helmet on the handle. This is a big joke. And people don't wear. And they are wandering everywhere, and we do meet with many road traffic accidents, and most of them are motorcyclists. And it is a huge trauma and very commonly to the head. And I, being the radiologist, first of all, I thank you all inviting me, giving me this opportunity. In fact, the day is gone जब रेडियोलॉजिस्ट को लोग पूछते भी नहीं थे, अकेला काले कमरे में बैठा काले काले एक्सरे देख रहा होता था. एंड मुजाहिद ने मुझे 2-1 दफ़ा जब इनवाइट किया है, रिक्वेस्ट की है, एंड आई एम हेयर, तो मुझे था कि वो जैसे कहते हैं ना कि हम पे ये अनायात कभी पहले न थी, साकी ने कुछ मिला ना दिया हो शराब में. एंड आई एम थैंकफुल. In fact, I will just convey some very basic what to choose and when to choose and what to do when you are referring a patient for imaging, radiological imaging, when you are assessing a patient for trauma pattern, what is inside going on and what is damage done and what is impending damage to be done. And when in very good hospitals, when you have many choice, you have MR, you have plain X-ray, you have angiography, you have CT there, and what to choose. And the scene is different in different hospitals. The choice is limited in periphery, and already the patient condition may vary a lot. And for radiology, I request you, ABC is the first. First, please ensure ABC and then refer to radiology department. And if the patient is unconscious, some anesthetist or some resident should accompany the patient. And for neurotrauma, plain X-ray, no more. Head injury, plain X-ray, no more. It is wastage of time. MR, so very sensitive, assessing neuro and neurotrauma, but not at all the first choice. For neurotrauma, CT and CT. It is the first and it is the foremost choice. You must go for CT. And one thing very clearly to be understood, for neurotrauma, not CT with contrast. Please understand, for neurotrauma, CT without contrast. With contrast, you may miss subarachnoid hemorrhage, you may miss bleed, and then many of these patients, many of these patients, they are not with the isolated neurotrauma, they are most commonly with polytrauma. There may be lot of killing injury to the chest, to the abdomen, blunt abdominal trauma, a big secret, and patient may go and bleed inside and die of that. And very good choice is again CT. We have the ready-made protocols for the patient of multi-trauma, polytrauma. And for those, please go for whole body CT and write trauma protocol. Tumor protocol and trauma protocol. Tumor is different, trauma is different. And for that, the protocol dedicated is, first of all, we do the CT head without contrast. And then after that, we give IV contrast and we perform the whole body CT. Again, head, neck, chest, and abdomen, including pelvis. So you can manage the patient absolutely beautifully, knowing everything going inside. And believe you me, the CT is ever emergency friendly, not MR. There are lot many contraindication for MR, and there is no contraindication for CT. And CT is to be done just it can be performed for the whole body CT even within 5 to 10 minutes. MR takes at least 3 hours when you have to cover the whole body. Not MR, CT. Okay, when the CT is normal and the patient is otherwise managed, follow-up. Follow-up, any sepsis, any infection, any external injury. Okay.
Can I just interrupt? Sorry, thank you very much. I know this is very useful.
MR.
It's just because we are really limited with time, but I think the points you mentioned are absolutely essential. X-rays, apart from pelvis X-rays, I'm sure you'll agree, are useless. Pelvis X-rays are very useful. CT should be your gold standard, and exactly not to use contrast at the start. So he's basically covered the entire investigations for trauma. And everyone knows DPL is obsolete. Yeah, it's still in the ATLS guidelines because ATLS is practiced in remote areas. Yeah, so when I do sort of training in Sudan, they don't have access to CT. So they will do a DPL, but they won't necessarily do a laparotomy. Okay, so it's all clinically contextualized. So thank you very much for that. It was summarizing everything. The other thing, I'd probably add a point, though, and I'm only saying this because we've got a very close relationship with our radiologists and our IRs, and also my older brother's an interventional radiologist. Your request needs to be clear. If you just write abdominal pain, that will irritate the radiologist. You need to have a question. What exactly do you want the radiologist to look for? Do you agree? They may find something extra because they're very good at it, but you have a specific question because based on your question, they will tell the radiographers to do a specific type of imaging. Is that fair? Okay. So, but back to my original question, if you don't mind. Yes. Sure.
Patients in Pakistan, I am Dr. Liaquat, Professor Anesthesia. In Pakistan, 90% of these patient trauma, at least first few hours, will not have access to CT. And there are alternates, easy alternate. One is the FAST, and almost 90% sensitive in abdominal injuries. Then DPL is still very, very useful because of two reasons. Where CT is not available, as I said, only 10% patient in initial first hour or so will be able to have access to the CT scan. DPL even is sensitive, more sensitive in minor intestinal injury, which may be missed with the CT or FAST, etc. So according to the situation, if you are sitting in London, that will be all right. But in most of the area in Pakistan or many countries like this, I think these things not still absolute. They have their role. Thank you very much.
Agreed. But as I said, clinically correlate, because if you have blood positive in the DPL, but they're not hypotensive or shocked, you're not going to laparotomize them. And we know that because we do CT abdomens with minor splenic injuries, and you find that you don't use observe. Now, before taking more questions from the audience, I want to involve the panelists. So I don't know how powerful you as a body of doctors are to influence change in public health. So back to my original question, what can we do to influence changes in laws to make things safer?
I think in order to do that, the doctors' organization should have a relationship with the government at some level, which at the moment is non-existent or very little in the country. I know about the anesthesia organizations, both at the national and the provincial level, and the relationship is non-existent. The other thing would be to have specific neurosurgical organizations which take that up with the government regarding neurotrauma. But I don't see anything there. At the personal level, we can make efforts. We can write in newspapers, we can have public awareness programs, but that is again at personal level.
Okay.
But the thing is, when you're talking about road traffic accidents, helmets, I think there is an existing law that says that people should wear helmets.
Where's the implementation?
And there has been an increase in wearing helmets by the riders. I've seen it over the years. But then you see motorcycles with a rider wearing a helmet, and there's a lady sitting at the back not wearing, and two children sitting in the front who are, you know, at the mercy of God. So I don't know. It's, as I said, we can do a little bit at our own personal level.
I agree. I have to say, some of my colleagues who have visited here, they've taken pictures and videos saying this is fascinating. There's the man wearing the helmet, riding, and then behind him, one facing that way, one facing that way, and both have a child in their hand. How is this possible? And another one took a video of 20 people coming out of one car, which was just incredible. So, but you're right. I think, how easy is it for a body of such highly intellectuals to actually start having a say and a voice in government to influence public health and say that actually, look, we know when a primary injury occurs, so the primary brain injury we can't prevent, but we know after mandating seatbelts in UK, was it in the 60s or 70s, the head injury and the major trauma incidents just absolutely dropped and to an unbelievable amount. So we know it makes a difference. I guess that's a question for you all to think about later. Yeah, please.
Yeah, can I just make a comment about this? I started wearing seat belts after I heard Princess Diana's accident.
Okay.
And I was saved by that once when I had an accident in front of my own hospitals because I was wearing a seat belt.
There we are. So I think we know seatbelts don't completely protect you, but the injury pattern is not it's not lethal necessarily. Okay, I think we'll move to that because we'll try and get the questions at the end, but probably involve you in terms of challenges. Because of course, where I'm coming from, I can't say this is what you should do. What are the management begins pre-hospital, and in many ways that is so essential that it can determine mortality. What are the challenges that anyone's aware of pre-hospital at the scene before they come to hospital, and how can we address them? Anyone who wants to amongst you, and hands up as well, or no hands up. Go for Doctor.
Okay. So this all comes from awareness. Mm-hmm. If you recall, one of our famous politician, Imran Khan, fell from his stage a few years ago, okay, and how he was carried from the scene to the car or ambulance was amazing. And all principles of safe transfer were broken. Each and every principle was broken. And this is, I'm talking about somebody who has a very high profile in this country. So this is the state of affair at the scene. Public awareness about how to transfer, when to transfer, how to take care of the initial patients. Then comes the role of this ambulance service. There are multiple ambulance services running, some run by the government, like every province has some form of government ambulance service. Probably Punjab has the better ones, the 112s. Sindh also has something, I'm sure KP would also have something. Then there are private ambulances. There is significant lack of training of those paramedics, if at all they have, in their ambulances. It's basically the drivers and the families who transport. So yes, that is an area that needs to be taken care of, and I totally agree. The condition in which they present to ER could have been much better if the transfer would have been safe.
So do we have, are there insufficient ambulances or insufficient ambulances and paramedics? When I say ambulances, pre-hospital paramedics.
I think the city where I come from, the ambulance availability is very quick.
Okay.
It's the availability of the personnel who transfer the patient to the ambulance is the main concern.
Fine, I got it. I'll mention it. Okay, sorry. Okay, fine. So how, again, just like all of you were saying that we need to encourage recruitment to anesthesia, I would say we need to encourage recruitment into intensive care as well, because I am an intensivist to my bones, and I'm very, very passionate about anesthesia as well. We probably, sounds like we should be recruiting people to paramedic specialties, because actually we can do things in the hospital, but if they don't manage them and start the prevention of secondary brain injury, start immobilizing that C-spine from the very offset, then of course the injuries can be completely detrimental and life-changing. Dr. Hayat, you had your hand up.
My comment would be that it's not the availability of ambulances or the services. It's actually the care, the quality of care being provided by those who run that service. Because 112 service is now available in the FATA region even.
Okay. Oh wow. Okay.
They have expanded their services. But the question is, when we receive a patient from Bajor or from far from districts, they don't even have a small cannula. They are dehydrated. They are like our normal HB is 15, but when they arrive with us, their HB is just 6 or 7.
Okay.
So it's the basics, as our radiologist panelist highlighted, that we need to concentrate on the basics, ABCs first.
Agreed.
Thank you.
I think that, thank you, and actually that is the crux of the issue here. For me to come and say, this is our pre-hospital system that we have, you should implement it, would be foolish from my point of view. And it was not always good. It was dreadful at some point in history, I'm sure, but over time it has been perfected and improved. And I think you'd be surprised how much influence as anesthesiologists you can have in training the paramedics. We do combined simulation courses with paramedics on transfer training and safe transfer. We spoke about that a few years ago with Dr. Hayat, safe transfer training. And again, I'm not saying we will implement exactly our ambulance system here, but there must be a way where people like yourselves can have a strong voice and say, we're not taking nonsense, we need this to be better, let's look at what facilities we have and we can make it safe using that facility, those facilities, and then put pressure on the people higher up to try and implement better processes. I mean, now you all have capnography, you have the machines you have are better than some of ours. So I think in terms of resources, it would be unfair to say that Pakistan is a resource limited place. Of course, some sections are, but I think things are a lot better than what it appears to be outside. I think, yes, someone, yes.
So one of the challenges we are facing right now is also about the communication gap.
Okay.
From the area of the accident to the hospital, there is no communication. We get to know about the patient when the patient has been landed in the emergency by the paramedic staff. So we are not well prepared for that thing as well. We don't know, we have to intubate the patient, what are the condition of the patient, what was fluid given to the patient. We don't know anything about what paramedic has done to save the patient. This is one of the challenge. Because in the from the part of the world you have been working on, there is always a communication. They know that you know prior to the attending that this is the accident, these are the patients, this is the age of the patient, they have been treating this way, and now we have to do this way.
You know what, actually, I'm loving this discussion, and actually I love how all of you are saying exactly what I want to hear, because all of you have the medical knowledge, and we all know the human factors are one of the main causes of patients coming to harm or mortality. It's not because you don't have the knowledge. You just pointed out that one word. They don't communicate with you. If you had that information that patient was wearing a seatbelt, high speed, GCS, whatever, even if that's the only information you have, in your mind you're building a picture okay, they were a driver, so the seat belt, they may have a splenic injury, they may have rib fractures, GCS is low. If they were a passenger, you're thinking of a liver. So you can build that picture. And I think it sounds like one of the biggest challenges you have here is in the pre-hospital setting. Yes, Dr. Sharia, you had your hand up.
Moving forward, I agree with my colleague who said that we are not informed, but obviously communication depends where you are and how things are. But moving forward, I would say that things have to be improved in the ER. I mean, in every ER, there should be a resus area, as you are familiar with in the UK, that the patient who lands up with a extensive trauma or whatever serious disease or whatever, they come and land up in a resus area where he has a primary survey and a secondary survey. So, so far I have spent the time here. In the ER, they are more worried about bleeding and all these things, but they are not concentrating on the ABC of the patient.
So it sounds like, I think, you know what, the sections I thought we're going to discuss, we're probably not going to, because you've highlighted the main issues. It's at the scene, the pre-hospital management is less than suboptimal. Is that a fair comment to say? And actually the communication is non-existent. And then ER. So there are multiple stages where you'd be surprised how much influence as anesthesiologists you can have, both in so many ways, in training the paramedics, training ED doctors, and also implementing systems and processes with whatever resources you have. Because as Dr. Hayat said, they don't even come with a cannula. Just teaching them to insert a cannula and manage the upper airway just by putting a Guedel in may well save their life. They don't need to learn how to tube someone. Don't touch them. Tube them in a distant location, and they're esophageal. They've not confirmed it. They come here, they're brain dead. Yep. So I think those are important points. Dr. Mukhtar's online, but we can't see his picture. So do you have any comments at all? You need to turn the volume up.
Can you hear me?
Yes, we can hear you. Thank you. Welcome.
Thank you for giving me the opportunity. I'm listening to the discussion, and it's very interesting to see our community talking about neurotrauma. I have been involved in this educating for the neurotrauma management since 2017, when I was working in the Northwest Hospital. Professor Tariq, who was the then chairman of the neurotrauma committee of the WFMS. So, just as a perspective, in 2015 there was a Lancet safe, affordable anesthesia, surgery, and obstetric care. So, after that, women like this, and in 2019, Harvard University.
Yes, loud and clear. Yes, loud and clear. Thank you. I think your mic is off. Dr. Mukhtar. Yeah, we can hear you now, loud and clear. Thank you.
So in 2015, with the Harvard University, we presented national surgical guidelines. We also involved the government officials, and these guidelines were presented in an international conference in November 2019 Peshawar recommendations, the detailed item is comprehensive policy recommendations for brain and spine trauma management in low and middle income countries. It's published internationally with Harvard University, and it's very detailed. So, like those guidelines, I heard people who talked about that surgical communities need to bring forward with recommendation, which are already in place. So, I think there is a gap of knowledge and communication maybe from our side, but that needs to be taken into account.
Okay. Thank you. Thank you. That's actually very, very useful. So I think everyone here are singing from the same hymn sheet, so to speak. I would keep the video online. I don't need to see the PowerPoint because actually it makes it more engaging. Yeah, we started half an hour late, so it's not possible, I'm afraid. Okay. I think. Yes, hands up. Just shout. And how can you turn this down? It's really loud. Come on, I'm sure you can shout loud enough.
Thank you. So, we just talked about, we identified a couple of gaps. So, I want to come...
just, if Dr. Mukhtar, if you can mute your mic, then we will not get the echo.
All right, so we had identified a couple of gaps, but coming back to your second question, how we can bring change, like we are doctors, we know a lot. So my suggestion is that hospitals should be role model for the society. Like we cannot change a lot of things at the government level right now, but hospitals should mandate all the staff who are coming to the hospital that they should be wearing seat belts, they should have helmets. Just like we did in COVID, we mandated COVID testing, we mandated face masks. So my suggestion is that the first thing that we can do, which would not take a lot of effort, is that all these safety precautions, which we know are very important, we should mandate them. The second thing, which as doctors we should do, is that we should publish data. We should start collecting data, how many accidents are happening, what's the outcome, what happens if you're wearing a helmet, and what happens if you are not wearing a helmet. We saw this happening in COVID, that there was a lot of, and all that worked. So my 2 points are, one is that we should mandate these things within the premises of the hospital, and the second is that we should start publishing data.
I think that deserves a round of applause, because that is... You should run for Prime Minister next, okay? I think that is the point, leading by example. So if we are driving to work, and as our esteemed guest over there said that she ensured after that incident she wore a seatbelt, if we all don't wear seatbelts, what's the point telling someone else? And this whole, we can't do that, as in, they're doing something wrong, so we'll do it as well. If they see us leaders and leading as examples, because fortunately, you still have a lot of respect in this society for doctors. Am I right? Not so much over there. Here you still have respect, which is great. And I think when you say publish, I have to say my Urdu speaking is dreadful, but I can read it. And I've seen articles published in general newspapers relating to medical topics. Whoever is a good writer, maybe that's something they should take up and start publishing these sort of things to inform the public. I think you'd be doing a great service if that takes off. I think I think most of you know how to manage a patient perioperatively. Is that fair to say? I think you know your 5 essential, crucial gold points of how to prevent secondary brain injury. If we could have either of the panelists, because once the primary brain injury has occurred, we can't do anything about that. So our role is to prevent secondary brain injury. I'm just going to very briefly, do you want to just define that for the audience? Any of you?
I think one has to remember the physiology of cerebral perfusion pressures.
Yep.
And and also the spinal perfusion pressures, especially in spinal injury. I think most of us forget about that when we are doing spinal surgeries.
Yep.
And I'm sure the audience here knows about the cerebral perfusion pressure definitions and what should be done.
But in
with
practice,
neurotrauma.
when they come to you or yourself or anyone in this room, what are you going to ruthlessly prevent from happening in terms of CO2, oxygenation, temperature, glucose, and blood pressure? Yeah, I think those are the 5 points that we all know. And we can't forget about what's happened prior, but if from the very offset we take it serious, and even for that transfer to CT, maintain those 5 neuroparameters, they haven't communicated with you, but have you given a call to your friendly radiologist saying, this is the situation I have, I'm concerned about such and such, can we organize a CT? Then they will know this is an urgency, am I right?
In fact, I love you. Believe you me, you are doing a lot of job for us. And please, whenever you are referring a patient of neurotrauma to radiology, it's, believe you me, it's a race against time. And you can prevent a lot of secondary brain injury, secondary neurological injuries, when you image the patient as a whole and on a proper protocol. Please make us alert pre-hand so that patient should not wait in the waiting area. Machine should wait for the patient. That's the need.
Agreed.
We can spare other patients. We can prioritize your patient if you give a call. And after looking at the whole scenario, you can do a lot. Bleed inside, going on, progressive hemorrhage, compression effects, midline shift, herniation, you can do a lot, but after assessing radiologically. Yep. And we can give you all details about any possible 20 injuries inside. Thank you.
And Dr. Shariar, you had your hand up. Sajjad, sorry, beg your pardon. Can someone get the mic? Yeah.
Your question was... your question was about to prevent secondary brain injury. And as Dr. Saab had said, that we have to maintain adequate ICP and spinal pressure also. But the most important thing is, again, ABC. So we have to keep, we have to protect the airway as soon as possible. And the second thing is that there was a concept of hyperventilation, but we as understand that it has to be normocarbia. So, and the third thing that I want to add is that we need to make sure that the blood pressure is also maintained. Some neurosurgeons that I have interacted with, they say, oh, don't give him any sedation, we want to assess the GCS. So if not giving any sedation, you are letting the blood pressure shoot up, and they are going to not only cause secondary brain damage, but it will really kill the patient. So it is very important to, at the primary, when you see the patient, when you get the patient, you secure the airway, you make him relax, and you do the imaging, whatever you need. And after that, when the patient returns to you, then you decide what you are going to do with the blood pressure and carbon dioxide and everything.
I think
so. This is my message.
Thank you. Fantastic. Actually, that's it. I think if we were to summarize, beg your pardon, what we should do, yes, there's the medical side of aspects, of course. I think the neurosurgeons want to know the GCS to score them. You can say, I've assessed the GCS. You don't need a neurosurgeon to assess the GCS, do you? You can say the pre-intubation GCS was such and such and such. And this person has a low GCS, we need to protect it. And actually, so the communication, this is one of the reasons why I love ICU, genuinely, is because it's the one specialty that is genuinely multidisciplinary, a bit like radiology and anesthesia. So your communication begins, paramedics, you haven't got much from them. Radiologist, this is what we're concerned about. He will make sure, or she will make sure, the CT is waiting for the patient, rather than coming up with a surprise. Also, you'll be communicating with the neurosurgeon, saying, this is what I'm concerned about. That's the pre-hospital GCS, the pre-intubation GCS, and we're going to scan. And the third person is not just doctors, it's the allied healthcare staff who help us and facilitate us moving forward. So the theatre staff saying, get theatres ready, and the ICU staff saying, get an ICU bed ready. Would that be a fair comment? So it sounds like communication, if we can, as colleagues, and what's lovely seeing is that you have a radiologist in an anesthesia congress, and that is what we need to have. We've got a neurosurgeon across on video. This is exactly what we should be doing. We should come together and say, forget about blaming others. Let's sit together and say, how can we make things better? And if we lead by example, our juniors will be inspired and they will be future leaders and lead the same way. Dr. Hayat.
What's your practice regarding induced hypothermia in subjects?
Good question. I think induced hypothermia has been studied extensively in pretty much every major brain injury. There's no evidence that it works. But we don't induce hypothermia, we prevent pyrexia. So all we do is, if they're starting to get a temperature, we will actively cool them.
Normothermia.
Normothermia, absolutely. And methods, you can use whatever you want. I found that when we externally cool someone, we can be falsely reassured, because when we've put TOE probes in, the temperature outside was 37, but the core temperature was 40. They're cooking from inside. So, and again, we tend to, if I want to be really particular, especially in the burns patients, I will put a VAS cath in and I will start hemofiltration to cool them down, because that's the most efficient way. But I'm not saying that's what has to be done. Cool them by whatever means you have. Okay, yes, please.
Yeah, can I make a comment about Dr. Sajjad's...
You must.
Yes, regarding ABC. I'm talking about airway, but again, remember when you're intubating these patients, again, think of cerebral perfusion pressure. We don't have patients coming to us where we know the intracranial pressure. And so most of us, it's an assumption that their intracranial pressure is high because there'll be clinical signs depending on that.
For sure.
But if you're monitoring the mean, the MAP, then you have to maintain the MAP, keeping in mind that the ICP is high, but you don't really know how much high. So that needs to be taken care of and to be kept in mind. It should not be taken lightly as any other intubation in general surgery or any other specialty.
Completely agreed. So your neuroparameters are there because they are meant to be strict neuroparameters. If you allow them to become hypotensive, as you said, they will suffer cerebral perfusion. So completely agree. Unfortunately, there's no time to discuss the individuals in a lot of detail, but just make sure you remember those 5 things. They need to be maintained normally, within normal ranges. And of course, even during intubation, you need to make sure you don't cause surges in ICP while you're putting the laryngoscope and the tube in. And really, you can use whatever you want. I use extremely high doses of opiates. But actually, if you don't have those opiates, spraying local anesthetic onto the cord, I've seen neuroanesthetists do that. Whatever you do, think about any intervention you are making and the potential physiological impact. I think with deep regret, we have to bring it to a close. With deep regret, because this is actually a very interesting discussion, and I'd love to hear from everyone, but do you agree, Dr. Mujahid? We probably, because it's now it's nearly 20 past. I think closing comments from what I hear from our colleagues here and indeed in the group would be, ABCs are there for a reason, because they are life-threatening and they can be life-saving, and they're in that order for a reason. And communicate effectively and respectfully. Don't be that person who will call up the radiologist and say, are you a radiologist? I've received call, are you an anesthetist? Come and do your job. No, call them respectfully and say, we need your help. This is what I think we need. What do you think? Because sometimes they will have brighter ideas and say, get additional imaging. Yep.
I'm sorry, Tahir, that I've taken most of your time.
No, I like this. This is great.
But being involved in neurotrauma, I couldn't resist myself commenting. And the fact is that, once we stabilize the patient, the next question that we come across in the next few days is how to move forward. And again, the neurosurgeon, the clever person, he comes and tells, stop sedation, and we want to see the GCS. Now, that's a very tricky question for me to answer, because if I stop the sedation, then there is surges in the blood pressure and raised ICPs. So that's a thing which I really struggle to answer. So I don't know what is. Well, I do some tricks, but I'm not going to narrate.
No,
that.
I think actually no.
But I would like your opinion on that. That once you are over the woods and you are now thinking of either stopping the sedation or extubating the patient. So what is your strategy?
So I think I'll comment, but then I would like to see what our expert in the panel, Dr. Mukhtar, says, because for me to claim expertise in neurosurgery, again, would just be a fallacy. So our practice is actually exactly what the neurosurgeon says. The best assessment of someone's brain function is you talking to me and sitting up and neurologically working. Sedation and even ICPs are not sensitive. They measure pressures in one aspect of the brain. It's not quite as global as you want it to be. And all the other modalities, such as jugular bulb oxygenation, none of them are sensitive. So I actually agree. When they have managed the patient surgically, we will be stopping, thank you, we will be stopping the sedation and assessing the GCS. And based on that, we will be assessing whether they need to be resedated. You will, accepting the fact that you will have surges in ICP. If their GCS is stable, we absolutely would extubate them. If the brain injury is severe enough that the GCS, and more important than the GCS, the actual neurology is not appropriate, then this is the only situation, one of the very few, where we will consider early tracheostomies for a longer weaning. Before I get back to you, can I please ask Dr. Mukhtar across, as our expert in the panel, to provide a little comment there?
It's good to go for complete weaning, but should the sedation be continued? What we usually do is we closely follow the radiography. Unfortunately, in Pakistan setups, the radiology is not so widely available, especially not affordable by the patient's family. But if it is possible, it is a very good idea to do a CT plan before putting the patient on lower sedations. It will show you whether swelling, the edema, and the mass effects have subsided. And if that is so, or any other new developments, then you can decide whether it is good to go for lowering of the sedation for complete weaning, or as you said, for tracheostomy. Tracheostomy is a really good tool to speed up the weaning process, and that we used to practice quite frequently when I was working with Dr. Hayat. We had a very good experience with the tracheostomy.
Okay, thank you very much. I think, again, with deep regret, thank you very much for the panelists. I appreciate your time and your very, very valuable comments. Hopefully next time we have an event, and if I'm invited, we will revisit this section. And it sounds like we need to do a session prior to it about the management, but then we will see what have you done to make the system from the moment you receive them to ICU better.
Can I take 2 minutes, please, on this?
Of course.
Yeah. I'm Dr. Janzeb from Shifa International Hospital, consultant anesthesiologist. I'll summarize. I'll just take 2 minutes, really. I believe you come from London? You work in London?
No, but we're close, between London and Oxford, yes.
Somewhere in the UK.
Yeah.
So I spent my 28 years of anesthesia and intensive care training or work in UK and Ireland, and I've been here now. So I want to summarize the whole thing, actually. You know, if we look at it, I have some good message for our doctors here in Pakistan, what we call the third world. We promised so many things, actually, in our last 35 years, particularly in intensive care and anesthesia. If we talk about neuroanesthesia, hypertension and hyperventilation were the keys, where we called our neuro intensive care as hyperventilation intensive care at the stage when I was in training. We failed on that. Swan-Ganz was another one. Sepsis has been another one. We failed on so many promises that we made, and there's a positive message in that for us, that ultimately the gist of the whole discussion is that we should fix the basics first. And that should be the message for everybody here, which is a lot easier and cheaper in a country like Pakistan. The other message for all the audience here is that not everybody is a neuroanesthetist, not everybody is an intensivist. So, and not everybody works in the central tertiary hospitals. There are many people who work all over the province. And the message for them is, if you get a polytrauma or a head injury patient, traumatic brain injury, please do the basics right and transfer to a center where the services are available. And the transfer, as Dr. Saab mentioned about Imran Khan, that's the worry and that's the key. And I remember in 1990, just a quick reference to something, 1990, I was working in Dublin, and there was a DHL rider on a motorbike on the road. I stopped as well. There were a few people. I approached the guy, the injured guy, who was lying down on his face with a helmet, and about 10 people around stopped me from going near him. And that was the level of awareness in that society. So I'm coming to your basic question, and I said, don't worry, I'm a doctor. All I want to do is to talk to him. And I said to him, are you okay? And he said, I'm okay. By the time we were there, nobody touched, nobody twisted and turned the patient or the injured guy around. The ambulance came, and he was safely taken to the hospital. That's the key as well. So awareness in the society, awareness among us. We should not be complaining that I do not have an intracranial pressure monitor in Swat or Mardan or Bajawar. Just do the basics right. And if we get those basics right, and I remember actually one of our professors in London who was actually managing intensive care for 30 years, I'm forgetting his name, attended the Hot Topics Day, and he managed the 3 hospitals, Great Ormond Street, King's, and St. Thomas's as a professor. And all the studies, all the publications that he had all over those 30 years, and his message, his last slide, is a message for all of us that in the end, if you want to get your patient better, please keep the heart rate within the normal limits. Keep the blood pressure within the normal limits. Keep the saturation within the normal limits. Keep the CO2 within the normal limits. Keep the temperature within the normal limits. I mean, a professor who worked for 30 years on intensive care and ultimately comes to this conclusion that please, if you do that, and particularly it applies to us in Pakistan, in this province, that if you, as a first kind of responder, if you do the basics right, you have won the day, transfer the patient to the right place.
Okay, I think we're all saying the same thing, aren't we?
That I would say there is always place for improvement, but in many ways in intensive care and anesthesia, we have completed the loop, we have completed the circle we come to the basics, and we should not fail on human level as well.
Okay.
I
think,
you very much.
Thank you very much. Thank you very much.
Yeah.
It's very wise words. Thank you very much. So essentially, you're saying exactly what we said earlier. We're all in agreement. Hopefully, next time things will be better. I think we have to put this to a closing because my colleagues who are across in UK is 8 a.m. and they have taken time out, and I want them to start signing up to our next session. So thank you very much, everyone. You do your closing.
शील्ड अभी इसके बाद देंगे.
Thank you all for your valuable insight on the neurotrauma management, and thank you all for your patience. Now we move forward to the second session, which is on the modernization of anesthesia training. The panelists for the second session include Dr. Muhammad Hayat, Dr. Samina Ismail, Dr. Gohar Afshan, Dr. Philip Dagalbai, and Dr. Aliki Manaras. Just a little brief intro of the panelists. Dr. Muhammad Hayat is a consultant anesthesiologist at Northwest General Hospital, Peshawar, and an assistant professor of anesthesia at Northwest School of Medicine. He has a 7 years post-fellowship experience in the surgical critical care anesthesia. Moving on to the next panelist, Dr. Gohar Afshan is an endowed professor. Okay. I'm just introducing the panelist. Yeah. Welcome, Dr. Gohar Afshan. She's an endowed professor of anesthesia section, head of pain medicine, and former chair, Department of Anesthesiology at Aga Khan University, Pakistan. She established her first pain setup at Aga Khan University, followed by first pain fellowship program in Pakistan. Moving on to the third panelist, Dr. Samina Ismail holds the position of professor at the Department of Anesthesiology and Intensive Care, Aga Khan University, Karachi. She is currently section head of obstetric anesthesia and also heading anesthesia obstetric research group. Welcome, ma'am. And Dr. Philip Dagalbai and Dr. Aliki Manaras will be joining us through connectivity online.
There will be changes, so I will introduce the changed panel.
Okay, sir. Okay. Once again, I would request Dr. Tahir Ali, please, the moderator for the session, to come up on the stage and take over the session. Sir, please, over to you.
Thank you very much for the introduction, and I have to be honest, so welcome Alex, good to see you, and welcome everyone else here. So I think I have to admit fault here. I did the maths very wrong, because normally I'm used to converting time from UK to Pakistan, and I add 5 hours. So I did that, and everyone assumed it's later, 5 p.m. So it actually turned out to be a lot earlier, where a lot of them have school runs for children or are actually at work. So in terms of the panelists that hopefully will arrive, Dr. Duggleby, he may not be able to arrive because of his child is unwell. And his wife, who's our registrar, and a fantastic registrar, who is on nights. There may be a bit of difficulty. Dr. Aliki Manaras has just gone to get a cup of tea, and she hopefully will be joining us. Another very, very close and esteemed colleague of mine, a consultant in intensive care medicine and in anesthesia as well, and her special interest is spinal injuries. Dr. Duggleby, he's a very high flyer. He's also a intensive care specialist, anesthetist. He runs our follow-up clinic, which I have to say has just got better every month through his leadership. He's also our training program director for intensive care medicine for our region. And also, there's no point us talking as consultants What's very important, equally important, or in many ways more important, is to have the views of the trainees who are actively in the system. So Dr. Alexandra Edwards, we have been colleagues. She's been my SHO previously, and now our registrar, and has even she's completed a point of care ultrasound fellowship with us. So, and hopefully in the future she will be joining us as a consultant colleague. So we have a long history of knowing our trainees from a very young age, so to speak. And finally, Dr. Ifor Capel may be joining us. He's texted. He is a intensive care. He's now a consultant. Literally in the last few weeks, he's completed his CCT program, and he's an intensive care and acute medicine specialist, not anesthetist. However, he has gone through the entire training, and so again, having his perspective would be valuable. Alex, can I just ask you to give E4 and Aliki a call and see what they're doing? Thanks. Okay, so the purpose behind this, I don't want to bother projecting the PowerPoint, because the PowerPoint are just sort of guides related to the topics we're going to discuss. And we've titled it Modernizing the Medical Education and Training, or modernizing or improving the education system, because no one can claim that the system in one place is perfect. There will always be flaws. And some may feel theirs is perfect. I am definitely not going to stand here and claim that is the case. So the whole idea behind this is to gain experiences from our trainees, from our consultants, from our educationists, such as myself and Dr. Duggleby, and your colleagues as well, your consultants here. So I think we will just pause for a minute, and I will just find out one piece of information, and then we'll get cracking. Sorry about that. Okay, there, you can hear me now. So they're going to get cracking. So I think we'll just start firing off now and getting on with it. So I think because our training systems are quite different, we have, I will just summarize ours. We have a 2-year, in summary, a 2-year. In fact, Alex, do you want to quickly summarize our anesthesia training in a few lines? Thank you. Oh, we can't hear you. Your mic's off. Alex, your mic's off. There we are.
So firstly, at the point of entry into anaesthetic training, you decide whether you're going to take what we call the core training route or the ACCS route. Essentially, if you do the core training in anaesthesia, now you do 3 years of core training, followed by 4 years of 2 years of intermediate training and 2 years of higher training. If you enter in the ACS route, and you choose anaesthetic as your main STEM, then you end up doing a year of general medicine, a year of emergency medicine, and a year of anaesthetics, followed by a second year of anaesthetics before you start your registrar training. And the point you start your registrar training, the paths meet, and the training program is the same.
Okay, fantastic. So essentially, it is rough. It is at least 7 years. It's an at least 7-year program. Most of us, all of us, will do a fellowship of some sort in the middle, and before progressing from a core trainee, which is the new word for SHO, and now the newer word is stage 1, before progressing from stage 1 to 2, you have to sit your FRCA exams. And in intensive care, you have to sit your FFICM primary exam. The exit exams need to be sit in the next 3 years while you're a registrar, and you're not allowed to progress to senior registrar without. So the exams are very brutal, very robust, but there is a structured system, and also we've got what we call a spiral learning. So what that means is that essentially you do all the specialties at the start as an SHO, and you keep revisiting them as an intermediate trainee, and then as a higher trainee you pick a specific specialty. And that will involve all areas of anesthesia, including intensive care medicine, pain medicine, obstetric anesthesia, pediatric anesthesia, neuro anesthesia, and intensive care and cardiothoracic anesthesia. So these are mandatory. And anyone who wants to pursue a specific interest in one of those subspecialties, they have to take on additional fellowship. Welcome, Dr. Manoras. Thank you for joining us very early. Very good. So this is my colleague I mentioned. She's our consultant. Okay. Now, Dr. Hayat, if I can pass it to you, and you tell us the differences, and then I'll pass it to our colleague next to you, who will tell us the differences even within Pakistan, how drastic they are in terms of the training program. Thank you.
Thank you very much for providing us with this opportunity. We have got 2 different programs. One is from CPSP, which is a 4-year diploma, fellowship in anesthesiology, and another one is 2 years membership in from College of Physician and Surgeon. Other than that, we have got a diploma in anesthesiology, which is also a 2-year training program. All of these programs can be done after getting the basic medical degree. In admission in the DA or MS is without any entrance exam, and in MCPS as well. While in fellowship, you need to have part 1 exam of the FCPS to get enrolled to a training. And after this basic fellowship, we have some super fellowships in cardiothoracic anesthesia, critical care, chronic pain, and obstetric anesthesia, which are usually 2 years training program. These are the available training programs across the Pakistan. In Peshawar, talking about the training programs, we have got 6 teaching hospitals, which consist of almost 6,000 beds, amongst which 4,500 beds are in the public sector, and 1/3 are in the private sector. And the highest trained people who have got the 4-year training in anesthesia, they are almost 27, 28, and the deficiency is being completed by the promoting the MCPS and DAs to the consultant positions. And regarding trainings, difference in training from where I was trained, there are some gross differences in training structure and the training patterns in public and the private sectors, which I won't go into detail because that would be too lengthy. Thank you.
I think so when you say Peshawar, just for our, or could you please, E4 Capella is joining. Could you click and allow? There we are. Okay, so I think we just for them to understand, Pakistan has 4 provinces. The further down south ones are the more developed one medically and economically. I think that's a fair comment to say. And we in this site are probably a little bit behind compared to the others, which is why we've got people, consultants in the panel from both ends. So if you don't mind talking us through your training scheme.
Actually, in Pakistan, overall, there is one program, like FCPS, that is from the College of Surgeon and Physician, I think that is common for all of us, for all the provinces. It's the same, the training, the structure training program that we are all over from Pakistan, from south or the north. We do the same fellowship examination from the College of Surgeon and Physician. So the problem basically is the different types of the training that is being delivered. Okay, Hayat, I think, is going to highlight the problem that he faces in his institution and like the different localities. Like what we do, we had the requirement is 4 years, but initially in my institution, which is a private university hospital, Aga Khan, and Gohar is also from there, and she can highlight more. So we initially had a five-year program, but now we have a 4-year structured training program. And we have 3 exams, like the exam, the part 1 is given before you join it's an entrance test, you give it before you enter this 4-year residency program, and then there is intermediate module and the final part 2, which is an exit exam for then you get this FCPS degree. Now the trainees are being rotated according to the specification of the College of Surgeon and Physician and according to the infrastructure present in the individual university. So we have very structured rotations of obstetric, neuroanesthesia, pediatric, according to the level of the resident, according to requirement by the CPSP, according to our service commitment. And then we train for the initial 2 years, and then the resident is allowed to give the intermediate module, and then we train further, and then the resident go and finally complete his period and then give his FCPS part 2. And then of course we have fellowship program that is mostly done after you do your basic FCPS, which is in pain, cardiac, obstetric anesthesia. So this is the basic training program that we follow in our institution.
And can I ask, do you have a set curriculum?
Yes, we do have.
You do. Dr. Harth, do you have a set curriculum?
Yes, from CPSP, yes, we do have a set curriculum.
In your province?
Set rotations, sets of rotation before the intermediate module exam and after the intermediate module exam. But unfortunately, I would say, that pattern, that rotation is not followed in many of our training institutes.
Right, interesting. And I think it sounds very much like there is a curriculum. Who dictates that curriculum? Is it the College of Surgeons?
College of Physicians and Surgeons. The anesthesia faculty over there in College of Physicians and Surgeons, most of our esteemed guests are members of that committee. They decide the curriculum.
Yes, please. If Dr. Gohar, if you can answer, that would be great. Thank you.
And I would just like to highlight again what Dr. Samina and Dr. Hayat has already said. So we were talking about our national program, which is the Fellow of College of Physicians and Surgeons in Pakistan. And this is a 4-year program, which is a national program, and all the affiliate centers should follow the curriculum, the assessment methodology, the work-based assessment, the formative summative assessment is the same across the country. And fortunately, this movement, if you just see the data, because our program is 50-year-old, we started the first program in 1972 and now we are in 2022. So in 50 years, we have passed out almost 1,200 high diploma, which is a 4-year program, and we are still continuing our minor diploma, which is a 2-year program, because of the need basis of some of our rural areas. But we prefer, as a habit of anesthesia, to continue as a 4-year program to run the academic center, maybe the tertiary center, and the basic urban area requirement. But we are afraid that we cannot stop the 2-year program in the next coming years because of the need of our country and the many rural areas of the Pakistan. Secondly, because you just mentioned that Pakistan has 4 provinces, now Pakistan has 5 provinces.
Oh,
now
okay.
you know that the 5th province, we need to struggle for that again to begin with the 2-year diploma program. Our program is basically a competency model of 5 components. And it is we started from the knowledge and clinical reasoning, then technical skills, the communication skills, then we really emphasize on the teamwork, because it all, in the current pedagogy of this medical education, this competency-based model is very, very important. And additional component, which is because this is an area of my interest, and I found very few programs across the globe where the training go through some kind of a research, and in our curriculum, one mandatory research. This is must for a trainee to go through the 4-year program, and currently we have a number of published anesthesia research is based on their trainee research actually.
Okay.
So these 5 competency models, the research is also included. They are basically the strength of our program.
Okay.
You talk about the curriculum, and certainly we have at CPSP, at our national college, we have a faculty of anesthesia having the representation from south to west from all 5 provinces. And there's one dean and one secretary of anesthesia, which rotate after 3 to 5 years. And in every exam, they expect, the CPSC expect the faculty that they review the curriculum periodically in 5 years' time, and then the methodology, then formative and summative assessment, and anything which is according to the international guidelines. So we have been doing regularly. We have a very robust online system, and every supervisor and trainee has their own portal, and we are giving very regular feedback about the trainee feedback to the CPSP, to what is happening with the trainee, and the vice versa. The trainee is also giving the feedback about the rotation, about the law cases. So this online portal system is, we believe that this comprehensive program actually is, this online system gives strength to this program. Everything is available. If you just go to the online site, you'll find all the details of what we expect from the trainee, what are objectives for the 4-year program, how the person rotates from 1 year to 4 years, and how the in place is set up, for example, the issue which is we are facing right now in a formative assessment, and which I would like to ask my other panelists, because this is the issue which we are facing.
We're going to discuss that. We're going to discuss the assessments. I thought we deal with bits sort of in chunks, in bite-sized chunks. Okay.
So that is the issue. Otherwise, everything is according to, it is available online, and the training is supposed to follow all these curriculum according to that.
Okay, thank you. So
right now, 1,000 accredited centers for training.
So what I got from that is that you've got the system, and that's in Karachi. You've got you've got a national system, you've got a national curriculum, you've got a national learning methodology, but it seems like down this end, the implementation of it is not as robust as it is in your centers. Is that the message I got?
The curriculum is there, like implementation would vary according to the institution.
So we don't mandate. Well, we do mandate it, but each institution does not necessarily follow the structure as robustly as you do. I will come to you at the end. I want to move now, actually, because we've talked about what we have and what you have in Karachi and what you have here. I actually want to hear from who are currently trainees in anesthesia in the audience here. Excellent. Right. Do you mind handing the mic, please? Yep. Have the mic ready to go, please. Okay. Hand the mic, and can you tell us, as a trainee, what are your, don't have to say all of them, what challenges do you face as a trainee in achieving your curriculum, knowing your curriculum, and also a second question, how much emphasis, don't have to mention your institution name, is placed on exams, and how much is placed on the additional very important aspects of medicine, which is communication skills, team working, human factors, and so on. Please, and introduce yourself.
My name is Dr. Laila Habib, and I'm second year trainee FCPS in Peshawar. So it is sad to tell you that we have, okay.
Just louder.
Okay. I am the only one in the trainees who wants to follow the curriculum. So I was the one who took the curriculum to my department, and I wanted to tell them that I want to follow it because I am very passionate about my field. So what happened that they said, okay, to whichever OT you want to go, we will let you go. But at the end, they always send me to some other OTs which I have already done, and they will say that we have a shortage of staff, we have shortage of doctors, so we cannot let you follow the curriculum as you want to. So that is the problem I face. And regarding the exams, we have very less APs in every OT. Not every OT is supervised by an assistant professor or a senior consultant due to shortage of the consultants. So most of the time, we are alone in the OT, and we are not guided by our seniors. So that is the challenge that I face, and we have to call to some other consultant.
Bahar, there's a lot of noise outside. Tell them to stop, please. Okay, thank you. That's actually very, very, very interesting. So you're saying opportunities are there, but you don't necessarily get them because of potentially short staffing, and also even if you get those opportunities, you don't have a mentor to supervise you and guide you through the best practice. You may have to sometimes just wing it and learn it on your own. Is that a fair comment? That's very, very useful, very interesting. Now, just to take that across to the other end of the world, E4, welcome, as usual, fashionably late and very serious looking. Tell us, since you have just gone through your training and completed them, what challenges did you face in our system over there? There may be none, there may be a lot. Be honest, it's all fine.
I don't think there were many large or systematic challenges that I had to overcome in my training, and the pathway is reasonably structured. So I've just come to get my training as a medic intensivist, so I suppose the only major barrier that I had to overcome was getting into intensive care with a non-anaesthetic background. And I think in fairness to the training pathway, the training programme, it's become quite structured, allowing routes of entry at registrar level, so towards the latter half of your training as a sort of more senior clinician, for a variety of portals of entry into intensive care training. So ED physicians, medics, and anaesthetists can all become intensivists. It just requires a period of structured anaesthetic time to ensure that you'll be able to competencies to practice safely. In terms of some of the issues that have been mentioned thus far today, I don't think I've faced anything like that in our training programme at all. It's all been reasonably sensible in terms of it's been very clear to me throughout that we were following the curriculum. It's been very clear to me throughout what I needed to achieve and do in order to achieve my competencies at every year's annual review.
Okay, thank you. That's good to hear, but I can tell you it was not always, our training system was not always that good. Everything evolves and gets better, and I think the evolution has definitely improved it through feedback from trainees, because just like our trainee in the audience over here who expressed her challenges, if we don't address the challenges, then it will just never get better. And then I will take this to Alex, because obviously you're currently in training. Your feelings of having a extremely super structured training program, challenges you've faced, or what you like about it? Yeah, muted.
Time that I've been a trainee, our curriculum changed quite drastically. We went from a very modular-based curriculum where we had to get modules signed off in pain, orthopedics, general surgery, and sometimes it was quite difficult due to it being so specific to get all of those signed off before you reach that end of the stage of training. It's now moved to a more generic approach where it's split up into 7 generic professional competencies and 7 specific skill-based competencies, which is a lot more generalised approach to our curriculum, and it does make it a lot easier to get the opportunities and get each aspect signed off without being too structured. So that's been, I think, a real positive change. I think I think there's a lot of support in our system for training. We do follow a very strict curriculum, but all the consultants I work with are aware of the curriculum and what needs to be required to meet those specifications. I think that is certainly very helpful. We have educational supervisors which change every year, and we meet with them regularly to make sure that we're achieving what we need to achieve. And there's a very clear process for speaking to our risk coordinators about how we can allocate to lists to ensure we are achieving all the requirements.
Thank you. I think that actually blends itself quite well into my next section, because obviously there's so much to cover here, but I want to hear what people have to say, and the whole purpose behind this is how can we, across the other end of the world, with people who are interested in education, help not tell you what to do, but work together, collaborate with you to bring positive changes. So the next question is, and it may be a bit controversial, so don't throw anything at me. Can all consultants and heads of departments be trainers and supervisors, and should they be? Now, hands up, anyone who feels, anyone who's a consultant, HOD or professor, can and should be able to be a efficient and effective supervisor. Interesting. Okay, so no hands up. That's very interesting. And I'm actually going to ask the question back from Dr. Kapel. Sorry, it's very formal here. So, do you feel in UK every consultant can be a supervisor and trainer, an educator, and if yes, why, and if no, why? Because I'm interested to hear your views as well.
Even if sometimes what you're learning is potentially ways that you wouldn't wish to handle certain situations, and that's either professionally, clinically, or non-clinically. But everybody and everyone in the audience will be able to respect that we all have our own set of skills and abilities, and not everyone is an excellent educator. I mean, we don't all have parts to play within service, and it doesn't mean we all have parts to play within medicine. There are consultant colleagues with whom I've worked, and there are consultant colleagues who do not have any training responsibilities. That is because often by their own admission, they don't enjoy and are not good at education. And assigning trainees to work with those colleagues leads to a poor experience for everyone. The trainees don't get trained, everyone's a bit grumpy, that ends up affecting the patients at the end of the day. That doesn't mean that that consultant colleague is a less able colleague. That doesn't mean that consultant colleague is a poor colleague. That means that you just want to use the skills that they have. You know, that old adage that if you ask a fish to climb a tree, it'll think it's an idiot for the rest of its life. You know, everyone has an ability that it's good at. If you ask the fish to swim, it'll be really good at it. And if you ask the monkey to climb a tree, it'll be really good at it. But if you ask the monkey to swim, it doesn't really work. It's exactly the same thing with education. Some people are good at education, and the people that are good educators, and Dr. Ali, you are a very good educator, the people that are interested in it and are good at it should be encouraged to do more of it.
Thank you. And actually, do you mind telling me what systems do you have in place in your institution to ensure that the trainees are mentored, not just the teaching, because anyone can teach a topic. It's the actual longitudinal mentorship and the pastoral support and the facilitating trainees through their training. How do you do that, and do you think it can be better or not?
Okay, before telling you about my institution, from the College of Surgeon and Physician, every trainee has been assigned a supervisor. Okay, so he's a sort of a mentor and a supervisor. Like as Dr. Gohar mentioned, the resident has to complete the research project. So he's supervising the resident for the research project, and he's a sort of a mentor. In my institution, we have a program like such that we have a residency director. Okay, he looks after the administrative affair. He liaisons with the educational group, the education committee, to make sure that there is a proper curriculum, the rotation of the resident. So this is the more administrative work. The residents are rotated in the right rotations according to the guidance from the College of Surgeon and Physician. So he works holistically for the administrative affair. Then there has then every resident is assigned a supervisor, who is actually a supervisor registered with the College of Surgeon and Physician. Now that supervisor is supposed to be a mentor and supposed to guide the resident in all the personal problems as well, and the dissertation and the research project that the resident is continuing. But I don't know how I would say that every supervisor is fulfilling the role of a mentor or just supervising the resident for the research project that is supposed to be handled according to the College of Surgeon Physician. So in my opinion, if you think that the way forward should be that every resident should be provided a mentor as well. And I think the trainee himself or herself should be able to choose the old mentor. Now, in our hospital, we have a mentorship program also. Dr. Fawzia used to be used to chair, and I used to be there in the committee. So it's mostly it's for the junior consultant, but I think such sort of a mentorship program should be there for the resident as well, where they can choose their own mentor. If the supervisor is too busy to not being able to play the dual role of supervising the research project and acting as a mentor. So this is the program that we have in our university.
Okay, I think allowing them to choose, it sort of opens a can of worms in that you may find 2 or 3 people being chosen by everyone and others not. So we actually, the way we do it, we have a list of qualified mentors and supervisors, and actually ones that are interested in doing it, and we allocate them.
Do have the list of
Sure. Dr. Manoris has got her hand up. Do you want to get in there and comment? Because then I'll take it from the audience over here. Thank you. You are muted. You are muted. You are muted. You are muted. Oh, you need to speak up. Oh, we can hear you now. You just need to really speak up. Yeah.
Okay. No, thank you for inviting me, obviously, on the panel. I'm really sorry I have to rush off to go and join the ICU handover. But I just wanted to kind of add my experience. So I'm probably the older trainee than E4 and a couple of the others on the panel. And I did do the old style training. And unfortunately, in my training, I was I had the educational supervisor that essentially, as we discussed, probably shouldn't have been doing it, wasn't really engaged or aware of all the, the kind of aspects that I had to provide as a trainee. So it made me very self-directed as a trainee. But I think as a result of it, I do agree that not all consultants essentially should be supervising training, because there's an engagement, I think, and I think that's your expertise. I think it's important to tap into those qualities. I think we all are educators when we have training with us, and we should be able to impart our experience to shape, training experiences and give them that experience. But I just wanted to, give my experience because I saw sort of both sides of it essentially.
Thank you. That's very useful, Dr. Minoris. Can I just ask, are there any courses where educators and supervisors and mentors can go on to teach them how to mentor and supervise here in the country?
Actually, we from the every supervisor before becoming a supervisor has to undergo a whole set of workshops. This is called supervisory workshop, and he or she has to complete that workshop in order to be designated as a supervisor. So we do have the mandatory requirement of becoming a supervisor to attend these, I think 4 or 5 workshops are there. 4 workshops.
In addition to that, after doing the residency and completing the fellowship, one has to complete 5 years to become a supervisor, along with a submission of MCQs, which are as per CPSP's requirement, which is the College of Physician and Surgeon. And along with that, there has to be a completion of the...
So at least you will take, I think, 7-8 years to become a supervisor after you complete your postgraduate examination.
I am Dr. Khalid Bashir. I am Dean of the Faculty of Anesthesiology, CPSP. May I ask a question? Do you have same standard of training in across the whole UK?
I mean, for me to be able to answer that question, it would be impossible, because...
So the same is the case in us.
Of course.
We have different standards in different areas.
Yeah.
Okay? It depends on the supervisor and plus the workload which they are facing. Okay? Then the question you asked was eligibility of to become supervisor. That said that there are criteria. Minimum is 5 years post-fellowship posting and attendance of 5 mandatory workshops, which include communication skills, supervisor or assessment, and presentation writing. We have 5 ALS, ACLS, and BLS. So a person who wishes to become supervisor, he has to spend at least 5 years after FCPS in a teaching hospital and attending these 5 workshops. Okay, and the standard varies from person to person and area, station to station.
But that's actually, you've lent yourself quite well into the next section in terms of standards vary, we know this.
Hello.
Someone having, oh yeah, please, sorry.
I'm Dr. Nasreen Laik. I would like to comment on the objection raised by the Dr. Leila. She is right, to some extent she is right, because we as a supervisor have to face a lot of problems in our teaching hospital. I would like to discuss my hospital. For example, I am working in Lady Reading Hospital. It is one of the biggest hospital, I think, in the whole country. It is 2,300 bedded hospital, and we are having 85 operation theaters running at a time. And these 85 tables are divided in almost on 15 ORs. They are scattered. These ORs are scattered all over the hospital. And at a time, one anesthetist can't control 2 OTs at a time. You have to be in the one OR or in the one operation theater at a time. Regarding this workload, we have to have at least 15 supervisors, at least. And unfortunately, we are only 2 supervisors in the whole of the Lady Reading Hospital.
Wow, okay.
And I think Dr. Gohar will agree with us that only one supervisor can take only 8 trainees at a time.
Yeah.
So we are having only 16 FCPS trainees. And if we divide it on all the OTs, it is impossible to divide it on the whole OTs. She is right to some extent, but they are rotated in all of the ORs, but not according to the CPSP protocol. My suggestion and my recommendation is there must be more supervisors, or the CPSP must allow at least double of that trainees to one supervisor, or at least the MCPS level must be upgraded to be supervisor, so we can take more of our trainees in teaching hospitals.
I think that
These
that's
are some of the problems and we have to face.
And of course, I think what we have over there is we're quite a lot of luxuries where we have now a lot of supervisors who will get straight to you next. Yeah, so I completely agree. And of course, the challenge is having 2 supervisors supervising all those theatres. It's not sustainable. But hopefully, this is a forum where all the young trainees here, younger ones, will be inspired to be supervised and be interested in mentoring and educating and actually making the experience of future trainees better, because it starts by inspiring people, hopefully. Carry on.
Thank you very much. So one thing which I want to bring to the discussion is that one of the problem in training is that the hospitals have to balance service delivery with training. So trainee, in addition of learning, also has to provide service. So my thought process is that what is the incentive for the hospital to train? I think that is the way in which we can improve that. For a trainee, the incentive is that he wants to complete the training, he wants to pass the exam, and he wants to become a consultant. But for the hospital, I think the bigger pressure is service delivery. So we can learn from an example in your setup, or how can we incentivize hospitals or departments to engage in training more? That's what I want.
Bigger question. Patient safety. By providing good quality supervisors, more available supervisors, that will impact on patient safety. So that should be the hospital's prime responsibility, and then service provision. Because if you ensure patient safety and you put in place processes to mandate everyone in the room, from the porter to the cleaner to the HOD, to feel accountable for every patient, and then everyone will want to make the system better. So patient safety should come above all of that. I think, again, as I said, I'm not here to say you should adopt the same model. Actually, I'm learning a lot about your process, and I'm sure Dr. Capel and Dr. Edwards, and neither of them are saying you should adopt. Your number of supervisors are a lot fewer. And that's sort of discussed. So next point, because I think in terms of time we're coming close. To go back to you, Dr. Hayath, the implementation, how do you, in your institution, or assess progress of trainees, and also just question from trainees, do the trainees have representatives and a voice where they can go to the HOD and say, we need something extra here, we need some additional help? Because you're all adults, you need to take responsibility as well and direct your learning and what you require. Most of the changes in our department are because people like Alex and E4 have wanted those changes, and we've even introduced education supervisor training for trainees in their senior year. So E4 Capel was one of them, where he was supervising and mentoring, not necessarily in theatres, we're talking about mentoring their training whilst in our department. And I comfortably say we were probably, E4, were we the first one to do that in the region? Probably not. Oh, okay, good. So encouraging others. I'll come to you. I think I want to hear from Dr. Hayat. How do we assess progress? And I don't want to hear exams. I mean, outside exams, how do you assess progress?
I work in a Northern General Hospital, and we assess our trainees by arranging talks every 6 monthly and giving them multiple choice questions. 6 months. This is how I was trained, and I somehow try to implement it in my institution. I have got, our hospital have got 5 fellowship trainees and 1 membership trainee, and other than that, we arrange general clubs and 1 weekly class for them on physiology and assess. So that's the only thing, an assessment that we do every 6 months.
Okay, that's interesting. And I'll just tell you a little bit. I'm a lot older than E4 and a hell of a lot older than Alex. I was at the year of, I don't know if you heard about MMC, Modernizing Medical Training or Curriculum, where we went entirely to a very, very rigid competency-based system where we had to do, we had to submit forms related to procedures, related to clinical encounters, communication, and then we also had to have what we call case-based discussions where we discuss an incident or a case and then learn from it and learning outcome. It's not an exam, it's more of a discussion. And we were very much against that at the start. We said that we are adding a tick box exercise, and indeed, a lot of the supervisors and trainers who had not been trained in how to use these forms were just saying, yeah, it's fine, tick, tick, tick. It was used as a tick box exercise, so we were very much against it. But over time, it's been ingrained into our culture, and a lot of us in my generation, we actually used it as an opportunity to guide our learning. So yes, there were minimum forms that will need to be done in each module, but we thought, I said, I want to get more interscaling blocks, for example. So I would take that to my super, and I understand it's not the same, and I can't, and you need to provide a service. And likewise, we had to provide a service, and I can tell you for sure in the audience, the number of times I was taken out of elective lists to go into emergencies, out of elective lists to go onto ICU, and to go home and come back as a night, I've lost count. We've tried to limit that now, but we use the workplace assessments looking at, I want to do these procedures, or I want to manage these sort of cases, and we directed our learning and used those forms in a slightly more positive manner. So, yeah, hands up. So hands up from Dr. Gohar first, please.
Dr. Gohar, please.
So 3 quick points. So first thing you were talking about, because at that time somehow it was missed my comment. So about the who should be the supervisor. So the system in Pakistan is different from the UK, because majority of our institutional accredited centers, the faculty must have some kind of academic title, assistant professor, associate professor, and professor, and we expect that if somebody is holding an academic title, they must participate in UG and PG programs. So they don't have option. They don't have an option to say, no, I'm a university faculty, but I would not like to participate. So to us, supervisorship is the kind of mandatory work of any university faculty or academic institution associated with the affiliated training center, first thing. Secondly, you're talking about difference in the training programs across the world, even the highest program in title in America and in New Zealand and Canada, so there is a variation. And the people start this resolution for that variation is differently. In Pakistan and CPSA, we add 1 intermediate exam. And this intermediate exam after 2 years, because we really want that everyone should be in between, should be at the same level. Although we cannot guarantee that everyone at the time of exit exam will be the same, but we try putting up intermediate exam after 2 years before the exit exam is after 5 years or after 4 years may have some problem. And then we added this, what we were talking about, the work-based risk assessment, the mini CAS and the DOS, which is actually a challenge for us because majority of the center, the faculty said, as Dr. Masri just mentioned about, a lot of service workload would not allow a direct supervision for dogs and the mini CAS activity. But that is a challenge that we have already implemented, and I'm pretty sure that coming years we will be able to solve this issue of in-place exam training.
Thank you. I think with people like yourself and those in the panel, this will be very easy. Dr. Hayat, you had something to say? Did she say it for you? Okay.
Dr.
All right.
Now, answer the question.
And again, as I said, we're going to conclude on this one because there's a lot more to discuss, but there's never enough time for this. I want to turn this around to our trainees. Your feelings about workplace assessments and its use, and what are your feelings about them? We'll go for Alex first, please.
We're very lucky with our workplace assessments. I would be expecting to send at least 1 or 2 of these off to a consultant every shift I do, and that's really, and a lot of the way it's done is that we do the work for the workplace assessment, so we fill in all the details. So it's a matter of our supervisors just confirming that they agree with everything that we've written, and it does give them an opportunity to write some feedback as well. But I think that can often be a limiting factor for consultants who are understandably very busy if they're getting lots and lots of work-based assessments and having to enter a lot of information for it. So I think the system needs to be set up so it's as easy as possible, and the work staff need for trainees to take on that workload. I think obviously we have a range of different assessments, and then it's up to the trainee about to match what they send off to the curriculum. And as we said, our curriculum is quite rigid, and it does require a lot of evidence and work-based assessments to be uploaded to our portfolios. And that all gets reviewed at the end of the year alongside our multi-source feedback, is where we get feedback from our colleagues about us, not just our skills, but also our professional capabilities and our interaction with patients. And then we also have assessments where we have to show that we've been involved in research and quality improvement, and that's all assessed at the end of the year.
So it reflects what Dr. Gohar said across there, which is we also have to have a set exam because we have to achieve a minimum standard of knowledge. I mean, that's across the board. So, yes, please.
I just tell about the assessment. I don't know. We have a very robust system of assessment. like residents go through every rotation. Every rotation have a continuous evaluation. Like if he's rotating in pediatrics, anesthesia or ICU, there's a continuous evaluation. There is a viva. After each rotation, there's a continuous evaluation, there's a viva. Then biannually, every 6 months, there is a test that every resident go through. There is OSCE, and then the whole each resident continuous evaluation, viva, test, OSCE is discussed in the faculty. Among faculty, then every faculty give their opinion. That comments are taken by the residency director, and then the residency director 6 monthly have face-to-face discussion with the resident, telling, look, like you have been missing out this thing and what needs to be done. So our system of assessment and feedback is very robust, and we go like this. So I just wanted to share our system.
So I think we can conclude there that the points we've learned is that obviously we know the system is different across the country, but more importantly, the system is different and is quite significantly different between North and South. There are clearly enthusiasts here who want to try and make the whole system across the country very similar and more robust, and there are clearly trainees in the audience who want to have a good training system and hopefully will be future supervisors and mentors, and you put people through a mentorship program. Potentially there's something we can learn from that. Workplace assessments, either using it as a tick box exercise, but if trainees are given a bit more autonomy on how to use them, then they will use them as slightly more effectively. And I think there's so many other things to discuss, but there is no time, and we started a little bit late. So I think we're going to have to conclude there. I probably can't take any more questions from the audience. I want to thank all the panelists, and we will be exploring aspects of this in the team building session later in the afternoon. That's going to be a very open discussion with all of the audience actively taking part. So we're going to be discussing something very close to my heart, human factors and mentoring. So we're going to discuss that in a fair amount of detail rather than lecture. So thank you, Dr. Khushal. Thank you, Dr. Samina and Dr. Hart. And thank you very much, Dr. Edwards and Dr. Capel. Don't need to look so serious. Well done. Thank you for having us, and thank you for giving us your time. Well done.
Okay. Hello. Hello. Thank you so much, Dr. Tahir Ali, for some nice session. Thank you, everyone, the moderators, the audience, for making this event successful. I would like again, Dr. Tahir Ali, to quickly present the shields to our panelists. Dr. Tahir Ali, please, sir, can you come on stage? Dr. Fatima.
I would like to come each of the panelists to receive their shields. Madam, please, Dr. Samina Ismail. Dr. Muhammad Hayat. Sir, please. Madam Fozia Anis, please. Dr. Javed Khan. Dr. Hamidullah, please, sir. Thank you so much. And Dr. Javed. Okay. Please, sir. Thank you, everyone. Thank you, Dr. Tahir. And lastly, Dr. Tahir will be presented a shield by Madam Dr. Nasreen Laik, please. Thank you to the audience for your patience. It was really an engaging session. The lunch is being served. You're all pleased attend the lunch, and would like to have you all for the next session. Thank you.
start करूं? Bismillahirrahmanirrahim. Honorable Chief Guest, delegates, participants and members, Assalamu alaikum. A warm and pleasant afternoon to all of those who are present here today. I, Dr. Sara Rahim,
and I, Dr. Shahriyar Khan,
are your hosts for today. It gives us immense pleasure to welcome you all to the 3rd Annual Congress of Anesthesiologists Peshawar. This conference aims to serve as a platform for new ideas and concepts. This is not only a good opportunity to present, but even a better way to learn from the work of others and to set future plans in the field of anesthesia. This session would be chaired by Dr. Khalid Bashir, Dr. Liaquat Ali, and Dr. Salman Salim. The titles of today's presentation is Pain Management, and we shall have a total of 6 presenters. Before we begin, I would like to highlight a few rules. The maximum time for each speaker is 18 minutes, and each speaker is requested to follow the time limit strictly. The first time reminder bell shall be rung at 12 minutes, second at 15 minutes, and the third conclusion bell at 18 minutes. Audience are requested to note down any questions or queries with themselves. At the end of each presentation, there will be a question-answer session for 10 minutes, and no one shall be allowed to raise their hands during presentation to avoid any interruptions. I would now request the worthy chairs to please come over and take their seats at designated places. Thank you, sir. Our first presentation is by Dr. Professor Khalid Bashir. He is the consultant anesthesia and head of pain management in the National Hospital and Medical Center in Lahore. He is the first trainer and examiner of FCPS pain medicine and is the president of Pakistan Society for Treatment and Study of Pain, Lahore chapter. He received his primary training from Oxford, UK, and has been participating in various pain management activities in Pakistan. Please welcome him on stage for his presentation on the topic Interventions of Back Pain, What to Do and When to Do.
Thank you very much. The topic given to me, rather given to them, is interventions for low back pain, what to do and when to do. Because in our practice we see that patients are referred to anesthetists, इसको epidural लगा दो, इसको facet लगा दो, तो ऐसे नहीं होना चाहिए. We have to deal the patient scientifically. Okay. So just for revision, the most commonly cited problem, prevalence 40 to 70%, and annual prevalence about 10 to 30%. And 30% they develop chronic pain frequently and they seek help. It is a financial burden on the family, on the country, on the friends, everywhere. Okay. So how to deal with? So various interventions which are usually practiced are intralaminar or translaminar lumbar epidural steroids, transfemoral lumbar epidural steroid, caudal epidural, facet joint injections, sacroiliac joint injection, preformis injection, trigger point injection in the back, and radio frequency. These are the usual interventions which are carried out by various pain consultants. So what to do? कौन सी करनी है हमने इसमें से? Choose किसने करनी है? For this we need to know the generators of pain. What are the pain generators? Pain कहाँ से arise हो रहा है? Okay, it can be from nerve roots, maybe myofascial, maybe facet joints, or intervertebral disc bulge, maybe disc degeneration or disc pathology, spinal stenosis, maybe sacroiliac pathology, or it may be piriformis syndrome. So any one of these or a combination of these can result in backache. And then you have to choose what interventions you need to do in that particular patient. Next question is when to do. When you should do, when you should not do. So first requirement, prerequisite is assessment of patient. Usually patients are referred to us after due assessment by orthopedic or neurosurgeon, but still we need to do our own assessment. We need to exclude pathology. We need to review the cause of pain, pain generator, and exclude red flags, which are tumor, cancer, fever, fracture. These are cardiac venous syndrome. So these are some red flags which need to be excluded. And of course, any contraindication like platelet and patient is on antiplatelet, we usually avoid these injections. So one should be sure that what intervention is he going to do, what intervention is the need for that particular pathology or the pain generator. So the person who is giving, he should be confident of that this intervention is indicated for this particular cause of backache. Then again, the person should be aware of different complications which can arise and management of these complications. I usually say 3 words. Whenever you do a procedure anywhere, maybe in the anesthesia or in pain, you should preempt complications. First, preempt complications. Then you should know how to prevent these complications. And thirdly, if they happen, how to manage these complications. ये 3 बातें आती हैं तो हाथ डालें नहीं तो पीछे हट जाएं. ठीक. Then infection rule out करनी है. Then facilities available. You need to have all resuscitation facilities and sterilization, and of course these days we use C-arm or ultrasound to administer these interventions. This is the algorithm, theoretical maybe or practical. Low back pain, what is the problem? It is radicular or non-radicular. So you can just go through, just read yourself that the epidural is injected, facial joint is indicated, in conditions, sacroiliac is indicated, and finally further review if you don't get any relief. So we have been using steroids for these patients. Now how do these steroids, they provide pain relief? First of all, they are inflammatory mediators, and it acts as an anti-inflammatory agent by inhibiting phospholipase. They suppress the ectopic discharge from the injured nerve. They depress conduction of C fibers, which is the cause of which is pain transmitting fibers. Then steroids also have local anesthetic effect. Plus, we mix local anesthetic, which results in immediate or instant pain relief. Then saline effect, we dilute to 10-15 ml, which also dilutes the mediators there. Because whenever there is some backache or disc prolapse, there is some inflammation. There are inflammatory mediators which are causing pain. So by adding volume, by adding saline, increasing the volume, it will dilute the mediators and wash out the mediators, resulting in pain relief. And then if you inject 10-15 ml, it also results in adhesiolysis in some patients. So there is evidence that epidural steroid injection is effective for 3 months. But now recently the updated article shows that relief, it gives relief up to 12 months even. And again it varies from patient to patient. Right? That's not a fixed rule. There are certain factors which affect outcome after epidural. First is pathology. What is the pathology? How much is the disc prolapse? How much is the compression? How much is spinal stenosis? The route of injection. Caudal is effective in 33 to 77% patients. Interlaminar up to 90% patient, and transfemoral even better. Okay, so these are 3 routes which are commonly used. And then you are using particulate or non-particulate steroids. In transfemoral we use non-particulate, preferred non-particulate in cervical region, but in lumbar area we do use particulate and non-particulate both. In transfemoral there is theoretical risk of venous arterial blockage, which can cause paraplegia. So one should be careful and exclude the intravascular placement of needle. Volume, I already mentioned that volume is effective in diluting the mediators. And then again, inter-individual variation. One patient may get relief for years, and one patient may not get relief even for a month, depending upon the pathology, depending upon the skills and of the operator. We use fluoroscopy, and it is definitely helpful. Is better technique than blind landmark technique, because it has been shown that about 30% cases the drug, you enter into false epidural space. Let us see what does caudal epidural do. It is the choice of epidural in certain patients who have previous spine surgery or spine deformity. Severe scoliosis, sometimes you are unable to pass give transfemoral or translaminar, then you enter through the caudal route. It carries advantages that we can pass even catheter through this, and advanced catheter under fluoroscopy guidance, and break the adherence. Caudal epidural results in more ventral spread, okay, as compared to lumbar epidural, transfemoral, or translaminar. It carries less complications of intravascular injection or dural puncture. But there are certain limitations. You don't reach at the target, because you have to increase volume to reach the target. If you want to reach L5S1, it may take either 10 centimeters away from the caudal septal hiatus. So you need to increase volume to reach the target. This is just a diagram to show caudal. This you can see the needle. In the caudal space, the dye pattern is like this on the lateral view. This is typical caudal image after dye. And dye gets diluted after we give local. This type of patient, caudal is the choice of injection. We pass, usually in these cases, we usually pass catheter from the caudal route and advance it under fluoroscopy guidance. So interlaminar or translaminar lumbar epidural, it has better chance of targeted as compared to caudal epidural. It is helpful in bilateral pain conditions. Volume used is less than the caudal. 5-6 ml is sufficient. And overall, there is good evidence for disc herniation pain. In spinal stenosis and discogenic pain, there is less evidence, but still it is useful. But the problem is that it causes less ventral spread. The problem is ventral, but it has a less ventral spread, and dural puncture are the chances of dural puncture is there. This is typical translaminar, lateral dye spread, midline. You can see the ventral spread. देख रहे हैं लाइन नजर आ रही है ब्लैक इसमें ये चलता नहीं है, इसमें ये चलता नहीं है, उधर नहीं आता, कहाँ से पास करना. This anterior spread. ये the needle, ये posterior spread आ रहा है, ये anterior. So it doesn't happen in every patient. किसी में नजर आता है सब. Oh, this is an interesting case report published in New England Journal of Anesthesia. So this is the disc L4-5, and this is the disc after epidural. It happens in some patients, not in every patient. The disc can regress. So there is another technique, parasagittal epidural. We enter the needle instead of midline, either left or right, whichever side is more effective. It is a substitute to transfemoral injection. Okay, and drug tends to stay on that side. See, this is we are entering on the left side. Midline drug is confined to the left side only. No drug on right side. Left side. left nerve roots are outlined. Okay. The next technique is transformal epidural injection. It is latest advancement. You enter in the just close to the nerve root, and the target, exact target पे आप drug inject कर देते हैं. It has certain advantages or certain requirements. It must be performed under fluoroscopy. No point of blind का कोई chance नहीं इधर. Needle is placed within the neural foramina and is most targeted. There is lower risk of dural puncture and there is greater mental spread. So disc अच्छी तरह inflammatory mediators को counter कर देता है. और radical pyramid is very effective. Okay. This is needle, typical pattern of root, and gets diluted. There is also studies that epidural prevent surgery. In some patients, if they who are advised surgery, we give epidural, there are chances that surgery may be delayed or may be prevented in certain patients, not in all patients. But one must try epidural if there is no contraindication. So there are complications when we do some procedures. When we in medical, there are complications are bound to occur. So preempt a complication, prevent and manage. Generally, they are uncommon, but they can lead to infection, meningitis, and intentional intrathecal steroid they can cause endocarditis, and arterial injection can lead to spine infarction. This is typical transforaminal intravascular spread. Sorry. When to repeat injections? 2 to 3 injections are sufficient, and 2 weeks is better if you repeat after 2 weeks. Facet joint injection are given when there is facet pathology, which is usually there in elderly patients. Sacroiliac joint injection. Piriformis is again very common these days. Typical piriformis syndrome, pain in the hip area. Sorry. There are trigger points in the back. It is a very interesting slide. These are paraspinous muscles, these are nerve roots and this disc. If one muscle is shortened, spasm में जाता है, so it can press, can put pressure and nerve is compressed, will lead to radicular symptoms. So in these patients, epidural won't work much. It will be relieved with trigger point injection in the back or sauce block. These are trigger points. This is an important topic which I have presented in Dhaka conference last week. The interventions in the pregnancy and back pain. So if a lady is pregnant and is getting backache, what to do? You can't give all drugs. You can't give all the drugs because of teratogenic or abortion. So interventions are indicated when there is pain which is resistant to non-pharmacological methods. It is recommended that don't do MRI, don't do X-ray, do a clinical examination, make your provisional diagnosis, and inject sacroiliac, facet, or epidural blindly, landmark techniques, or ultrasound. Don't use fluoroscope. So this is standard recommendation which all of us should know that what to do in pregnant patients. First, सीधा offer कर दे injection को. Just a slide of our Department of Pain Medicine, National Hospital Medical Center. It was recognized for fellowship in pain medicine. We have 2 supervisors, Dr. Atiq and myself. We have visiting faculty, Dr. Liaquat and Dr. Asya Saptan. We have 5 trainees with us. This is just a group of working is that we see patients at clinic, referred patients, inpatients, and my main teaching is what to do, what not to do, when not to do. We do counseling, we do a procedure, and then telephonic follow-up. patient performer. These are the interventions which we did in last few months. These are our plan in future. Thank you. क्वेश्चन साथ साथ करने हैं कि बाद में करने हैं? And then, thank you.
Thank you, sir.
Thank you for the presentation, sir. Our second presenter for today is Dr. Gohra Afshan, who is an endowed professor of anesthesia, session head of pain medicine, and former chair in Department of Anesthesiology at Aga Khan, Peshawar. She established the first pain setup at ACU, followed by the first pain fellowship program in Pakistan. She is a recipient of many national and international grants and is an author of more than 120 peer-reviewed publications. Unfortunately, she couldn't join us today, but we are heartily grateful that she accepted to deliver her topic online. Password है इसमें. Password.
like Pakistan and other lower middle income countries. Currently, Pakistan is struggling to establish this need of the art speciality, which is pain. About Pakistan, we know it is the fifth world's most populated country with a population of 207 million people. It is a federal republic of 5 provinces that include Sindh, Punjab, Balochistan, Khyber Pakhtunkhwa, Gilgit-Baltistan, and Islamabad is the federal capital. Azad Jammu Kashmir, we all know, is administered by the government of Pakistan but has autonomous governance. Healthcare system in Pakistan is a three-tiered, which includes public, private, and miscellaneous sector hospital, some autonomous body hospitals. And the major portion of health resources actually is spent to support the tertiary care center. And this is important. The majority of the healthcare expenditure is going towards the center. So what is the prevalence of pain in Pakistan? Unfortunately, we don't have a published prevalence of pain in Pakistan. So we try to extrapolate from the other studies or from the other global data. So if you see the global data about the prevalence of pain, then we found it is estimated about 27.5%, which is across the 52 different countries, the high-income countries and the low-middle-income countries, and the data shows that it is between 9.9% to 50.3%. So some of the countries, they prevent pain, so maybe their prevalence is much lower than some of the countries where there is no prevention, but the pain is only treated. In a rapidly aging population, and we all know that, pain is emerging as a significant healthcare problem which may likely to exert pressure on the existing healthcare center system in Pakistan. As I told you that we don't have a published data in Pakistan for prevalence. However, in India, different data shows between 19.3 to 25.2%. Recently, we were visiting to Bangladesh, and where we were discussing about this thing, and Dr. Khalid Bashir, again a renowned professor of Pakistan, and Dr. Atiq, again he's a renowned person in pain medicine in Pakistan. They were telling me that they just finished one of the study for prevalence of pain in Pakistan. It is not yet published, but according to their findings, which is certainly they just mentioned to me verbally, is about 50%, or I think more than 50 to 53% prevalence in Pakistan. Certainly we have to wait until the published data comes. But this
In the meantime, if any question regarding my presentation, कोई पूछना चाहता है तो क्वेश्चन कर ले, टाइम बचाएं अपना. Intervention for back pain, any question?
हाँ ले लो.
Here, स्लाइड तो लगा दें, हम बहुत बोल लेते हैं, बढ़ देते हैं। रूम में आ गए।
Ma'am, can you hear us? I don't think she's
Yes.
connected.
Can I start?
Yes, ma'am, please. Please do start.
Can I start?
Yes, ma'am, please do start. Ma'am, you can start now. Connected here? Ma'am, can you hear us?
Can you see my slides?
Yes, ma'am, we can see your slides. You can start now, please.
Okay. So slide is the healthcare in Pakistan personal philosophy. So this is very important slide, and I put deliberately during my presentation because I want to highlight that the role of academic physician, the physicians who work in an academic center, their role is much more, than the faculty or the consultant working in that. I'm confused at which slide you are displaying. Is my or is?
Ma'am, your first slide is being displayed, the one on your screen that's been shared.
That's been shared, the healthcare in Pakistan?
Ma'am, your first slide in presentation, that's being shared right now. Pain medicine in Pakistan, a futuristic study.
Okay. This is
The title one.
Okay. So I think we have all heard about this. So I'm going fast. Okay. So
Yes, ma'am.
Can you see here this slide? Healthcare in Pakistan.
Yes, ma'am, we can see that.
Okay, so I just wanted to see that we as a physician, academic physician, we believe that regardless of the patient social status, we should provide the best possible care irrespective of their status. And I also believe that as a physician, we can benefit thousands of patients, but when we play a role as an academic physician, we can positively influence the hundreds of students who will certainly influence the thousands of patients by providing quality health care. And this is relevant to every specialty. If you see the health expenditure in Pakistan, so Pakistan is 3.38, which is much less than WHO recommendation. If you see, compare all the regional areas, every country has a much lower than what WHO says that. Some of the developed countries, they have a GDP ratio is much more than what WHO recommends, and certainly they prioritize the education and health. So here we just, because we don't have a basic data, so we did one national survey, and this survey actually is based on the healthcare facilities of Pakistan. And this is, we thought, because ISP recently revised the definition of pain treatment facilities into 3. So based on that, we actually designed this survey. So we all know the healthcare indicators in Pakistan, they are lag behind the achievement of optimal health targets. Health resources are very scanty in terms of material as well as trained personnel. There is absence of data regarding the types of pain treatment facilities. And objective of this survey actually is to characterize the structure of pain treatment facilities available in Pakistan according to the ISP definition. So ISP classified the pain treatment facilities into 3, which is the pain center, pain clinics, and the pain practice. This survey was a prospective cross-sectional survey, and we conducted after approval from Ethical Review Committee at Aga Khan University. We design a Google form according to the ISP standards, and the questionnaires which we put in the Google form is about the structure of the pain treatment facilities according to ISP guidelines, associated teaching and research activities, then a spectrum of the pain treatment facilities with the treatment modalities, then what kind of services available to particular center, and the barriers and difficulties. The results. So data was collected from 117 tertiary care hospitals, which is 45 public and 72 private, registered with the Pakistan Medical Council. So basically, the Pakistan Medical Council, which is now again the PMDC, so our data based on the center that was registered there. So 117 tertiary care center, out of 117 tertiary care center, 40 hospitals or 40 centers, which is 33.9%, have an active chronic pain medicine specialty, and these constitute 38.6% of public hospital and 31.1% of all the private hospitals. For this number, if you just calculate, it means that we have a pain services of 0.0193 pain services per 1,000 or 100,000 population. We have 73 pain physicians in Pakistan and 52 nurses, meant that again 0.035 pain physician per 100,000 population and 0.025 nursing staff per 100,000 population. 3 hospitals out of 40 have no support from Allied Health Department. Total of 52 nurses trained through the workshops are present, and only 1 specialist pain nurse in the country is currently a qualified pain nurse in the country is present. We are fortunate that we have Mr. Zina Kirai, who did her master's from Cardiac University in pain management, and she is nowadays also the joint secretary of the SARP society. Azad Kashmir and Jammu Kashmir and Balochistan, they have no pain nurse. Psychologists are employed in 30 hospitals. Physical therapy departments are presently in 37 hospitals only. 39 hospitals out of 40, they offer intervention procedures, while 1 center, they are doing pain services, but no intervention are being done. Advanced neuromodulation technique, intrathecal pumps, and spinal cord stimulation is not present as a routine in any of the service. However, on the need basis, 2 to 3 centers are being done. So here you see the pain treatment facilities in Pakistan. In Azad Jammu Kashmir, 1 private sector, we have 1, then Islamabad, then Balochistan, 2 in the KPK, Punjab mein 9, and Sindh mein 9. If you see the public sector, then in public sector we don't have anything in Islamabad and AJK, while in Balochistan there is 1 center, 2 in the KPK, 9 in the Punjab, and the 5 in the Sindh. So what type of treatment facilities are available? And according to, again, ISP, the pain center, the pain clinic, and the pain practice, and the difference between these, I'm sure that you all know that just for a revision, the pain center is just not providing services, but also the academic, that is the training programs, and also the research. Pain clinics are just providing the services plus some kind of a teaching or training or academia, some level of academic activities. And the pain practice, where the physicians are just doing pain practice, no research, no education, and no training workshop as such. So here is that you can see that out of 40, 25, we have a pain center, which is reassuring that majority of the centers are involved in teaching and training. Then 11 centers are the pain clinics, where some kind of education is being happening, and the 4 are the pain practices. And these are the further subdivision of this thing. Then we see the program availability. So postgraduate program in the pain medicine, if you see in Islamabad, there is 1. Sindh, there is 1 in private and 1 is the public sector. This all 3 are the FCPS. However, in the Punjab, there are 3 private and the 3 public sector. But here, apart from the FCPS, there are some other programs like MSc and FIPM. I'm not sure about the curriculum of these 2 programs, but because I'm involved in FCPS mainly, so I know about the FCPS curriculum. So here is you can see that mainly the FCPS training accredited centers are available for the teaching program. This is very interesting. You see that in some of the areas there are very few number of green and the blue dots, means the centers, and you see them in Balochistan. But there are some centers where there are red dots. That there are several centers in the Punjab where there is no pain service, although they are tertiary care center. So this is a certainly alarming number. So the survey which we conducted recently, and it was the conclusion, this was the first, in our knowledge, this was the first survey of the pain treatment facilities available in Pakistan. The current data indicates severe shortage of pain treatment facilities as per defined standards. There is a lack of pain physicians and allied health professionals. There is a lack of a structured training program in the pain medicine, and there is a need to have a national motive for addressing these issues at the earliest. And here I would like to acknowledge Dr. Usama Ahmed, who is our fellow and is just finishing his two-year program in December this year. And he was a very active participant of this survey, and his contribution towards this survey is enormous. Now, if we compare our data with the international data, so where we stand. So if you see the Australia, Canada and UK, they have 0.322, 0.38 and up to the 0.5 services per 100,000 population, as compared to Pakistan, which is 0.0193 centers per 100,000 population in Pakistan. So this is alarming number. We are far away from the high-income countries where the pain centers, availability of pain centers for the common pain sufferer is much more than us. International recommendation for physician staffing is a minimum of 1 pain physician per 100,000 population, whereas in Pakistan we have 0.035 physicians per 100,000 population. Like other HIC, Pakistan, like other HIC or high-income countries, Pakistan has disparity in availability of pain facilities. That majority of the services are confined to the urban cities and mainly in the province of Sindh and Punjab, not in the other provinces. And again, for rural masses, which make up to 63.6% of the total population in our country, there are very few resources available for this kind of a therapy. But this is if you compare with the other countries, this variation is even in the developed countries also exists. According to the to the British Pain Society 2020, the core standard, which is very, very important, the pain services must ensure joined-up care with the health system. Unfortunately, in Pakistan, we don't have this kind of a pain network or the referral system in Pakistan, not in pain medicine, not in any specialty. Although we have a primary healthcare system and secondary and tertiary, but there is no communication so that the patient can be rightly referred to us. Overall staffing and expertise of the nurses in Pakistan falls out of the recommendation as the skills are task-driven. So again, we have to see how can we improve this angle. British Society also advised further by recommending a career pathway for the nurse working within the pain management. And this is altogether absent in Pakistan. I know one of my nurses, when I was trying to train the nurse, I faced a lot of problem because certainly we have to rely on these nurses in the pain management if we want to really provide much accessible services to our own people. Only 75% of the program have input from psychologists in our country. One of the largest barriers is inadequate pain management is the lack of adequate training in pain medicine. Only 9 hospitals out of 40, 9 hospitals out of 40 currently offering some kind of a training program and comprehensive training program. I'm not talking about the workshops and simple the 2 years comprehensive training program as in comparison with the 2 years or 1 year program in USA and Canada. American Board of Pain Medicine certification requires successful completion of primary residency before starting the pain medicine. Unfortunately, in Pakistan, it is not, nobody is actually watching for this important thing that you have. This is a second specialty. We have to, qualify the first specialty and then you can practice that. And this is one of the achievement, I think, from the people like Brigadier Salim and, Dr. Amjad, Dr. Khalid Bashir, Dr. Asif Gulkiani, and maybe I'm missing the names. The contribution actually made this possible, the pain medicine second specialty. So here I would just like to conclude that there is a dearth of pain treatment facilities in Pakistan as per the available data. The current situation of pain medicine specialty in Pakistan is certainly better than in the last decade. When I started, in 1990, it was certainly very, very bad, hardly 2 or 3 centers, but certainly it is improving. But certainly in the years to come, we will further improve. Concentrated efforts have been made by different institutions like STSP, then some individual giant figures like again, Sir Salim is here to improve the pain-related education program in both the areas. Better education and training of the healthcare team and the better awareness of patients about pain management are needed. Concerned health authorities need to have a national motive to relieve pain and appropriately address the related shortage of the resources, including the doctors and nurses and the allied health professionals. It is quite certain that the pain medicine will continue to grow as long as the human continue to live on earth with pain and other sufferings. STSP needs to have a close coordination with the government authorities to improve the overall picture based on the sum of basic data, and we academic physicians, and I really believe in that, we academic physicians should take a lead to promote pain medicine in Pakistan, which is a futuristic specialty. Remember, failure to treat pain is viewed worldwide as a poor medicine, unethical practice, and abrogation of a fundamental human right. This is very, very important that we have to remember, and we have to do actions accordingly. And here I'm closing my talk with the famous Rabindranath Tagore. He's a social reformer, he's a philosopher, he's a poet, and he's so long list of his achievement. And I like his saying that you cannot cross the sea merely by standing and staring at the water. We have to move, we have to do something. We can't complain all the time that we don't have resources, we don't have this, we have to move forward, and we have to take this lead as an academic physician to improve the pain medicine specialty in Pakistan. Thank you very much.
Thank you for the presentation, ma'am. Our third presentation is by Dr. Amjad Iqbal, who shall be talking about knee and hip joint innovation, a new paradigm for chronic arthritis. Regarding Dr. Amjad's academic excellence, he is a professor of anesthesia and pain relief consultant and has been practicing pain medicine for the last 27 years. He is one of the pioneers of pain faculty for FCPS pain medicine. Amongst his numerous attributes, he is also a teacher, supervisor, and examiner of FCPS pain medicine in Pakistan. Please welcome him on stage for his presentation.
इधर से भी कर सकते हैं और उसके लिए मार्कर के Bismillahirrahmanirrahim. First of all, I am thankful to the scientific committee of this conference for extending an invitation to me. And I also must congratulate the organizer for organizing such a beautiful conference and such a beautiful activity. Well, ladies and gentlemen, the topic I have selected, that is the chronic knee and hip pain. In our pain setup, after the low back pain, chronic hip and knee pain is the most commonest ailment. And unfortunately, there's no proper treatment available for this ailment. As we all know that hip joints and the knee joints, they are the weight-bearing joints in the body, and they are bound to get wear and tear with due course of time. And the commonest cause of this pain is the osteoarthritis. In next 15 to 20 minutes, I'll briefly discuss this osteoarthritis and different management, and in the end, I will discuss the new paradigm in the treatment of chronic hip and knee pain. Yes, we all know that this osteoarthritis is the most frequent cause of chronic hip and knee pain. Other less common causes of chronic hip and knee pains are osteonephrosis, rheumatoid arthritis, there's chronic infections, there's post-traumatic arthritis, persistent pain after total hip and knee replacement. Osteoarthritis is a non-inflammatory form of arthritis. There's a common misconception that osteoarthritis is only because of wear and tear. This is just because of the reason that this happens in old age group. It is also called as degenerative arthritis, but actually osteoarthritis is the result of bland degenerative process and the regenerative process. You can see in the picture these growth of new bone and this degenerative process, they are happening at the same time, which causes osteoarthritis. The morbidity confirmed by osteoarthritis of the knee and hip in an ever-aging population is major. At this time, the medical treatment of osteoarthritis is not as sophisticated as the treatment of rheumatoid arthritis. All too often we fail with the conservative treatment and patients with hip and knee osteoarthritis progress to total hip arthroplasty. Advances in joint replacement seem to overshadow advances in more conservative medical treatment of osteoarthritis. The stats about this is there are about more than 320 million cases of hip and knee osteoarthritis reported worldwide in 2021, with figures expected to rise even further in the future, particularly among women according to a data published in the Annals of the Rheumatoid Diseases. The lifetime risk of developing symptomatic knee osteoarthritis is about 45%, rising to 66% in obese patients. It is clear that morbidity and disability conferred by osteoarthritis of the hip and the knee are enormous and demands our attention. Most of the time, patients present with pain, stiffness, and altered function. Initially, pain tends to be worse with weight bearing and ambulation. But with due course of time and with the progress of the disease, the pain comes day and night once the cartilage leads to bone-to-bone contact. Now we compare with the hip osteoarthritis with the knee osteoarthritis. True hip pain is felt in the groin most commonly, but can also present in the buttock and often down the anteromedial thigh to the knee. Not uncommonly, patient may present solely with the knee pain when the problem is in the hip. Pain in the hip area is aggravated by activity, walking, putting trousers on, putting this, wearing shocks on, and during the hygiene, care of the genital hygiene. So, at time, patient find it difficult to sleep on the affected side. Pain may be accompanied by flexion deformity and patient limp and may have waddling tendinous gait on advanced osteoarthritis. यार इसको जरा बचवाइएगा एक मिनट इधर आना है. यार इसको ना फुल पे कर दो जरा, इसमें ये छोटा आ रहा है ना, मुझे इससे साथ प्रॉब्लम हो रही है. उधर से नजर नहीं आया.
नहीं सर, एक्सटेंड पे बनी नहीं आपकी फाइलें. आपकी फाइलें एक्सटेंड पे बनी नहीं.
I'm sorry, I'm just finding with the problem with my glass here, I can't see it properly, and that is far away. So there is some issue. So I come to the next slide. Now, pain arising from osteoarthritis of the knee is felt right around the knee joint and unlike pain caused by this hip osteoarthrosis. This pain does not typically radiate, it aggravates on movements on the knee joint. On examination, there may be a cartilaginous capitus or coarse bone-on-bone grating capitus. Loss of cartilage of the knee joint lead to malalignment of the leg with a varus deformity or bow leg position. You can see on this picture. There's often a loss of range of motion of the involved knee or hip, particularly with the progression of osteoarthrosis. The goals of the management of chronic this hip and knee pain is the decrease the pain, improve the mobility and function, improve quality of life. The current medication available, this is a pharmacotherapy, the physical therapy, muscle strengthening exercises, this weight reduction, braces and splints can be applied to reduce the pain. Biological like PRP and stem cells, they are also being given for the management of chronic hip and knee pain. Injection like steroid, the synoviscus like hyaluronic acid, these injections they are also given, but they have a very limited effect. Alternative therapies like acupuncture, magnetic pulse therapies, they are also being administered, but of very limited value. Now the new treatments, new techniques are emerging for the management of this hip and knee joint pain. Radiofrequency ablation is an emerging technique for the management of chronic pain and knee pain. While the use of this technique is quite established in the other field of medicine, like it's being used in the cardiology, in the gastroenterology, we being pain medicine specialists, we are also using radiofrequency treatment in the trigeminal area, in the lumbar region, in the medial branch block. These techniques are being used in these fields as well. The literature of the target and the use of imaging and details of needle placements are emerging. Now this is a RFA generator. You can see along with these are the thermocouples. They are attached with these RFA generators. These thermocouples, they are inserted through the cannulas. They are special type of cannulas with exposed tips. They are applied precisely located at the site of the nerve, and then these lesions are generated. RFA is a thing which we create a heat lesion, and sensory nerves carrying painful impulses from the knee and hip joints, they are being burned or they are being ablated. Successful treatment can result in pain relief which can last for several months. This treatment is performed under local anesthesia or in a light IV sedation. This treatment, it takes about 4 to 6 weeks to be fully effective. Since over the years, several groups of researchers have attempted to improve thermal radiofrequency hip and knee joints partial denervation to maintain pain control effectiveness while reducing its side effect. Other researchers have also investigated other methods which might yield better results, such as pulse radiofrequency, water-cooled RFA, and cryoneurolysis to avoid damage to the treated pain. Indication for the hip joint RF denervations are when the pain is persistent. All the conservative treatments are failed. Only then we decide to do this radiofrequency ablation of the hip joint articular branches. Indication is the persistent pain, the hip osteoarthrosis, in a rheumatoid osteoarthritis, the osteonecrosis, avascular necrosis, chronic infectious osteoarthrosis, metastasis and persistent pain after total hip arthroplasty or after hip dislocation. The indication for knee joint genicular radiofrequency denervations are when the pain is persistent and is not relieved by the routine conservative method or by these steroid or synovial injections. Or patient with a failed knee replacement. or patient is unfit for knee replacement. As we all know that most of these patients, these things occurs in the geriatric patient, and most of these patients, they are having so many comorbids, and they are not, either they can't afford it, or they are not able to undergo such a hectic surgery. So these are the candidates for the radiofrequency ablations. Next, the patient who wants to avoid surgery, and before or after the knee replacement this can be applied for the quick recovery. Before we plan radiofrequency treatment of the hip or knee joint, we should have a fair idea of their nerve supply, sensory nerve supply of these joints. Hip joint is supplied by these obturator nerve, femoral nerve, sciatic nerve, and sympathetic supply is from lumbar sympathetic plexus. The anterolateral aspect of this joint is innervated by branches from the femoral nerve. The anteromedial by the accessory obturator and obturator nerves. The femoral and obturator nerve can be reached with ease with minimum risk, whereas the posterior aspect of the hip joint is supplied by the sciatic nerve, a quadratus femoris branch, which is a branch of a superior gluteal nerve. This nerve is difficult to approach, and there is a risk of damage to the main trunk. So this is usually avoided, and we can get an appropriate result with the blockade of, with the ablation of the femoral and obturator nerve. Hip joint pain is usually referred to the groin, or and this is being communicated. This is being conveyed by the articular branches of the obturator nerve, the nerve pain which refer to the groin area. The trochanteric area pains come from the articular branches of the femoral nerve. In a damaged hip joint, the biggest discomfort comes from hip flexion, putting trouser on, and from hip abduction. The sensation for both movements are mostly covered by the articular branches of the obturator and femoral nerve. Knee supply is innervated by these various nerves like femoral, common peroneal, saphenous, tibial, and obturator nerve. These branches around the knee joints are known as genicular nerve, and these genicular nerves can easily be approached with needle under fluoroscopy. RF is usually done in a two-step. It can be done under fluoroscopy, it can be done under ultrasound guidance, or both can be used at a time to get the precise location of the needle. In a first step, a small dose of anesthetic drug is injected into the area, around the nerve, which is meant to be ablated. If the anesthetic agent produces good pain reduction of about 80% or more, the person is a candidate for the ablation. Then in the second step, it's almost the same as the first step, except we use a thermocouple which is attached with the radiofrequency generator. This thermocouple is placed through a special cannula. So a special cannula, the stellate is removed and thermocouple is placed inside. This terminal, the tip of the cannula is unexposed. The size of this unexposed part, it varies from 2 millimeter to 10 millimeter, depending upon what type of lesion and how much of the lesion you want to produce. These needles are placed at the appropriate place under fluoro and ultrasound guidance, and then these nerves are heated to get the ablation. For hip joint, obturator and femoral articular branches are lesioned. For obturator nerve, the needle is inserted 2 centimeter medial to the femoral vessel and 2 centimeter below the inguinal ligament. For the femoral nerve, the needle is inserted 2 centimeters lateral to the femoral vessel. When the needle are placed to be on the very safe side, this bone contact should be felt at the tip of the needle. Then electrical stimulation is performed to rule out proximity to the main nerve trunk. Once in a safe position, then consecutive thermal radiofrequency lesion for each of the femoral and obturator nerves are made at 90 degrees centigrade or 120 degree for 120 seconds. This is the fluoroscopic view of the needle placement. For the lower one is for the obturator nerve. Under fluoroscopic guidance, you see a teardrop shaped structure, which is the landmark on the bone where the needle for the obturator nerve is placed. These are the landmarks for these targets for this genicular branches block of the knee, you see. Several genicular nerves can easily be approached with a needle under fluoroscopic guidance. These are the fluoroscopic view. Here this superior and superior medial and lateral genicular nerves are blocked, and inferior medial genicular nerves are blocked, and the inferior lateral genicular nerve is avoided just because of its close proximity to the main trunk of the common peroneal nerve. These are different fluoroscopic views. These RF is being done. Patient should be monitored throughout the procedures. In experience and the chances of complications are very rare. Radiofrequency denervation is satisfactory in the majority of the cases with good long-term control reported for thermal radiofrequency. With cooled radiofrequency, there are no long-term follow-up reports so far available, but a lot of studies are being carried out on this, so yet not much results are there. With pulse radiofrequency, the pain is back in less than a year. In a conventional thermal radiofrequency ablation, the pain relief can last up to 2 years. So there may be some soreness in the area for a week, but most people get more relief than discomfort. The pain relieving effect usually lasts from 6 months to 2 years. A major concern of this type of procedure is the progression of osteoarthritis or induced Charcot arthritis, because patient don't feel any pain and he keep on doing everything, so it's the degenerative process may accelerate. But different studies shows that the chances of Charcot joints are very less, whereas the studies shows that the patient who have been given these local anesthetics and these steroid injection, they have more chances of developing Charcot joints. Just to conclude, aging population may suffer from significant comorbidities that may impede hip and knee arthroplasty. The relative simplicity of this technique is worthwhile for those patients often confined to wheelchair and with no prospect of surgical relief. They are often pleased even with a partial pain improvement. These procedures had no major complaints and could be applied to patients who had a very poor general status. Thank you very much.
Thank you, sir. Our fourth presentation is by Dr. Asma Abdul Salam, who shall be talking about pain management setup in resource-limited countries. Regarding Dr. Asma's academic excellence, she is a consultant anesthesiologist and pain physician and is an assistant professor and program director anesthesia at Ziauddin Hospital, Karachi. She is a pioneer in anesthesia postgraduate training program, including academic session, workshops, and CMEs. She established the first pain management service at Ziauddin Hospital, Karachi, and is the director of many workshops on pain management. Without further ado, please welcome her on stage.
Thank you, everybody. So I'm really thankful to the organizers for inviting me today and letting me speak on this topic in front of all of my seniors in pain management, Brigadier Salim Saab, Dr. Safiya, Dr. Amjad Gulkiani, and all my chair speakers. So I have no actual or potential conflict of interest in this relation, and I also have to disclose that there is no financial interest in the content of this subject. So in low-resource countries like Pakistan, pain management services are not prioritized as clinical services, as we all came to know just before by our esteemed pain physicians. There is systemic information which is in regarding to the prevalence and management of non-chronic chronic known pain in Pakistan is also not available, and even when patients they do have access to the healthcare services, pain relief remains elusive. So despite of the fact that several national and international associations are working on it, including STSP and IASP, we are looking forward to have more pain management services. But before I step into giving you an insight on how to establish a pain management service, I just want to quickly go through the definition of pain so that my junior colleagues come to know about it. That IASP has got a definition, specific definition for pain, and that is an unpleasant sensory and emotional experience associated with or resembling that associated with actual potential tissue damage. So from there, the classification of pain came in, and usually pain has been classified as per physiology, which is nociceptive, neuropathic, or inflammatory. But other than that, the most commonly type of pain which are being used in our normal practices are upon intensity, which is mild, moderate, or severe, or according to the time course, which is acute chronic or acute on chronic pain. Other than the types of the tissues affected, because some of the people, they also, our physicians, they also categorize it as skin pain, muscular pain, visceral pain, joint pain, tendon pain, and bone pain, and so on and so forth. And then there are other syndromes which chronic pain patients can have, like cancers, fibromyalgia, and migraine syndromes. So most of the time which we categorize pain as is according to the time duration. And just a quick and brief review of what acute pain is. Acute pain is the pain which is caused by the tissue damage or a disease which lasts only for a shorter duration of time. And it usually resolves when the underlying cause of pain has been relieved or is being treated. So usually it resolves within 6 to 12 weeks of the onset. And it is usually provoked by identifiable stimuli, and it usually disappears as soon as the tissue injury has been healed. However, chronic pain is the pain which persists beyond the normal expected time of healing, which is more than 12 weeks, or it persists beyond the course of an acute disease or after tissue healing has been completed. So usually it persists more than 3 months. So why it is important to know the difference between acute and chronic pain, that I will come at the end, and you will know why I said that. So basically, pain has a biophysical framework, and whether it is acute or chronic, it is a multifactorial condition which has biological, physiological, and social contributors. But how much each domain contributes to the particular patient's pain, it varies from one patient to another, and it also varies from time to time. And as Dr. Gohar has also mentioned in her previous talk about the burden of the chronic pain, which is one in every 5 patients has pain, but 1 in 10 patients are diagnosed with chronic pain every year. So in a low molecular income countries, its prevalence is, as has already mentioned, from 28% to up till 50%. But in Nepal and India, which are our contemporaries, it goes up to 50%. In Pakistan, it was reported in a non-indexed journal as up to 34.5%, but it was non-indexed, and it was quite recent study which was published in 2022. And because of the impact of the untreated pain, there is high clinical, financial, and humanistic burden on people who have access to public health which is not even funded or even inadequate. And there is a wide-ranging negative physical, psychological, and functional effects which leave them unable to participate in their daily life activities. So chronic pain, basically, it affects the families, it affects communities, it affects the workplaces, health systems, and the economy as a whole. And despite of a very strong and consistent evidence of the impact of pain burden globally and nationally as well, there is again a mismatch between the burden and the resources allocated to the pain services. And this mismatch is evident by the lack of availability of multidisciplinary pain management service. So basically what a multidisciplinary pain management service is, it refers to an integrated approach in which the multimodal treatment is provided by a multidisciplinary team which collaborates in the assessment and the treatment using a biosocial model and goal. So all team members, they work closely together by participating in regular meetings and agreeing on the diagnosis, therapeutic aims and plans and treatment and reviews. But the overall goal is to provide the safe and timely and effective management to all pain scenarios. So why it is important to have such kind of pain service in any hospital is because it significantly improves the treatment in lieu of the organized leadership, centralized vision and care integration. It provides dynamic treatment to the patient in the form of care and assessment with the quick adjustments for the side effects and adjustment to ensure the consistency. And also there is care is provided to avoid the medication related or the technology related errors. So the patients, they benefit from all aspects because of this teamwork. And the basics of any pain management service is frequent surveillance, so that the ultimate goal becomes the return to the work, improve physical function, resulting in increased family activities and obviously increased satisfaction of the patient. And because of this organized approach to acute or chronic pain management service with the standardization of the procedures, orders and monitoring along with an integrated interdisciplinary emphasis is the main basic of having any interdisciplinary or multidisciplinary pain service. So basically before going into what and how to establish a pain management service, there are certain characteristics which the staff of the multidisciplinary pain management service should have. So they should be able to understand overall the pain main objectives of the service, as well as they have to act accordingly, and they have to be committed to be as a member of that team, and they should be able to understand the contribution of that psychosocial issues which is impertinent and in particular to the chronic pain. They should be able to empathize with all patients, especially those patients who are in chronic pain and as well as in acute pain. They must possess and use effective communication skills, which is very important, and they should be able to understand and respect the cultural norms and also participate in the continuous professional development along with the ethical clinical practice. So these were some of the essentials for having a multidisciplinary team. But how is this team developed is there are certain cores to it in which there are certain personnels which are involved, which I'll be talking about in a few minutes. Then there are some facilities which are required, and in the end, evaluation is the most important and the key factor for it. So for the personnel, there are certain core competencies which but the most important and the lead person should be the pain director. Now, who can be the pain director? I'll be discussing about it. Then another person who is important and essential for in a pain multidisciplinary pain service should be the other physician who is also essential to have. And the third person, which is essential, is a pain nurse. And then there are other personnel who should be involved are clinical psychologists, physiotherapists, occupational therapists, and other personnel also can get involved, like from the other disciplines. So a lead physician or a medical physician is an essential person but whoever is the lead should be the one who is interested in and is already trained in managing the patients with pain. And they can be from any specialty, but mainly because we are the leads in Pakistan from the anesthesiology service. So, excuse me. So mainly the anesthesiologists are the persons who are leading the pain management service. But other than anesthesiology, people from rehabilitation, people from physiotherapy, people from orthopedics, they can also lead the pain management service. And they should have access to the other health professionals as well. And they should have a team who should be collaborating with them on daily basis. Along with that, in order to establish a pain service, one should also have official officer support along with the clinical administration and the research personnel. Thank you so much. So a pain director is one person who has got at least 1 year of training in pain management, ideally, and should be able to work collaboratively with the other members of the team to deliver coordinated treatment plans. So there is a need of coordination in all of these treatment plans. And the administrative task includes leadership, organization, support of the multidisciplinary team, along with the management of delivery of the pain services. He should be able to support and initiate research, because research is very important, along with evaluation and reporting outcomes to the relevant patients and team members. And again, if funding can be gained, then the source funding in the cases of individual pain centers. Then the second physician or the medical physician is the one who has got training in pain management for at least 3 to 6 months. So these individuals can be your PGs, can be your RMOs, or can be your colleagues from anesthesia or any other services who should be able to collaborate with you and assist you in pain services. So they should have an ability to work in an interdisciplinary manner to deliver coordinated treatment plans as per the lead. And along with that, they should also be able to participate in the multidisciplinary discussions on patients on daily basis, along with the support and initiate the research and evaluate again the outcomes. So I'll come to why outcomes are more important and why it is important to evaluate pain. Then their clinical tasks are plus minus the same, and the overlapping with the comprehensive pain assessment, diagnosis and identification, management of the complex comorbidities, pharmacological management, and perform pain interventions in case of need for chronic pain. And the nursing assistant should be a registered nurse with experience in working with the patients with acute or chronic pain. And their administrative tasks again should be participate in the team discussions, evaluate the patients, report to their seniors, as well as also participate in their research. So the other personnel, as I mentioned, are the same, but the training of these staff is very essential, and it's basically a layered approach, a tiered approach. The basic level training should be the basic pain management concepts and skills, and which is essential. And ideally, every hospital personnel, including the ER, including the nurses, the basic level nurses, they should know these basic level training. Then there comes the intermediate level training, in which should be mandatory for all those who are working in the pain centers or in the pain service as a part of preparation or establishing a pain service. And then there is advanced level courses in which are requirement for the development and the supervision of the training for the other health professionals who are probably in the lead position for the pain management. So in the entry level training, usually it should be some hours are assigned, for at least 4 to 8 hours. They should have done the essential pain management, some simple courses or the workshops, and multidisciplinary care working for at least an hour per week. Then in the intermediate level training, these should be mandatory for those who are working in the multidisciplinary pain services, and they should be have successfully completed all these relevant courses, in which should include the clinical assessment of pain, case formulation. They should be able to know the pharmacological treatment, how to prescribe. They should be able to know the side effects, indications, contraindications, dosages, how to titrate the effects. And for the non-prescribers, there only superficial knowledge is needed for at least a course of 4 to 8 hours. Then there should be continuous self-training programs of 30 to 40 hours. over a period of 4 to 5 days or extended period of time with the follow-up and consolidation. But for the leadership roles, advanced level training is mandatory, and it should be done after the training the trainer courses or as a series of interactive webinars, along with observation period of 1 week per or more at another center, pain center, or further specialist training for 3 to 12 months. If the lead physician already has a master's program, then it can be decreased up to 3 months. So, but first task for the establishment of any kind of pain center, including acute service or a chronic service, is to identify which healthcare professional you need to train in pain management and at which level to start. But for any kind of startup, it is very important to have a chronic and keen interest in pain management. If one does not have a keen interest in pain management, then the service might suffer later on. And ideally, all those who deal with patients in pain in a hospital, they should have at least basic level of knowledge and skills. So for the treatment in the facilities which are required, there are several types of services which are allocated, and they also reflect the healthcare system in which you are working. So basically it can be unimodal, it can be multimodal, it can be multidisciplinary, and it can be interdisciplinary. And here in this picture, as you can see, that in the unimodal pain clinic or a pain setup, there is only one pain physician, but there is no nurse and no other healthcare professionals who are involved. And it's usually the pain medicine services which are offered are usually single, and there is no research involved, no education involved. But in multimodal pain clinics, which one can start off with, there are usually 2 to 3 personnel involved with pain nurses, at least one pain nurse, and pain modalities which can be offered are quite several, including medications and procedures and interventions. And yes, at times you can have educational activities which are a must along with research, and then there are multidisciplinary system for the pain establishment. So, but these are the basics, and you can actually start your pain clinic if you are really interested with a unimodal approach, and then you can go into the multimodal and then multidisciplinary later on according to the facilities or the services or the resources you have been allocated. So the facilities which are minimum required are the space, are the equipment, utility, and the medicines. So in the space, consulting room should be there for a pain management clinic. But here, pain management clinic, we are referring to chronic pain management, because acute pain management service, or we don't usually have the clinics for acute pain management, and it's quite a dynamic field. So I'll come on to that later. So for the chronic pain service, one should have a consulting room, at least one room with the reception area, waiting room for the patients, the washroom, and the other relevant facilities. And the medicines, these are the basic, which are the medicines which one must know, which are for the pain relief, in which simple analgesic schemes along with opioids and the adjuncts. But along with that, one must also be familiar with the medicines for the treatment of the side effects, like antiemetics, antipruritic, medicines for constipation, and the reversal for the sedation. And then there are equipments in which the consulting rooms, the procedure room is also one of the must for the chronic pain procedure, for the chronic pain procedures, and then the utilities. But the ultimate goal of an ideal pain management service is to get the patients relieved, and to start off with, make use of the available resources. Whatever resources you have, just make maximum use of them and just start your clinic, and then later on you can get all the rest of the facilities. But for whenever one must establish a pain service, the most important thing is the evaluation and the measurement. Why it is important? Because patient outcome and satisfaction is the first and the foremost things which we should look after, and it needs to be reflected upon by the changes in the key domains of the pain quality, the stress, emotional functioning, and the pain interference. So these are the outcomes which we usually look at. But there are other outcomes which we can see in particular patients, like changes in their daily medication, decrease in the use of medication, especially the pain medications, behavioral changes like returning to work, and then improved quality of the sleep. So the primary purpose of the outcome evaluation is to help improve your services and outcomes for the patients with the chronic pain conditions. And why it is important? Because eventually it will decrease the cost, it will increase the convenience, it increases the accessibility of the services, and also decreases the waiting time. So in return, there is a win-win for even the patients and for the administration. So the outcome evaluations should include, they should be voluntary for the patient, they should not be a burden, additional burden on patients, and it should be in an as easy as possible mode, mainly by the self-report by the patient, but they should be using validated and reliable measures, and more importantly, they should be translated into their own languages. It should not be made difficult for them that you must be specifically asking them in English or any other language which they don't understand. They should be made easy to be understandable for each and every patient. And they should be completed before and after the treatment in order to determine if there was the meaningful treatment which was given to them. So you have to encourage the follow-up evaluations and record the clinical metrics, as well as to establish a secure and computerized database if available. So what are those dimensions or the outcomes which we can actually measure are the pain severity scores, the pain interference, which is the disability score, emotional, mood, anxiety, and cognitive. बस ख़त्म हो रहा है. तो जो मिनिमम डेटा सेट्स हैं, दे आर बाय सेल्फ रिपोर्ट्स ऑफ द पेशेंट्स, जिनमें आप 0 से लेके 10 तक का स्कोर कर सकते हैं, एंड दे कैन एक्चुअली गिव यू अ बेटर आइडिया. एंड सर्विस एवैल्यूएशन के लिए इंटरनल कंडक्ट्स होते हैं, इंटरनल सेल्फ ऑडिट्स होते हैं, पेशेंट का फीडबैक है विद विच यू कैन एक्चुअली इंक्रीज योर सर्विस प्रोटोकॉल्स. एंड देयर आर स्पेसिफिकली अगर कहीं फॉर्म्स अवेलेबल नहीं है तो एक्सेल शीट के ऊपर भी हो सकता है. एंड देन ऑब्वियसली अडॉप्ट अ प्रैक्टिस ऑफ बेंच मार्किंग विच इज़ by coming to a consensus that at least every patient should have a 30% pain reduction. So ये जो benchmark होता है, it should be done across the board and with the agreement with the all other facilities and the pain service managers, with which discussions can be made, and then eventually one come to a pain relief method. So and in acute pain management, obviously the key and maintenance of pain management service was the implementation of multimodal analgesia. So uska goal ye hota hai ki to minimize the side effects of every individual agent and to target the multiple pain receptors with optimum analgesia and facilitate recovery. Accelerated recovery hogi, reduced length of stay hoga, to patient ka jo stay hai aur satisfaction hai wo बढ़ जाएगी. So this was just a quick review of Dr. Ziauddin Hospital, and that's just a quick glimpse of how I started pain management service at Ziauddin Hospital, being the only individual, because I started off as a unimodal service where I used to do only the pain management clinic with no support at all. And then I applied for a grant at ISP, with which I approximately till now I have trained 200 nurses on initial pain management and assessment. So from there, I selected one of the person to be a pain nurse, and now we have actually established a pain management service because of this, the academic activity and the education which I have been holding on every monthly basis since the beginning of this year. So if I can do it, anyone can establish a pain management service. But before I end, it is very pertinent to know that acute pain management is the right of every patient and responsibility of every doctor, including every anesthesiologist. Everyone can do it. But chronic pain, it is a super specialty, and it should be done by certified specialist who deals with it. Thank you so much. And thank you for bearing me.
Now, our fifth presentation is by Dr. Sarah Haider Malik, who shall be talking about pain medicine as an emerging specialty. Regarding Dr. Sarah's academic achievements, she completed a fellowship in pain medicine and is a consultant anesthetist and pain physician. She has 14 publications in national and international journals and is a Pakistan's first ever female FCPS pain physician and KPK's overall first ever fellow in pain management. Please welcome her on stage. Yes.
Assalamu alaikum. Thank you for inviting me. It is a moment of great pleasure that I'm standing in front of you all today. I'm going to briefly discuss about pain medicine as an emerging specialty, a very new specialty not only in Pakistan but worldwide. Basically, pain medicine is regarded as a level 4 qualification by the College of Physicians and Surgeons, Pakistan. As per the International Association for the Study of Pain, the definition of pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now I would like to briefly discuss about the history of pain medicine. Initially, opium was used to relieve the pain and it was used for different surgical anesthesia, analgesia and as well as the anesthesia for several centuries. After that, till 2100 BC, Sumerian clay tablets were in use, followed by willow bark was extracted and used as for several analgesia regimes over 3500 years ago. The first ever morphine was extracted in 1803 from opium by a German physician whose name was Mr. Frederick Sertuner. Later on, Dr. Charles Wood was the first person who actually started using the IV injectable forms of the morphine. After that, variety of analgesic remedies were used, like drug-soaked sponges, compressors, plasters, oils, ointments, smoke-smelling salts, drinks, waters, pills, and even in the powder forms. Pain is a constant companion for humanity, a beautiful statement that was given by Ma'am Marcia Meldrum, who was an associate researcher in the Department of the Psychiatry and the Behavioral Sciences at the University of California. The field of pain medicine started back in 1960s, and the first ever research journal was published in 1970s by the IASP, which is known as the International Association for the Study of Pain. These are the different organizations that are working for the pain medicine. The International Association for the Study of Pain, known as IASP, which was founded by Dr. John Bonica back in 1973. The Society for Treatment and Study of Pain, known as STSP, is Pakistan-based. Rest of all the organizations are working in different areas of the world. Now I would like to briefly discuss about the pain medicine specifically in Pakistan. In Pakistan, it was started by worthy Brigadier Muhammad Salim Saab, who actually started a program known as the MSc Pain Medicine. And if I'm not mistaken, it was started back in 2007. Since then, we have a lot of graduates of the MSc Pain Medicine. Recently, CPSP, the College of Physicians and Surgeons of Pakistan, have started a proper fellowship program with the name of the FCPS Pain Medicine. It started back in 2014. The first batch of the FCPS Pain Medicine qualified in 2020, comprising of the 3 trainees. After that, second and the third batch qualified in 2022. Making a total of 9 fellows which are present in Pakistan as double FCPS, FCPS anesthesia, followed by the FCPS pain medicine. CPSP has recognized several centers in Pakistan for the fellowship of pain medicine, which includes CMH Rawalpindi, Fauji Foundation Hospital Rawalpindi, Shifa International Hospital Islamabad, and other centers in Multan, Lahore, as well as Karachi. However, the 9 graduates which are currently working as proper classified FCPS pain physicians, they are the graduates of Fauji Foundation Hospital Rawalpindi, CMH Rawalpindi, and Shifa International Hospital Islamabad. The curriculum of pain medicine as per CPSP includes acute pain management. In the acute pain, we further divide it as surgical pain management, the trauma pain management, and the labor pain management. Then we have chronic pain, cancer pain, palliative pain, pain management in the critically ill patients who are present in the ICU, the pain of the pediatric patients who are unable to tell themselves. Rotations are based in the subjects of neurology, radiology, psychiatry, rehab medicine, and orthopedics. Why there was a need of a pain medicine as an independent specialty? This is a very important question, because the prevalence of pain as a disease is present amongst the 60 to 70% of the population of either gender. Secondly, interventional pain medicine is in itself is a huge and extensive field which demands the complete presence of the pain team, which should be working round the clock to help alleviate the suffering of the pain patients. Therefore, there's a dedicated field of the pain medicine which is growing day by day. This is a WHO letter for the management of the pain. You can see there are two arrows can be seen, which are acute pain management and the chronic and the cancer pains. By the two arrows, I mean if you see the acute pain, it starts in a reverse manner. Like we do the step 4 management, then step 3, then step 2, and then step 1. However, for the chronic and the cancer pain, the ladder is as follows from the step 1, 2, and 3, and then 4. This is my Department of Pain Medicine at Fauji Foundation Hospital, Rawalpindi. This is my supervisor. I have the honor that he's around right now. Thank you, sir, for coming and joining us. Major General Yagat Ali, sir, is Hilal Imtiaz Certified Military, and the two of the fellows who are also working with us in Fauji Foundation Hospital. Now I would like to discuss the interventions that we are doing at our hospital. We do the fluoroscopic guided interventions, ultrasound guided interventions, radiofrequency ablation generator techniques, the regenerative therapies which include the PRP, cellular matrix, regen BCT from the Swiss lab. Knee implant gels are also in use, which include the Crespin gels, the Durolon, as well as the Hyaluron injections. Epiduroscopy and adhesiolysis is also being done. This is a picture of the fluoroscopic guided intervention. This is the erector spinae block being done with the help of the ultrasound guidance in a post-operative patient. This is the sacroiliac joint nerve block for chronic backache. These are the transforaminal epidural steroid injections and the acromioclavicular joint injection for the shoulder pain. These are sphenopalatine and Gazerian ganglion block. The sphenopalatine block is being done for the atypical facial pains who are not responding to any sort of medications. And the Gazerian ganglion block is done for the trigeminal neuralgias. We also manage the cancer pains regularly in our setup, and the interventions being done are the celiac plexus neurolysis, which is done for the CA pancreas patient, as well as the metastatic cancers who have generalized abdominal pains. We also do hypogastric plexus neurolysis, and we treat the patient with the multimodal analgesia infusions. This is the RFA knee joint. As discussed by Sir Amjad recently, RFA knee joint is basically done for the grade 4 osteoarthritic changes. However, these patients are primarily the surgical candidates, but either due to the patient refusal, they do not undergo the surgery, or because of the comorbidities present, the patient becomes a high risk. So therefore, to alleviate their pain, we do the RFA so that the pain can be relieved for a period of 1 to 2 years. In RFA, we have two modalities available at our setup. One is the conventional RFA, which can relieve the pain up to 1 year, and we are also started the cooled RFA technique, which can relieve the pain up to 2 years. This is epiduroscopy and adhesiolysis. This is done for failed back surgery syndrome. Now coming towards a few myths and misconceptions at the patient's end. This is a very interesting slide because I would really like to share a few personal experiences with all of you. The patient coming to us have the first and the foremost question which we have to answer on daily basis. Doctor साहब ये तो स्टेरॉइड के टीके हैं. डॉक्टर साहब स्टेरॉइड लगाने के बाद तो सारा कुछ खत्म हो जाता है, अब इसके बाद तो हमारा कोई इलाज हो ही नहीं सकेगा. डॉक्टर साहब कमर में टीका लगाने से तो पैरालिसिस हो जाता है, हमारे तो उन्होंने बताया था तो हमें मना करके भेजा कि कमर में टीके नहीं लगवाने. डॉक्टर साहब इनके लिए तो आप सुन करने के लिए लगा रहे हैं, इनका असर कितनी देर रहेगा, क्या बार बार लगाना पड़ेगा? Now here the role of pain physician as a counselor is also very important, because not only to answer the queries of patients in a manner that would not only alleviate the patient's anxiety, rather we have to gain the confidence of the patient to help them in various pain procedures. Why anesthesiologist as an interventional pain physician? This is yet another very important burning question these days. Well, in my personal opinion, I believe the answer to this question is, number one, John Bonica, who founded the pain, he himself was an anesthesiologist. Number two, while working around the brain and the spinal cord, the vital structures, there can be any complication. These are very high-risk procedure. So in case of, God forbid, if anything happens in a case of the code blue situation, anesthesiologist would be the perfect person to manage the case independently. And number three, definitely as per the CPSP, the eligibility criteria for having a fellowship in the subject of pain medicine, one has to do the fellowship in the subject of anesthesiology. I thank you, all of you, for your precious time and attention. Have a nice day.
Our final presentation is by Major General Dr. Liaquat Ali, who is a super professor and HOD of anesthesia in FEMC Islamabad. He is one of the pioneer supervisors at First Center of Pakistan, CMS Rawalpindi. Amongst his numerous attributes, he is also a teacher, supervisor, and examiner of FCPS pain medicine in Pakistan and has trained many FCPS trainees in ACLS and BLS courses. Please welcome him on stage.
यहाँ से होगा यहाँ से thank you Bismillah, thank you very much organizing for giving me this opportunity. This is my institute, I think one of the biggest medical welfare trust, university for medical health care colleges, 1,000 bed teaching hospital, and all in one complex with 30 peripheral medical setups giving cover all over the Pakistan to the families of veteran. The 90% patient in this trust, they are treated free, all type of treatment, cancer or any other treatment. And the unique thing is that this is the trust which don't take any donations, neither from persons nor from organizations. And one may ask how it is run. The pioneer in 1961, then when it was established, they were very, I think, genius peoples. What they did, they have one time funds from the government to establish this setup. And they received 20 million rupees in those days. They spent 10 million on the medical setup and 10 million to establish industry with the help of some Italian firm. And the medical setup and industry, they grew side by side. This medical setup is financed by that initial 10 million setup, which has grown a lot. So this is a unique experience working in this institution. This is just a procedure room of my department. The case I am presenting was reported in Epicare June 21. I think this has all been already has been covered, low backache, and very nicely by General Khalid also, and Khalid Bashir, Dr. Khalid Bashir. And all definition I think you know. This is last presentation, very short time. I am trying to save the time. Epidemiology was covered by Gaur F. Shah, Dr. Gaur F. Shah. One thing I just want to emphasize that low back is the most frequent cause of activity limitation in young population. So it is a huge burden financially as well as working hours. The common causes of low back may be mechanical, like disc herniation, neurological, maybe radiculopathy, or systemic, like inflammation, etc. Or there are uncommon causes like coccydynia, and then there are some rare causes like Bert-Lati syndrome, which I will be discussing. My first patient, about 3 years back, a 40-year-old male, doctor by profession, reported with a history of 3 weeks severe pain, low back pain radiating to the up to the right knee. He took all the medicine. He himself was doctor, but there was no relief. And when we examined this patient, and he has to take off from his professional duty, and there was tenderness on right SI joint, and all the tests of SI joint like Faber test, pelvic compression test, and sacral thrust test, they were all positive. And we prepared the patient for agent, triamcinolone and bupivacaine injection. We took the consent and prepared. After preparation, when we just examined under the fluoroscope, we could see enlarged L4 transfer process having a pseudo-giant with the sacral ala. So patient was again re-examined, and we found that tenderness was little lateral to the SA joint, and this pseudo-giant area that was tender. So we discussed with the patient, counseled him, and we injected the triamcinolone 40 mg and 5 mg bupivacaine according to our protocol after preparation and monitoring and everything. And patient has an excellent pain relief. We give for 2 weeks some anti-inflammatory, and we followed for now 2 years. And patient is symptom-free without any medication. And the next morning he joined his duty. Incidentally, he was a surgeon by profession. This is the just pseudo-giant which you can see here of that patient. The second patient was a 60-year lady who presented with a 5-year history, I think, of low back pain radiating to both buttocks. We examined it for the severe pain, 9/10, and we examined there was tenderness on SA joint area and lateral to that, and we did the all 3 tests for the SA joint. They were positive, and what we did the X-ray of these patients, as from previous patient we became little wiser because their tenderness was little lateral to the SA joint. So if you see, there is a bilateral pseudo joint with the ilium. So under fluoroscope, after consent and procedure, and we injected triamcinolone and bupivacaine, and patient has excellent pain relief, and after 5 years. Third patient was 58-year-old male, had a low back since 2 years, which was radiated to the right side to the gluteal region, inferior gluteal region, and there were minimum relief with the analgesics. So the SA joint and there was tenderness. We did all the 3 tests for SA joint. They were positive, and the tenderness was just little lateral to the SA joint and below the transverse process of L5. So we were suspicious when we did the X-ray of this patient. You see there is a pseudo joint between the sacral ala and transverse process of L5 vertebra. So we counsel the patient, prepare the patient, and give the routine injection under fluoroscope, and patient has very good relief. Only given analgesic for 2 weeks, I think. This fourth patient was little complex patient because this patient was getting treatment for low back pain and for last 10 years, and she was from a very well placed family and 85-year-old lady, and the pain was radiating to the left leg and thigh from the low back, and there was history of numbness also on the posterolateral aspect of thigh as well as to the leg. So when we examined this patient, there were tenderness and SA joint as well as and piriformis area. We did all 3 tests for the SA joint as well as for the piriformis test, like Alex test, Fair test, and Betty test, and all these tests were positive. So we made the diagnosis of piriformis syndrome plus SA joint orthopathy. So under fluoroscope, we give triamcinolone and bupivacaine for SA joint, and under ultrasound, we injected the piriformis muscle. After 2 weeks, we evaluated the patient, and patient reported 50% pain relief. Then when we just re-examined this patient under fluoroscope, we could find this pseudo-giant. This was after treatment, so maybe not be very nice picture, but you can see this pseudo-giant with the sacrum with the enlarged L5 vertebra. So we give treatment, counsel the patient for this pseudo-giant, and after that patient has 100% relief. And we are following this patient for the last 6 months, and patient is symptom-free. So, as the D.H. Lawrence said, that what the eye does not see and the mind does not know does not exist. As we treated first case for Bertrati syndrome about 3 years back, we are seeing these patients off and on. Only during last 2 months, we have treated another 2 patients of bilateral Bertrati syndrome. This large transfer pass L5 making giant with the pseudo-giant with the sacrum ala. This was a 65-year-old male, and bilateral treatment was given for this Bertrati syndrome as our usual routine, and patient has a very good relief. The pain score reduced immediately from 8 to 2. So another patient, 35 years, young female, having low back since 3 years, which were radiating up to thigh, and there was some short-lived relief with the analgesics. And we did the X-ray. As we examined, we have some suspicion of because the pain was little lateral, little unusual. So again, we could find bilateral pseudo-giant with the sacrum ala. We give the same treatment, injection of triamcinolone ibuprofen, and this patient has a complete relief. Since I think 2 months, there has been no treatment required. So briefly, the Bertolotti, it was an Italian physician, first described in 1970. It is characterized by the enlargement of the L5 transfer process, which may make giant either with the sacral ala or with the ilium. You seen in both type of patient. It may be partial, it may be complete, or it may be unilateral, it may be bilateral. And in these incidence is usually 4 to 8%, but in some studies up to 11% incidence has been reported. And the Kestlavi classified this into 4 types depending upon the extent of enlargement of the L5 transfer process and whether this giant is partial, complete, or unilateral, bilateral. These 4 types has been classified. In the other problem is it has been found in these patients with this pseudo-giant, the chances of degenerative disc disease, extraforaminal stasis, and foraminal spinal stenosis, they are much higher, up to 9 times or so. So there may be multiple problems in these patients. Coming to the treatment, initial treatment has to be conservative, like non-steroidal anti-inflammatory drugs and physical therapy and different like heel mobilization, banana exercises, back block or core strengthening exercises. But if they don't work, which usually don't work in this case, then you have to do some intervention. Direct infiltration, local anesthetics, and steroid, which we have done in our patients, and RFA ablation or other treatment. But in some percentage of patients, even this intervention may not work, then the surgical treatment is the only option. That may be resection of enlarged transfer passer, or maybe pseudo-giant may be fixed, and that will eliminate the pain. This is a proposed algorithm which is diagnostic as well as therapeutic. If patient has a low back ache and there is transitional vertebra. Transitional vertebra mean transfer passes of L5 and S1, they got fused. They cannot be differentiated. And you give some conservative treatment and it does not work. And you re-examine the patient. You find that pain is little lateral side as it is for SI joint at the lateral end of megaphysis. And you give some local anesthetic. If there is temporary relief, that is almost confirmed that this pain is because of Bertolatti syndrome or pseudojoint, and then long-term relief is expected with some infiltration or any other treatment. In some cases, as we mentioned, patient may need surgical treatment. If this feature does not exist, then there may be other causes of backache like sacroiliac joint, degenerative disc disease, myofascial pain, lumbar disc, etc. In conclusion, I must say that while evaluating low back pain, especially if a pain is little lateral to the SI joint or lateral end of SI joint, and then you must consider this possibility also. As you have seen in a very small study, that it may be, you can find it in young people's 20, 35, 40, it may be in middle-aged people, it may be in elderly people. It can be unilateral, it can be bilateral, and it can be joined with the sacral ala, or it may be allium. In just few patients, we have seen all types of patients. So this should be considered, and intervention treatment should be considered before opting for the surgical treatment. Thank you very much. Thank you very much for our organizer, and thank you very much, Peshawar. Thank you very much.
Thank you for the wonderful presentation. They were very informative. Now I request the worthy chairs to give their feedback on this session and the presentations.
Thank you.
Excuse me. Yes. Thank you very much for, especially the audience. We will not take my time, just 1 or 2 minutes before we ask the audience for questions. I think first presentation by Dr. Khalid Bashir was an excellent guideline for emerging pain specialists, especially the guideline for what to do with the pregnant patients having a severe or moderate low back pain. Then as far as second presentation by Dr. Gohar Afsham as a futuristic specialty, I think I am at least happy it is emerging for these events of last 5-6 years. Now we have 8 centers who are giving FCPS training in pain medicine. And I think within these 6-7 years, third generation of pain specialists, FCPS has come. Like one of my trainees has done FCPS. One of my trainee done FCPS, pain medicine, and he is supervisor, and his trainee has also qualified FCPS pain medicine. So I think it is emerging fast, and in addition to MSc and FIPP, which is also contributing a lot. In fact, in volume, that is the major. I think that is the encouraging thing. Then a very difficult topic, knee and hip pain together, General Amjad, and it was a very comprehensive how to manage these patients. And one thing just I want to clarify, as we were talking about the ablation of the femoral and obturator nerve, one may not get alarmed. It is just articular branches of these nerves which we ablate, which cause analgesia. We avoid motor component of these nerves. Then Dr. Asma's resource limited countries, it was a multidisciplinary team management. I think this model may be very good even for good resource countries if we can do it, and I think with the time will come when we will have these centers. And then as emerging specialty, I think I don't have to say anything. I think Dr. Khushal.
Thank you very much. All the presentations were very nice and full of knowledge. Especially this session was very important, through which we came to know that where we stand. So Dr. Gaurav Shah clearly told us where we stand, and then Dr. Asma gave good guidelines how we have to proceed and achieve the goal. So thank you very much, all the presenters and the organizers. Thank you.
I will not comment on any presentation done by General Amjad, General Liaquat, Dr. Gawar and myself, because we are old generation. It was a real pleasure to listen to Dr. Asma and Dr. Sara. They are the future. Yes. Excellent. Well, good job done. Keep it up. Thank you.
Thank you, sir. Now we proceed to the Q&A session. If anyone has a question they want to ask the presenters, they may raise their hands.
Leave it. They can ask afterwards.
All right.
Hello. A very small question, and I want a very brief answer. The question is specifically to Dr. Sara and generally to everybody. In the curriculum of pain medicine, can we include the traditional acupuncture or the homeopathic system? Because one can't deny their importance and their usefulness. So what is your say on it?
Dr. Sara, let me answer the question. Because anything which you want to include in the curriculum has to go through the faculty, has to be reviewed by the college council. So it's not an easy job to include acupuncture or homeopathic without scientific evidence or without having included in any textbook of pain medicine. जब तक किसी बुक पे नहीं आएगा रेफरेंस के साथ तब तक कोई चीज़ शामिल नहीं होगी.
In our curriculum, there is a part complementary medicine, and acupuncture is there in that part. But I think homeopathic is not present.
Sir, I would like to add one thing about homeopathy. What we are seeing in day-to-day practice is homeopathy is basically generally based upon the steroids. So most of the times it is highly not recommended. That's all.
Thank you.
Thank you. Now I'd like to request Brigadier Dr. Salim to come up on stage and award souvenirs to the presenters. Brigadier Dr. Salim.
Hello.
First to Dr. Khalid Bashir. Please come on the stage. Thanks. Next to Dr. Liaquat Ali. Please come on the stage. Next to Dr. Asma Abdul Salam. Please come to the stage. Next to Dr. Sarah Hather. Please come to the stage. Next to Dr. Amjad Iqbal, please come to the stage and receive your. Now I'd like to request Dr. Amjad to present souvenir to Dr. Salim. Please, Dr. Salim.
आपने जो भी है हमें भी
Thank you, sir. Ladies and gentlemen, now we conclude our session. Thank you for participating in this session. Thank you for coming. Thank you to all the presenters as well, and Dr. Gohar Afsha as well. Thank you.
The hair. Ladies and gentlemen, we will start our next session because of some time limitations. Our next session is about team building, and I would like to call on stage Dr. Tahir Ali. He needs no introduction now. So, Dr. Tahir Ali, please come on stage and enlighten us.
Thank you very much. Can I first ask everyone sitting in the back to come forward? Because this is going to involve a lot of you doing the talking. Come on, everyone stand up from the back and come and fill in the spaces. Come along. Because you're going to have to come to the stage as well. Everyone come to the front, please. So just full screen, I think. Just full screen. Yeah, I've put it's on full screen. Yeah. Okay, thank you. So actually we're going to do something sort of midway. I want everyone to get up, come to the stage, pick up a card, and I want you to look at any of the cards that represents your department currently as it is and what you feel the future holds for it. Everyone come, get a card, please. It's here for a reason. Especially the trainees. Let's get you guys moving. Let's move those DVTs around. Come on. Have a look carefully. What card represents your current department and what you see the future holds for it. These are pictures, very random pictures, and we're going to talk about them. And I want you to have a think about why you chose that particular card. And if you don't want to talk about your current department because your bosses may be sitting here, think about your previous department. I don't mind. Just there's enough cards to go around. Everyone get up, please. One card each. Preferably one card where it is and the second card regarding the future, but we may not have enough. Yep. So two and once you've grabbed it, go back to your seats. Right? So a card of what it currently exists as, and another one of what you feel it will be in the future. It's very random, I promise. And it's the picture, not the writing, by the way. Just the picture. And if there's loads left, take more than one. Take two, more than two even. That's fine. And sit close to the front because we're going to be handing the mic around, please. Anyone sitting at the far back will be picked on first, I promise. Yeah. If anyone has any written cards, ignore them. Come and pick up a picture, please. Anyone with writings purely on it, ignore those, just the pictures. Sure, now that we've got that, there's another announcement before we start.
This session will be chaired by Professor Dr. Mohammad Salim, Professor Dr. Amin Khwaja, and Professor Dr. Saida Haider. If they are present, please be seated. I mean, go to your designated chairs, but if not, it's okay. We will continue with our session. Please, Dr. Tahir.
Okay, do you have a mic, a mobile mic for me, please? Okay. Okay, brilliant. So we're going to have a think about the concept of a team. And interestingly, the last time I delivered this here in Peshawar, it triggered such interesting discussions and such fascinating points were brought about, more so than when I have discussed it back with my trainees. So we will, by the end of it, hopefully have a better understanding of teams. We may feel we know and we understand the concept of a team very well. If anyone has one card, you're welcome to pop up while I'm talking and take another one. It's not a problem, okay? And this group exercise we're going to discuss, then I'm going to show you a video I made with my trainees and my nurses in the SIM department. Full declaration, I am not a Hollywood actor, and I definitely did not win an award for it, so there's very, very bad overacting, but the purpose of that was to demonstrate many important points. So you will find many cringy comments like this, but it's true. When we work as a team, when we have an effective team, not just a team, because I can put a group of people together and they are actually less functional or more dysfunctional than an individual. So we're talking about collaborating together, working together, knowing each other's weaknesses, knowing each other's strengths, using those and supporting each other. Whether you are junior or senior, as I mentioned earlier, one of my registrars taught me how to do an ESP block because I hadn't done it and she had done it. I was like, great. Nothing makes me happier than someone much more junior than me teaching me a skill. So that is a slightly different concept. Maybe not. Okay? And Katzenbach and Smith put together a very interesting description of what a team is. Can you shout out which terms and phrases in their definition stand out to you? Anyone shout out? Come on, this is where I mean it, everyone is going to be talking. Committed. Commitment, committed, excellent. Great, anything else? Common purpose, very, very important. And? Mutually accountable. Who said that? I like that. What do you mean by mutually accountable? Sorry? They're not out. No blame. Who said that? Excellent. Do you mind sitting here, the two of you, so you can be in my... Yes. So they don't throw each other under the bus. If one person is struggling, they will go and actively try and support them. How many of you have seen that? Hands up. Where someone who is struggling in a team, the rest will actively go and support them. How many of... Excellent. How many... Fantastic. I'm disappointed there's not more hands up. How many of you have seen someone struggling and others giggling and laughing at them and actually not minding them being thrown under the bus? Wow, disappointingly more hands. Okay, right, so exactly. This definition highlights exactly what you mentioned. Don't forget, a small group. Interestingly, the ideal team is less than 10 people, 10 members. Beyond that, it starts to get too much. And actually, many of you who have, as I said, it's not perfect where we work. I can tell you for sure, UK is not perfect, and we're trying constantly to make things better. But you will find, for example, the classic example in a cardiac arrest scenario. When we start off by designating roles for each individual, everyone knows exactly what they're going to do. We actually ask them, are you capable of doing such and such? Yes, you do that. Are you? No. What can you do? Fine. The rest of you stand back. Compared to everyone, you'll see videos of everyone going and trying to find the cannula. Yeah? No one's doing chest compressions. Yes? Everyone's trying, everyone is focused. Even the team leader, the so-called pseudo-leader that I call him or her, is kind of looking at that cannula. Is it going in? Is it going in? Do you see what I mean? So too many people can get uncomfortable. So when I usually end up come to recess and there's a peri-arrest or an arrest or a trauma call and there's too much noise, I normally, this is where I get my serious hat on and I shout saying, silence everyone! No one's allowed to talk but the team leader. Who is the team leader? Then they're like, oh, okay, fine. You're the team leader. Have you designated roles? If not, everyone step away and you get individual roles. Okay? Then the nurses actually love it. The nurses say, finally, we know what everyone is doing, compared to one person trying to get a cannula on this end, the other one trying to get fixated on this bloody cannula. Everyone are fixated on a cannula. No one's keeping time for 2 minutes. No one is thinking about the causes. No one is doing a gas, which is more important to look at reversible causes. So this is where sometimes you, and it doesn't have to be the bosses who are team leaders, it can be the junior person being the team leader. Again, I will often ask my trainees or tell them during this scenario, you will be the team leader, which means you will stand at the back with your hands behind your back, not touching anything, and you have situational awareness. Because a team leader needs to have situational awareness of everyone. That's a big responsibility. Sometimes I've been in situations where I am the senior most person and I have to do the things, in which case I stand at the top, put the tube, and while I'm bagging the child, I am designating tasks. Not an ideal scenario, okay? But appreciating sometimes you're desperate. And the other thing I usually do is, and this is something I do as an absolute standard, if I'm in charge, I say if the patient needs an urgent procedure, such as, I don't know, a thoracostomy, and I get involved in taking over, let's say, the intubation or the line, then I expect you, I will designate someone to stop, come back and take my role. And we have, thankfully in our department, finally, we have encouraged a very flat hierarchy where our registrars, our senior trainees can feel comfortable talking to us and say, Tahir, we need to move on to this. I think you're missing that. Oh, sorry, I forgot. Sometimes we need that little nudge, okay? So we will talk about that, you will see what I mean. Adequate levels of complementary skills, committed to a meaningful purpose, as you said, so you all have to have a goal. In this scenario, we need to make sure our aim is to oxygenate the patient and figure out what the cause is. So all of you know what to do, and you designate roles to everyone. And even that scribe, the one who's writing everything, that is a crucial role, because that is going to form communication with ICU, with potentially theatres, with potentially surgical teams, and also in the future, when a lawsuit comes back, it will be clearly written that everything was done in order. Okay? So agreed approach to working together, that brings into place the pre-briefing, which is quite important, and I'm very, very clear about that, and of course mutual accountability. So we've picked up cards. Now, I'm going to, who's got the other mic? In fact, let's start handing out this mic and that one. So, well, you're at the front. You've got 2 cards. So can you hand that at the back somewhere? And we'll start going. So you picked 2 cards. You picked 2 cards. One of them represents your current team and where do you envisage it in the future? So tell me the card, describe it. Tell us about the card and describe it.
It's a clock.
Okay.
And I think it's about taking decisions on right time, so that a small delay can prevent any damage, any further delay.
And that's how your current team works?
No.
No. Okay. Is that what you want your current team to be like?
I want my current team to be very quick in taking decisions. I think sometimes, yes, we delay. I have delayed so many times, and I would like to correct that. And for that, of course, we need knowledge, and we need reflexive.
Reflective practice, yeah. Knowledge, supervision, mentorship, and potentially knowing that you have the support of your seniors in your decision making. Just to mention, delaying decisions is not necessarily a bad thing, because sometimes you feel you're in 2 minds whether or not to do one or the other. And do you know what we do? I'll tell you what we do all the time. I'll pick up the phone and call up one of my colleagues and friends saying, just a quick sense check. This is what I'm doing. Do you think I'm missing something? And they will do the same for me. And we'll be like, no, I think that's fine. Or, have you tried this? Okay. So it's okay, and that shows that you are reflective, and that shows that you are careful and you care about the patient. But there's no harm in picking up that phone, and even for consultants, to take a second opinion. It just makes you, it helps you sleep better. when you know the patient didn't survive, but I tried my best, and I have colleague who also back me up and would have made the same decision. There's no shame. If anyone sitting here claims that they know everything about everything and have got everything right in their lives, that is simply not possible. From the back. Oh, there's a hand up there. Yep, go for it.
In my card, there is a very surprising page.
Okay.
I'm looking like it's me, and I'm looking in my training like I'm missing something. I feel like I'm very interesting in my field, and I want to achieve a lot, and I am struggling for it. I want to build my skills, and currently I am working in a casualty where a lot of cases comes, and my skills are going to be building much more, and I am so much satisfied from my skill. But academically, I am so weak, and I want to, there should be someone to guide me so that I can, I have a balanced in my practice and my training, so that academically, skill-wise and everything should be in a correct way. So it's look like a so much surprising face, like it's me, and I am looking like I'm missing something.
Okay, well that's very, very humble of you. Actually, the first step to improving oneself is to accept their limitations. And I can tell you, in the workplace assessments that we do for our trainees and the multi-source feedback, one of the criteria that we judge all the time is, do they have awareness of their limitations? And in fact, indeed, the feedback that they do, mandatory feedback about all the consultants, which is something that I feel is very important. And I know that makes people uncomfortable. It makes people uncomfortable there as well. But some people who are simply, hands up, who has experienced bullying in the work environment at some point in their career or as a student? Hands up. Okay. If there was mandatory feedback for the consultants as well by the trainees, that dampens that a little bit. And this is a very good method of making some people aware. It doesn't mean you say horrible comments, just like the consultants should not be putting horrible and damaging comments in your feedback, which can potentially impact on your career. That should not happen. It shouldn't happen either way. Likewise, if there is a problem with someone, you mention, you detail it, and you state in your anonymous feedback why it's a problem and how it can be made better, and you also mention positives about their methods. So this is not just a paper where you can bash your boss or your boss can bash you. It's a mechanism whereby you can anonymously express what you really feel. And that's really, really important. So thank you for that. Do you have your mic? Yep. Or shout out loud.
सर हमारे डिपार्टमेंट्स में तो इस तरह काफ़ी होता है कि अगर कोई एक बंदा कोई चीज़ कर रहा है अगर किसी सीनियर्स को वो चीज़ नहीं आती या वो उसके लिए इनकरेजिंग नहीं होता तो वो क्लियरली उस चीज़ के अगेंस्ट बिल्कुल सीधी तरह जाते हैं एंड जो फीडबैक का सिस्टम है वो हमारे यहाँ डेवलप नहीं है. अगर कोई फीडबैक देता है तो उसको आगे इनकरेज नहीं किया जाता, वो बॉक्स के अंदर ही पड़ा रहेगा, उसको आगे एंटरटेन नहीं किया जाता. तो हमारे यहाँ पे ट्रेनीज़ जो आगे लर्निंग और वो नहीं होती, स्किल्स इंप्रूव नहीं होते, तो दिस इज़ वन ऑफ द बिगेस्ट रीजंस कि कोई उसको एंटरटेन नहीं कर सकता.
Interesting. Very interesting. So what I hear you saying is that you want your seniors to be proactive and encourage you to learn more skills, even if they don't have them, and to supervise and facilitate that process.
Exactly, sir. अब हमारे 4 years training में मैंने एक ब्लॉक नहीं लगाया. This is something मतलब मेरा बहुत deficient है. I don't know echo, अल्ट्रासाउंड का मुझे नहीं पता. तो ये चीज़ें काफ़ी deficient हैं और मतलब सब की deficient हैं. मतलब ग्रो कोई भी नहीं कर रहा यहाँ पे.
Interesting.
This is something wrong.
It's sad for me to hear that, because clearly you are someone. Can I just ask, everyone sitting in the back rows, come to the front, because I want everyone taking part in discussions, or you will be picked on every question. You sound like someone who really wants to update yourself and learn new skills and make things better, but you're limited by the system. So I think that comes back to this panel discussion that we had earlier about supervision and mentorship, where everyone agreed not everyone should be a supervisor. And we certainly, often in hospitals, we do not place trainees in lists where someone is known to not be supportive and actually not encourage learning or have other personality traits. Okay, I need to know times just to sort of...
Hello.
Right.
Dr. Khalid, PGR.
Who's talking? I can't see you. Oh, there you are. Okay.
सर मेरे साथ ये पहले पिक्चर में रेक्ट कार्ड्स है जो स्टैक्ड है एक दूसरे के ऊपर. तो करंटली जो सिनेरियो है मेरे ख्याल में वो इसी तरह है कि हम लर्न कर रहे हैं इस एनवायरनमेंट में जहाँ पर हॉस्पिटल और बर्डन है. तो और मैं होप कर रहा हूँ ये दूसरे पिक्चर में सिनेरियो बड़ी खूबसूरत है, सी व्यू है और बोर्ड्स है, कैरिज्मेटिक एनवायरनमेंट है. तो इंशाल्लाह हम स्ट्रगल करेंगे. द अनटोल्ड स्टोरी ये है कि एक CPSP का करिकुलम है और एक हमारी ट्रेनिंग है. तो इसके दरमियान एक गैप है, क्योंकि अगर उस करिकुलम के साथ आप नहीं चलेंगे तो आप पास नहीं होंगे. वो गैप ये है कि हम जब वार्ड में आते हैं, ट्रेनिंग करते हैं, तो जब हमारी ड्यूटी ख़त्म हो जाती है तो उसके बाद हम स्ट्रगल करते हैं और हम हार्डली मेहनत करते हैं और उसको कोप करने के लिए, उसको टैकल करने के लिए हम डबल मेहनत करते हैं ताकि उस करिकुलम के मुताबिक हमें जो चीज़ें हासिल करनी है, हमें जो सीखनी चाहिए वो हम हासिल कर सकें. तो उसके लिए तो अनटोल्ड स्टोरी ये है कि हम जो ट्रेनीज़ है वो बहुत स्ट्रगल करते हैं और सफ़र भी करते हैं. सफ़र भी करते हैं इसलिए कि क्योंकि पहली बार और दूसरी बार अगर कोई जो CPSP की क्राइटेरिया है उसके मुताबिक ट्रेनिंग नहीं है तो फिर मतलब एग्ज़ाम में फ़ेल होना या पीछे रह जाना, ये चीज़ ऐसी है जो उसकी फ्रूट्स है.
I mean, you said it all well yourself. I actually don't need to elaborate on it. Yes. So there is a gap. There's a curriculum, but there's the delivery of the curriculum. Do we need a... So the system in our hospitals for the last, I don't know how many years that since I was a trainee, is that every specialty has what's called a college tutor. So that is a person responsible for all the trainees in that specialty. I am the college tutor, which is called faculty tutor, for all the intensive care trainees. And it's our responsibility to hear what they have to say, amongst many things, and to ensure that the curriculum is delivered. So it sounds like in the future you should be that person who knows there is a curriculum and there's a gap because it's not being delivered, and put systems in place to ensure that every trainee gets the whether they take it or not is their decision. Remember, you can't spoon feed an adult. You're all adults. You need to make your own effort and try, but to put systems in place whereby they can have those learning opportunities. Okay? Yes?
Is it working?
Yes, it's working.
Yeah. I just want to clarify the fact that if I understand your topic well, we are talking about teamwork. And probably we are just a bit straying from the topic, as I can... the doctors here, they are, I think, sort of complaining about their system of training, which definitely has gaps. And I think at the moment we are not going into that discussion. What are the training gaps and what's their curriculum? We I think should be focusing on a teamwork. So a teamwork is say for example there's a patient who collapsed or a patient you are dealing with in the ER, and how this is what I think you are trying to focus on.
More than that.
Yeah.
It's bigger than that.
Yeah. Okay. So I think whatever teams you want to build up teams. So I just wanted to let these audience know that you are concentrating on the.
So I will actually turn that around and say, they are telling me things that are very, very specifically related to team building. We're not talking about teamwork specifically. We're talking about building an effective team. And part of building an effective team is building an effective team of supervisors and consultants and HODs who can facilitate a user-friendly and trainee-directed learning environment. So I will actually turn that around and say, we're going to talk about different aspects of team, hearing what the individuals, the bottom of the list, what their experiences are regarding teams is very crucial in this. So I actually wouldn't shut anyone down, and I would say we're talking about team building in every aspect. And yeah, sorry, you have the mic.
Carry on, continue.
That's it, that's fine.
नहीं, मैं तो ज़रा से बात करना चाहता हूँ ट्रेनीज़ के साथ on the behalf of CPSP because I am Dean Faculty of Anesthesia. क्या सब ने करिकुलम पढ़ा है कि है क्या? किस किसने पढ़ा है पूरा complete? Kindly raise your hand. जिन्होंने पूरा करिकुलम पढ़ा है. One.
I don't think. I don't want to. I'll tell you. I don't want to isolate people and target them and say who has read the curriculum or not.
दूसरी बात ये है कि रोटेशंस हैं करिकुलम में कितने केस करने हैं पूरा करने का बड़ा रोबस्ट करिकुलम है ठीक है हाँ ये ज़रूर है डेफिशिएंसी ट्रेनिंग में कुछ को भी अल्ट्रासाउंड नहीं है ठीक है उसका लर्निंग के लिए मेरी मशवरा है आप लोगों को नॉट मैं कोई जस्टिफाई नहीं कर रहा CPSP को मशवरा दे रहा हूँ कि काम कई जगहों पे नहीं है जस्ट गो टू YouTube सी वीडियोस क्या हो रही हैं क्या इक्विपमेंट है टू शुड बी फेमिलियर विद दोस्त फिर ऐसे सीख जाएंगे इंशाल्लाह हम भी स्टेज से गुजरे हैं अब सीख ही गए हम भी थैंक यू
Thank you. And we're talking what my juniors back there were talking about. I'm going to agree with you regarding a system to implement the curriculum. You may have read the curriculum, but you need to have access to abilities to be able to implement it and actually have opportunities. Now, of course, when it's a busy environment, and someone said earlier there's 2 supervisors supervising 15 theatres, you'd be surprised you can still make that a useful learning environment, okay? And that's for another discussion another time. So I think, yes. Yep, I think we can now, I would rather do a whole session just hearing from everyone. I am someone who I have not mentioned exams once. Exams do not make you a good doctor, okay? Exams never make you a good doctor. They will ensure that you have the basic required knowledge, which is important. You can't progress unless you have the knowledge. We have exams, everyone has exams, but we see exams as a hurdle that we need to pass, and we try and focus more on the actual ongoing continuous training. So you have to go through exams. There's no question there. There's no point. Yes, Anwar.
Sir, I have got 2 cards. The first one is a lamp, a little lamp that's upside down, and I'm trying to put goggles on it. And it has weak eyesight. That's my team currently. That's how I would say that. I mean, I'm working in a diverse environment.
Clearly.
And the second picture is actually of a rugby team, and the ball's really high, but they are all reaching up for it, and they are supporting each other. That's
Excellent.
where I vision it to be, inshallah.
Okay. So what's really nice is that we have a lot of people in here who are clearly going to be future leaders. And I think don't let that be beaten out of you. You need to maintain that passion, and when you receive that position of responsibility, that you make the environment even better, because medicine evolves, training evolves, knowledge evolves, We can't be stuck in the 1960s. We need to evolve. If you feel, as juniors right now, that your actual examination system could be better, for example, if you have essay questions is a thing of the past in many, many countries. Essay questions do not test your focused knowledge on important things. Maybe in the future, I don't know, you don't have essay questions anymore, do you? No, excellent. Essay questions were a thing until 10 years ago, I suspect. They still were. What you want to know is, can you manage someone with COPD? Can you manage an acute asthma exacerbation? Not to write everything you possibly know about asthma. You see what I mean? It makes no sense. Anyway, we're going to move on, and sadly we can't deal with everyone's comments, but I would love to hear it afterwards. So, and this is where I was trying to get to this point. Group versus a team. How many, let's not put hands up this time, let's just go through it. Sometimes you will have a group of individuals who just solely coordinate their own efforts and know about themselves. They have no relationship with anyone around them. That happens. That happens in hospitals. And then we have teams. I know there's levels of teams. Teams, as we discussed earlier, we know the definition. Now, here's another little exercise for all of you. Hands up, who feels that their current team that they work in, whether they're a house officer or a HOD, is a high-performing team? Hands up, please. High-performing team. Meaning you collaborate, you're effective, yes, okay, so there's one hand there, a hand there, okay, so a high-performing team. So we got quite a few people, okay, more. Who feels that they're working with a real team? Okay, okay. How about a potential team? Okay. And pseudo team? Okay. And there's obviously a working group. Now, let's start going through what these individuals are. Then I'm interested to hear what you feel. A working group is just a group of people, a bunch of people. They do not have mutual accountability. They don't care about each other. The only time they may actually talk to each other is to, they generally don't communicate with each other. They don't have collective outputs, all about me, 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 individual outputs. How can I make my name in this and walk over everyone else? Okay? It may be successful, it may not be, because each individual may be very good at what they do, but there's no collaboration. Then we go to the bottom of the graph. And in the bottom of the graph, that is the lowest performance. There's still no collaborative effort or benefit. They're all individuals. They may be good at what they do, but they're only out for themselves. We see this all the time. They feel they're part of a team, but they never ever act. Sometimes when they're talking to each other, they will talk to each other about what they've done, but that's as far as it goes. They do not have mutual accountability and a common purpose. Then we start to go up. Now, here we're starting to get into the zone. A potential team. So this was still at the bottom on the right. We're moving in the right direction. They're not yet collective accountability, but they're trying. They have more clarity. They know their goals. They kind of work, they have a common goal, common approach. They know what they're doing. They can communicate with each other. And they start to become more effective. And they start to produce meaningful results. Because we look at results as physicians. But I'll show you how we need to try and change the way we think. We need to change the old-fashioned way of thinking that result, 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 and actually process of getting to result. That how if you sort out a whole process, the results are always perfect. Okay? And can I have the mic, please? And there was a very interesting corporate person, so responsible for one of those massive corporate giants. asking, so when he moved to the health service, he said, I asked the directors and the chief executives whom they feel are the most important people in the hospital. And he goes, the response was unequivocally the patients. He said, that's where they're wrong. They're very wrong. Why should the CEO and the medical director be focused on the patient? That's our responsibility. That's the responsibility of the nurses, of the healthcare assistants, the physio. That's what we do. We go out of our way. We lose sleep. We are hungry to make sure the patient's well. He said their focus should be creating a comfortable, positive working environment where actually you and I can thrive. He said the results will happen anyway. If you just make it that little bit better, there'll be fewer absenteeism. You won't have to cover shifts with locum people who are not familiar with the environment and cost more money. You will actually save more money. So their focus needs to change. They need to make sure you have simple things like access to drinking water, snacks, things like that. So focus needs to change for those people. And the interesting thing is the same people who've described this in a lot of detail, they said the steepest performance gain comes between a potential team and a real team, which is what we should aim for. And you can be along that graph, you could be anywhere in between them as well. You don't have to be essentially in one place. And this one is quite impressive. This one, the team, they all have a realistic goal. They're not going to say we're all going to fly. No, we're going to achieve such and such and such. These are the skills we have. You have such skills. You have other skills. The house officer has interesting new skills. They are actually very good at IT. Let's use that. This person is very charismatic in the way they speak. Let's use that. Let's get everyone together, boost up their confidence, encourage them, make them feel that they are contributing positively to the team. That sounds good. And actually in the corporate environment, they will not allow teams to go out unless they have achieved this. They train and train and train them till they get to this level. And actually every member, they know how the other one functions. They know their strengths and weaknesses. If one is struggling, they will support them. That is a real team. Our team in our department is not a real team. We are still in between potential and real. And so we mentioned the impact on absenteeism and mortality. If you have a comfortable, non-hostile, non-threatening, non-bullying environment where a trainee doesn't get scared, where they voice their opinion, and the consultant, there's no harm in disagreeing with yours. If my registrar has said, I would do this, and I'll be like, well, that is a way of doing it, but I would do it this way. It's fine disagreeing with someone. Likewise, we sometimes have ward rounds where there are two consultants running, and there may be a disagreement. If there is justification for both, that's fine. Sometimes one will justify better than ours. Okay, that makes sense. And registrars are generally very much more up to date than us. They will be reading articles all the time. So I love it when we have a senior registrar who's coming towards the end of their training. I sometimes say, anything new in this area? He'll be like, well, actually, I read an article here. I'm like, okay, let's have a look at that article. Okay, let's do that. And it's quite nice because it saves me having to read that annoying journal and that article. This team only exists in the military. This is exclusively in the military. It does not exist outside the military. It never has. This is far too superior for us to ever get to. And even in the military, when they get to that, it takes weeks and weeks and weeks to get to that, sometimes months. They swiftly disperse them and get them to start training other teams. It doesn't happen. It doesn't. So I'm glad you felt that you work in a high-performing team. You're probably more, let's go back to that here, you're probably more, if we can get to a real team, we've got it. Your department will be the exemplary department in the entire region. People will hear about it because all of these young ones, they talk. And when they say, look, in this one, we have these bosses, this one grabs me and says, let's learn this procedure, come and let me teach you this, let's try and work on these gaps in your knowledge. Actually, you want some Viva practice, come along, I'll do that for you as well. The word travels, I promise you. Do you agree with that? Yes. Okay, so I'm interested, but I won't ask hands up, how many people still feel they're in a high-performing team after what we discussed? Now, this is where I was talking about results. Results. We always talk about results. In the actual functions of a team, look at how little importance we have in relation to results. If I ask you there, I need you to manage this patient, you're going to do it. You're going to try your best. If you work as a team where you trust each other, you know the one next to you is not going to throw you under the bus and go and take credit for what you've done, going to encourage you and support you. Not just consultants, we're talking about your peers, because this sort of behavior occurs amongst peers as well. And I can tell you, as a consultant, I get that sort of behavior from my juniors as well. Very, very different. We don't have as much power there as consultants, I can promise you that. It's a very different environment. If conflict is addressed, you're never going to like everyone. It's not possible. It's never possible. But if you can put your dislikes aside and work professionally together while you're at work and ultimately for the patient's best interest, and manage conflict. If there's conflict amongst yourself, rather than bottling it up and then going to this person, forming a little clique saying, oh, that person did that, ooh, what weirdo, ooh, ooh, ooh. And then it becomes a whole little, like, just a little drama that you don't need. Managing that, meaning all of you will be committed to that common purpose and to each other. People I don't get on with, sometimes I've said, I don't care if outside you don't even look twice at me. You don't say hi to me. I don't care. At work, I expect professionalism. That's it. I'll work with you, I'll support you, and I expect the same. Outside work, don't look twice at me. Never bothered me. Okay? You'll never get on with everyone. And we mentioned accountability. Once you address these 4 large, massive, important components of a team, you've built it, you've got it. And actually, the results will be perfect. They will be better. Because rather than feeling horrible and feeling PTSD when you come to work because you know such and such is bullying you, not just your boss. People get bullied from their peers. Consultants get bullied from consultants. I promise you. It happens all the time. Okay? I'm not having a go at the seniors. I'm saying sometimes younger people can be more toxic, right? Agreed? So, I need people to understand I'm not having a go at the bosses. I'm talking about teams where there may be one boss and there may be 8 juniors. The problems can arise amongst them and the boss is unaware. Yeah, so bear that in mind. Don't just start bashing your bosses. Look at yourselves and your peers. How well do I work with my person next to me who's at my same level? Okay? Results will get better. Now, we're going to watch a little video. Now, as I said, I'm not an expert actor. This was overacting for a purpose. Can you turn the lights off, please? And we need to see if the sound... I need to check the sound, please. And also, full exposure, we did this in one take because I was in a rush and I got someone to cut bits off, but it was all in one take. So get ready to feel incredibly cringy and uncomfortable. The acting is disgusting for a reason. Okay? No sound. I can probably use this mic, can't I? Hmm? You have a cable for yeah, okay, great, go for it. That'll be better.
Put it.
Yeah? I'm the consultant, just a moment. Excellent, thank you. All right, get ready to feel sick. How not to do things. Or to do it, we'll find out.
Right, so here's the pneumonia guide though. Have you got everything ready?
No. What? On your smartphone, just about aspects where you felt they were uncomfortable and could have been done better. Can we turn the lights off, please? Thank you.
Right, so here's the pneumonia guide though. Have you got everything ready?
No. What? I didn't know it was coming.
What? Okay.
What
So
do you need?
we need some. We're going to need to tube him. So some stuff to sedate him, and he's going to drop his pressures. So we'll need some NORAD or something.
Okay. Yeah, I'll try and find that.
I
Yeah.
thought you were getting it ready.
I definitely called down. I called down and someone said they'd sort it out.
Right. Thank you. Is this the pneumonia cap?
Yeah, yes, yeah.
Right, okay, all right. Yeah, yes. Just a moment. I'm the consultant. Just a moment. Right.
So we were just nurses. They haven't got anything ready, so they're going to
Well,
get some
that's just not good
bits.
enough. We've had an hour's notice knowing that the patient's coming. Alex, get ready to stick the tube in from the top, please. You, get ready to do the central line. You shouldn't be on here if you can't do a central line, okay? So just get on with it and just come on, just go on, get things together. You're going to put in an arterial line, please.
Again, I've done I've done one before.
You've done blood gases, haven't you?
Yeah.
Right, so you stick a cannula in there. Just get on with it. Come on, go get stuff together. And you get some drugs together so we can intubate. Go. Go. Right, where's our nurse?
Where is the arterial line stuff? Do you know where
Just find out from someone else. I don't know these things. Right, can you get some drugs together? So get some infusion for noradrenaline.
Noradrenaline, please. It's stuck for a station, so I'm just going to get this.
Yeah, go. Come on, hurry up then. Propofol and alfentanil. How hard is that? Yeah, we're going to put you off to sleep. We're going to put you off to sleep.
I've got the checklist ready. Should we run through
No,
it?
we don't have time for that rubbish. Let's go with it.
Is everyone ready? I've got the drugs.
Let's get on with it.
Yeah, just
Well, where's the nurse? Where's the nurse? Right, I said to get scrubbed up. Well, go ask someone else. Why? I don't know where all this nonsense is. Just get on with it. You guys, how long have you been on ICU? You've been long enough. You should know where things are. 3 months. Well, that's just a bit pathetic. Come on.
I'm ready.
What's wrong?
I've got the outline stuff.
You're going to sleep. You're going to sleep. You've got bad pneumonia. You're going to sleep. You're going to, yeah, come on, get on with it. Come on, don't look at me, just get on with it.
I've already really done one before.
Yeah, just feel for a pulse and put the needle in it, it's not that hard.
Get your arm.
Straighten your arm.
Right.
Just put your arm flat.
Get on with it.
Dr. Abbey, why is my staff nurse coming to me really upset because of the way you've been treated?
Well, the patient's dying and I need someone who's competent.
Dying?
I need someone who's competent. This is not the time for this. Get someone who knows what they're doing.
I'm going to the doctor.
Yeah, go for it. Thank you very much. Don't have time for that. Come on. Right. That's not how you pre-oxygenate, is it? Come on. Go behind him. Do it properly, guys.
Just some oxygen.
Right, are we ready then?
Well, get on with it. What are you doing?
I can't feel a pulse.
You can't feel a pulse. Well, he's obviously alive. Oh, for God's sake, just move out of the way. I'll do it myself.
Sorry.
Okay, lights on, please. How to do it right? Hopefully not. Okay, so as I said, terrible acting, uncomfortable, but it was one take in my defense, okay? and I don't work like that, just in case someone was wondering, although I played the role quite well. So, how many people here, and everyone look forward, I don't want anyone to judge anyone, how many have experienced an environment similar to that? Wow. Okay. And Dr. Sajjad will know this happens there as well. We have this. I'm not picking on Pakistan. I can tell you, Pakistan is so dear to me. I love it. I love coming here. And when Mujahid texted me saying, do you think you'll be available? Only giving me 3-week notice. Yes, I'm going to keep saying that. I thought to myself, do you know what? This will be an excuse to go back, meet the people who I met, and actually have some great food and meet more inspiring people. So I am not knocking Pakistan, ever. In fact, I will always be defending Pakistan when people over there will criticize. So don't forget that, okay? And I want all of you to remember and be proud of where you are. Not takabbur proud, but proud of where you are. You have got every possible facility available here, and you've got more interesting patients. You can make your units and your departments exemplary just by listening to each other as peers and trying to tackle things like that. When I have seen behavior like that, I have tackled it there and then, and it's very uncomfortable for me when I am tackling a peer, not physically. It's very difficult, but we do it. Sometimes at that time it's not the right moment, so I will take the trainees aside later, and they're all in tears, and I will provide them with support and other areas of support, psychological support, which is available in the hospital, occupational health. And actually occupational health, people who have worked in the UK, they know they're there actually for psychological support. It's not just taking bloods from us. There are designated people available there for us, so why not use them? So now let's talk a little bit about that video. From the beginning, start telling me about aspects of it that you felt were uncomfortable and wrong from the very beginning. The patient is brought in and the registrar is standing there saying what? What did she say? This is the pneumonia guy. Yeah? I have very close friends that are orthopedic surgeons. We have a great time together. How many orthopedic surgeons said, where's the knee? Where is the hip? Where is the shoulder? They don't put names to it, do they? Yep. The pneumonia guy. That pneumonia guy is awake and he can hear everything. How do you think he felt? This may be the last few moments of his life. Put yourself in that position. Put your own family in that position. That may be the last moments of his time. I've actually stopped telling patients that your mortality is high, you're going to die, before I tube them when I know that's exactly what's going to happen. I just say, I'm going to take good care of you. Don't worry. We're all here to look after you. We're going to take good care of you. The nurse is going to be with you 24 hours a day. We're going to be available 24 hours a day. No expenses spared. You get everything you deserve. It's better to hear that. I'm not saying I'm great. Believe me, I'm saying, as I said, be proud of where you are from and who you are, and just use the Pakistaniness, which is exemplary in many ways, to just make your system better, because no one will deny that all of you are incredibly hardworking. Your exams are ruthless. They are evil. They're far too difficult. You know? So no one can deny that you are intelligent, dedicated people. Am I right? Do the consultants agree? Anyone who's passed your exams, I can't even dream about it. I'm not even going to try it. I think in earlier times when there was FCPS for medicine, the Royal College of Physicians actually came here. This when my father was teaching in KTH. They said that you guys are far too brutal. Yes, we approve this exam. If someone passes this, then they're doing well. So no one is saying you're not hardworking, you all are. So then what happened? So that's the starting point. The nurse, please don't forget your bedside nurses. We dictate plans, and in ICU it's a bit different. We implement plans as well, but the nurses carry those plans forward. Having them on your side makes your life so much easier. And it can make your life hell as well, if you don't. Yeah, there's a smile there, so here, and a smile and a nod. Yeah. Show them the respect they deserve. Did this doctor inform the nurse? No, it was a complete surprise. Okay? Then what happened? Then I rocked up, and I started shouting at everyone. Yep. I started telling everyone off. First training I said, put a central line in. He goes, I've not done one before. What was my response? Get on with it and do it. You should know how to do it. Right? Did he feel comfortable coming back to me and expressing his lack of ability? He would probably, olden days, would start doing it and put the needle somewhere in the neck and something would happen. Yep. This is not rubbish. This has happened in the past. It's happened in the past. The next one said, I've only done one I've not done an arterial line. I said, well, you should know it. It's not quite the same thing. There's obviously a different process to it. And I started shouting at him. I, in fact, humiliated both of them. Something else I hope everyone picked up on, when someone said, shall we go through the intubation checklist? Just full declaration, you all need to know, we have absolutely categorically mandated the out-of-theatre intubation checklist. Because theatre is a different environment. Your anaesthetic nurse, your ODP, they know your language. You just do that and it appears in your, because they know exactly what you need next. ICU nurses, not necessarily. Yep. ER, ED nurses, not necessarily. So having an intubation checklist reassures them that we have the right kit, but also that we have the right staff. And also if, for example, it's one of you in the back, the juniors, the one who's going to be managing the patient, whom is the next port of call in an emergency if you fail. You can never say you have intubated every patient first attempt and never failed. You've not done enough then. Knowing that, I'm not saying actively go in the esophagus, please avoid that. Know what your training gap is, but know that if you know the processes, know what to do if you're not in the right place, and know whom to call, and feel comfortable to come up to your more, it doesn't have to be consultants, can be your more senior registrars who've had more experience. Because generally, just to give me an idea, on an ICU, you'll have overnight, because that's where everything goes wrong overnight, yep? Patients become hypoxic, the nurses roll them and they become hypoxic, everything goes wrong at night. In fact, there is actually evidence to show that most cardiac arrests occur between 2 and 4 a.m. I don't know. Whom do you have overnight covering ICU? Is it SHOs, registrars, combination? Registrar level, okay. So, and I presume at the same time you will have another registrar in theatre, for example, covering theatre. Okay, so that's exactly like ours. And all it is for that person to be aware that if I'm struggling, I can call a friend next door. And just making them aware, saying, this one's a bit complex, I may need a second pair of hands. The second pair of hands may be just standing there just to provide that little support. They may not need to everything will go smoothly most of the times. But in that one occasion where it doesn't go smoothly, what happens to all of us? We know this happens. We get task focused. We're like, I need to get this tube in. Rather, I need to oxygenate. I need to get the tube in, and you go blind, you go deaf, you don't hear anyone. There's something we call graded assertiveness. This is when we're teaching and learning about human factors. You'll know exactly about that. So So let me give you an example. I'm trying to tube someone with a pneumonia on ICU. You know, this whole optimization as much as possible. The DAS guidelines or the anesthetic guidelines are that if you can't get the tube in, you wake them up and take it out. Yeah, that's the anesthetic rule. That doesn't apply to ICU. That needs to go in somehow. So you need to put in systems to make sure it goes in, because you can't wake them up. They're at death's door. They've got an awful pneumonia. Their SATs are awful. You don't have that option, which is why you need that extra backup. Even if it means calling up your consultant at home who's on call, not any consultant, saying, I suspect this may go down south. This is my plan. What do you think? Most of them will hear it out and say, okay, this is a human being at the other end. Maybe I'll go in and provide support. And sometimes I've gone in and just sat at the nursing station away, not even told the trainee that I'm there, just in case anything goes wrong. And just once I've had to go in and help, so that they know that. And I learned that from one of my consultants who I have a lot of respect and time for. I didn't know he was sat in the back for 2 hours between 2 and 4 in the morning while I was managing someone on the cardiothoracic ICU. It involved a lot of things. He needed a tube, then a central line and a VAS cath, and you put on renal replacement therapy. And he just stood back there and he said, you didn't need help, but I thought I'd just stay here just in case. He could have just as easily come and meddled with everything. Knowing that you can approach your seniors that way. Then what happened? So, intubation checklist. I said, we don't need that rubbish. I have heard this myself. I'm not talking about Pakistan. I have heard this myself. And I'm sure you have as well, yeah? Because I keep pointing at you because you've worked in our hospitals, yeah? And I'm sure many others have. Okay? Then what happened? So I didn't care about the intubation checklist. I was telling off the person at the top. I was just being a complete idiot. Yeah, that's the honest fact. You agree? I was being a fool. Just disgusting. Then the nurse came and I humiliated the nurse, telling him you should have been ready. How do you think we could have handled that better? Anyone? So I'll tell you what I normally do. Because sometimes, and anyone who works on ICU knows that sometimes we don't have time to prepare the whole bed. If they're in ED, that's a bit more useful because ED has a bit of a critical care type environment, so you can put the line in, start noradrenaline, and wait for the bed to be ready. You can generally do that. But when it's from a ward, when you're in an unsafe environment, where doing anything more than just putting on oxygen can actually kill the patient because these don't have systems. I mean, I remember giving drugs before intubation checklist, giving drugs and getting the laryngoscope open and realizing there's no battery in the laryngoscope. And I had to get someone to hold a torch from one end, and that was a bit of a nightmare. And worst of all, I was in a ward that was so far away from everything, some of the drugs were expired. So I'm telling you, again, I'm not knocking Pakistan. I'm trying to elevate all of you. I'm telling you these problems exist everywhere in the developed world, so to speak. Sorry? I'm sure you would be. I'm sure you would be. Sorry? Yeah. I know. But that's see, this is interesting. This is why I whenever I go back, I usually... Excellent. So you have that in place. This is why whenever I go back, I sort of present what I've done here and show them what we have here. And they're like, wow, that's Pakistan. I'm like, what did you think it was? I said, you think about the kit, we have it. The problem is, and we have to be honest about it, is that some places, some people don't know how to use the equipment properly. They may be consultants, they may be junior, because they've not been trained. And sometimes people don't want to admit they don't know how to use something. Is that a fair comment? If we can just improve that bit, all of us, as juniors as well as seniors, we may get that a little bit better. So use your intubation checklist. It's there to protect you, and it's there to save the patient. Then the senior nurse came in. Now what I normally do when I don't have time, and we all do that in our departments, and I'm sure you do the same, I normally rush around to ICU or phone ICU and say, I'm bringing them around. I know you're not ready. It doesn't matter. We just need them in a safer environment. I'll bring them around while we are putting in lines and putting them on oxygen and doing various things. You can get the ventilator ready. In an ideal world, you rock a patient up onto ICU, they have a line trolley ready, they have a tubing trolley ready, they have the ventilator primed and ready. It's not always ideal, yeah? And no one can claim it's always ideal. So that little bit of communication, if I had done that with that junior nurse would have gone up to their charge nurse or sister and said, this is coming around, come and help me, because they now feel part of the team. I have communicated. We used that term so many times earlier. Communication is our biggest weakness. The nurse feels, I'm a junior nurse, but this person's communicated what he or she needs with me. I'm going to communicate that with my charge nurse to have backup, and we're going to make it happen for this doctor, these doctors, and for the patient. Is that a fair comment? Due to time, I'm not getting so many people involved, because this is normally like a 1.5 to 2 hour session where people talk with a break in the middle. Then when the other nurse came in and started shouting at me for being a bully, what happened? Oh yeah, I mean, it was a standoff. If we had weapons, we would have hurt each other. But what did I say worse than that? I said, the patient is dying. Yeah? That patient, how did that patient feel? No one told me I'm dying. And from the very start, what was I telling the patient? Shush, shush, shush. We're putting you off to sleep. Did that patient have any confidence in me as the team leader, or in any member of my team, because I humiliated every single one of them and made him believe that none of them are capable at doing anything? How did that patient feel? Devastated. Okay? So, we're not going to show you the second video, because the second video is essentially exactly the same scenario and same people. Identical scenario, done better. Patient rushed in, rather than saying, this is the pneumonia guy, this is Mr. So-and-so, he's got a bad pneumonia, we need to get him on the ventilator. Someone is there reassuring the patient, don't forget, these are people, they are people, and when they talk to us in follow-up clinic, I mean, the stories they tell us is terrifying. At the initial stage, during their stay, it's just terrifying. You think, what did they go through? It's not surprising that they actually have PTSD, a lot of them, which Dr. Habibullah spoke to us about. Reassure them. And then following that, the nurse said, I'm not ready. And instead of being a complete idiot, I said, I'm sorry about that, but the reason for bringing him early was because we weren't in a safe environment. Don't worry, we need such, such, and such. Get the charge nurse to come and assist you, and we will start just optimizing him as much as possible. Do you think that nurse had a little bit more confidence in me? It's a longer video, it's about 11 minutes, so I'm not going to bother showing you. Then that trainee said, I've not done a central line. So instead of calling him a complete idiot and telling him you shouldn't be here, I said, well, okay, Becky, you are a senior registrar. We will get the patient on the ventilator. If they are stable, then why don't you use this as a training opportunity? Because I am all for training at 24 hours a day. And you supervise Alex putting in that central line. That would be useful. But I said, if, however, the patient's crashing, then she will take over. He goes, of course. Do you think that would be a little bit nicer? I can promise you, and again, I'm not saying I'm good. I'm not trying to praise myself in any way, but I love looking after my trainees. I remember being that trainee who was bullied on so many occasions. And I hated it. And I felt scared going to work sometimes. It just was not nice. And I'm not, again, not talking about Pakistan. Yeah. As a medical student, I remember being terrified going to some placements because of the bullying and the harassment. This happens everywhere. And I know colleagues who have experienced the same. So I said, I'm always going to try and look after my trainees. And even at 2 in the morning, when there's a training opportunity, oh, there's a chest drain. Have you done one? No? Okay, fine. Let's talk. I'm awake anyway. I'm not going to go to sleep now when I go home. Might as well learn. If that sort of environment is created, like in that scenario, maybe there'll be much more buy-in. So following that, of course, the nurse and so on, and then we went through the intubation checklist in quite a lot of, we made sure we go through it. And that concept that I hear from some people, again, not here, that, oh, there's no time for this rubbish. I said that on purpose because that's from what we heard. There's almost always time for it. There's almost always 3 to 4 minutes to do the intubation checklist, just to make sure you've got everything you need. Okay? So, the purpose of this, once again, is not to bash any of the consultants here. As I said, trainees need to learn a collaborative approach and a collaborative way of dealing with each other and having mutual accountability, and also supporting your consultants. I can tell you for sure, as consultants, they don't sleep much. There's one person responsible for all these patients. Support them. Don't ignore. Don't say, "Oh, they're the bosses, so they have everything and they're lucky." No, we struggle as well. A lot of times, I have been, especially during COVID, I have been in tears on the way home, thinking, "What the hell is happening?" So please support your consultants as well. You'll go very far. So I think we'll just. Reflections, we spoke about it. I think we all appreciate the importance of these aspects, and I've tried to illustrate it. And we're all friends over there, so we were not fighting. We did it together, but it was in one take. And for one take, it's not that bad. It could have been worse. Yeah. And we spoke about pre-briefing as well, how pre-briefing is very powerful. Because now we did pre-brief in that one. And I found out that these people do not know how to do that procedure. So I gave them another task, but said, if opportunity arises, we'll teach it to you. Okay? Any questions on that note? Thank you. Well, thank you very much for your attention. It's been... I love the engagement. Apologies that we couldn't engage more, but time is a limiting factor. So thank you for all your attention, and thank you for the heads of departments and the consultants for being patient. And again, I want to make sure no one feels offended. I was not attacking anyone. I am giving examples from what I have seen personally outside Pakistan, and be proud of where you're from. Thank you very much. Assalamu alaikum wa rahmatullah. Can we just pass the cards forward and collect them, please? Thank you.
Okay. Thank you, Dr. Tahir. You have been delivering the talks, the presentations, the speeches for the past 1 week with the same enthusiasm, with the same zeal and zest. And I know You need more time, but we are very limited of it. And with this, we come to the conclusion of our scientific program. I will not call it the conclusion of our Congress, because there is a very big gathering coming ahead at 8 o'clock, inshallah. A few announcements. First of all, I would request Dr. Shahab Naqvi to please come up on stage and distribute the certificate to our moderators who have worked so hard to make the scientific session successful. Dr. Shahab Naqvi, please. Ji. Sir. Dr. Saima Askar. Aisha Mehraj. Sara Rabbani. Dr. Laila Habib. Dr. Sara Rahim. Dr. Shahriyar. Dr. Musaddiq. Okay, and last but not the least, Dr. Aizaz himself. Thank you very much, sir. And now I would request Dr. Kashif Anwar, President PSA-KP, to please come up on stage. Before delivering the closing remarks, I would request you to please confer upon the prizes, the cash prize to the winners of poster presentation. Okay, brace yourselves for the cash prize of rupees 10,000. The third position goes to Dr. Azmina Azam, Department of Anesthesia and Critical Care, Jinnah Hospital, Lahore. Okay, I have brought the cash with me, but let me make sure which envelope contains which prize. Okay, this one, hit here. Please, please. Third position. Sir, unko de. Okay, for a cash prize of rupees 15,000, Dr. Azha Maqbool. Sir. Okay, and for rupees 25,000 Sikka Raijul Waqt, the first position goes to, from Rahman Medical Institute, Dr. Muhammad Shahid. Okay, the closing remarks, vote of thanks by none other than Dr. Kashif Anwar.
Bismillah ar-Rahman ar-Rahim. This is, as Abid said, this is not the closing. We are going to have a gala night. So I hope I'll see you everybody there. But I thank everybody. Everybody means everybody, consultants, not consultants, everybody who have participated in this event and made this event a great success. People from far and near came to join us in Peshawar, which was a great privilege to the whole PSA-KP for supporting us and helping us in hosting this event. I hope we will continue this success story, and hopefully this event is going to be held annually in KPK. Again, in the end, if there was any deficiency, we apologize for that, and we will appreciate any criticism, anything from the participating people who came here, and we will take him as a plus point for us, because we are still in a stage where we are evolving. We haven't evolved completely, because this is only the third time since 1947 that anesthesia conference has been held in Peshawar. So again, in the end, all seniors and juniors for coming and helping us in this event. I congratulate my organizing committee, Maqsood, who's here, and I would like to give him a round of applause because he hosted and helped us in planning all this event. And the pharmaceutical companies who supported us, they also need appreciation, because the time was very short. This whole thing was organized within less than 3 months, and their support is very generous support from them. So thank you very much for coming and joining us, and God bless you all, and hopefully you will have, inshallah, a safe journey back home. Thank you very much. God bless you all.
So Dr. Kashifan, it was so nice of you. So we conclude the session with 3 cheers for anesthesia. Hip hip. Hip hip. Okay, Pakistan Paindabad. Okay, the dinner is supposed to be started at 8 p.m. sharp. You are supposed to be there at 7.